Good morning, everyone. Welcome to the Tuesday, March 11th Human Services Committee public hearing. Before we kick it off, any remarks from a good co-chair?
We have a lot of people to hear from today, so I don't want to take up any of the committee's time.
And how about my ranking member, Representative Case?
Let's get going.
All right. First up, we have our state treasurer, Eric Russell, joining us via Zoom.
Morning, Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, and members of the Human Services Committee. Thank you for raising Senate Bill 1476 concerning the ABLE Act and for the opportunity to testify in support of its passage today. I want to thank this committee for its longstanding commitment to people with disabilities through its support of ABLE-CT. As you know, the Office of the Treasurer administers ABLE-CT, Connecticut's federally qualified program that allows people with disabilities to accumulate savings that can be used to help them with their disabilities without losing their eligibility for federal or state benefits such as Medicaid or supplemental security income. ABLE-CT accounts are invested and managed through the National ABLE Alliance, which is a coalition of 19 states, including Connecticut. And this coalition allows us to have strength in numbers by increasing the overall amount of money available to invest on behalf of account owners. This bill updates the ABLE-CT statute to align with recent changes in federal law and to ensure future changes to federal law are automatically incorporated by reference. First, it increases the age of diagnosis, which is the determinant for eligibility for an ABLE account. It increases that age from 26 to 46, effective January 1st of 2026. The change is expected to significantly increase the pool of eligible beneficiaries, including an estimated 1 million military veterans nationwide. So this change has been made to the federal law already, and we need to update the Connecticut ABLE statute to reflect that. And as I mentioned, the bill also provides that the future changes to the ABLE law at the federal level will automatically be incorporated at the state level. So we won't need to go through this exercise every time there is a change on the federal front. Additionally, the bill gives the treasurer the authority to cover account maintenance fees within available appropriations for individual ABLE-CT accounts. So while these fees might seem small, they do create a significant burden to ABLE account holders at times because the accounts are often not substantial. So a $30 or $50 annual fee on an account with just a few $100s in it can be frustrating for this constituency. Even with investment gains, they often see their balances go up and down. And so we want to be able to ease that burden on the program beneficiaries. And we expect that the total cost is estimated to be less than $50,000 per year. Finally, the bill requires that ABLE-CT accounts are disregarded for all means-tested programs, not just those currently listed in the statute. This year marks the 10th anniversary of the National ABLE Initiative, and Connecticut joined the program in 2020. It's been incredibly impactful, allowing members of the disabled community to make financially responsible decisions and accumulate more money to cover their future needs without worrying about exceeding the assets they are allowed to have under other programs. Prior to ABLE, saving for the future often meant someone living with disabilities would risk losing essential benefits like Medicaid. So by further safeguarding these protections and expanding them to people who became disabled later in life, including many wounded veterans, we can provide individuals with greater peace of mind as they save for critical expenses like housing and assistive technology and medical care. ABLE really is a pathway to independence and opportunity and security for our disabled citizens. And so we're working to expand the impact of ABLE-CT so as many people as possible can reap the benefits. And I thank you all for supporting the important enhancements reflected in this bill and for allowing me to testify today. And with that, happy to take any questions that the committee may have.
Thank you, Treasurer Russell, for your work on this important legislation. Representative Case. Senator Lesser, followed by Representative Case.
No, he can go first.
Okay, Representative Case.
Here we go. Hey, thank you, Mr. Russell, for coming forward. So with this ABLE account, what we are actually helping the IDD and disabled population. In previous years, most IDD population were forced to go out and do special needs trusts. But this allows people in the disability population to save. What are they actually able to spend this on down the line through you?
Sure. So thank you for the question. So it's pretty flexible. It's anything really that's related to living expenses or medical expenses. It's pretty broad. I would say that in addition to the benefits of the um, kind of savings without it jeopardizing programs, there's a tax deduction benefit, much like our 529 college savings programs, where up to $10,000 can be deducted as it's being contributed to these accounts. And they're getting the benefit of the fact that these monies are invested after they are put into the ABLE accounts as well.
So, and I think the key point of this, as you stated, it doesn't require the downspend in order for a disabled person to stay on state or federal benefits. And I think the downspend would be in Connecticut, the 1,600 level. And I think it's imperative that people who are able to, and that's why it's the ABLE Act, to save, because we do have more expenses on the personal level throughout our lives, whether you're disabled or you're not. So this is one way to move forward. I appreciate your office taking this on and allowing for those accounts to grow so that people can actually have a better way to fund their life. Thank you.
Thank you.
Senator Lesser.
Thank you, Madam Chair, and thank you, Mr. Treasurer. It's good to see you, and appreciate your support of ABLE, which is a fantastic program. Just understanding what this bill does, though, it does something that we're not doing a ton of these days, which is adopting by reference federal laws and regulations, which of course can change from time to time. Is there a specific change that we're anticipating? And, how do you, obviously at other times we may want to decouple. So how are you looking potential changes or is this just a general policy that will hopefully keep us more harmonized with the federal regs?
So great question. Thank you, Senator. So first, there is the change that is coming up on January 1st, as is outlined in the legislation, which is the expansion of eligibility from the age of 26 to 46. We are part of, as I mentioned, this National ABLE Alliance, and much of the work that's happening to move ABLE forward is really happening on this collaborative basis. And so there's generally really broad support as initiatives are moving forward on the federal level as well. The thought here was that putting something in statute so that some of these small tweaks and changes that may be made over time to the program wouldn't require us to come back to the legislature every time. Past the age adjustment, I don't know of any immediate anticipated changes to the program, but we wanted to be proactive and so that we're aligned with what's happening more broadly.
Great. Thank you very much.
Great. Thank you. Any other questions? All right. Seeing no hands, thank you so much for being with us today.
Thank you very much.
Next, we'll hear from Commissioner of the Department of Social Services, Andrea Barton-Reeves.
Good morning.
Good morning.
Good morning. Good morning. Chairs Lester and Gilchrist and ranking members Harding and Case and distinguished members of the Human Services Committee. I am Andrea Barton-Reeves, the Commissioner for the Department of Social Services, and I am pleased to be here today to offer some remarks on several of the bills on today's agenda. I'll note up front that two things, if you don't mind. We have a lot of bills. I will not be testifying on all of them today. I just want everybody to be relieved by that. I have a few that I just like to bring to your attention and not even in their entirety. So I will not have you here forever. And the second is that as I am testifying, there will be instances where I will raise our opposition or concern to a bill. And that might be because of fiscal policy or other concerns that we have, but that is not an indication that we are not open to having any further dialogue on any of the policy issues that are raised in the bills. We're happy to continue to have that conversation with you. So thank you. So I will start with Senate Bill 1482, an act concerning elderly nutrition. So the other thing I want to mention is I do have a few subject matter experts here with me if we have additional questions. Thank you. So as we know, this bill requires that DSS, in consultation with the Commissioner of Aging and Disabilities, maximize the use of federal SNAP or Supplemental Nutrition Assistance Program funds for nutritious meals for elderly persons. What we know now is that SNAP does support over 479,000 people, and of that number, 88,300 are over the age of 60. Right now, we do this under a waiver that's known as the Elderly Simplified Application Project, which we know internally as ESAP, and that allows us to increase participation among older adults who are low income, who are facing barriers to participation by allowing them to extend their benefit period. So to increase awareness of the SNAP program, there was legislation that was passed in October 2024, and we have been meeting with the Trade Association CAFCA of the community action agencies to find ways that we can expand SNAP. So as a result of that, there was more SNAP outreach last November, and we continue to have stakeholder meetings. Finally, the federal regulations already allow individuals age 60 plus to access prepared meals under SNAP through the Meals on Wheels program, which is also administered through our community action agencies. So that does allow for those who are age 60 and older to get Meals on Wheels, as well as what is known as communal dining facilities. And the United States Department of Agriculture's Food and Nutrition Services, which we colloquially refer to as FNS, is the only entity that can authorize retailers, including Meals on Wheels and communal dinings, to participate in the program. So at this stage, there are a number of programs in which we are trying to maximize the use of SNAP benefits, particularly for our older population. And so we believe that we are taking the appropriate measures, but certainly open to more discussion as to how we can better maximize these resources. Next, I'll go to Senate Bill 1475, again concerning food deserts and the SNAP program. This bill would require DSS to develop and implement a plan to participate in what's known as the Restaurant Meals Program, typically known as RMP. It is in fact a state option that some states have engaged in that serves members who are homeless and older adults 60 and above or disabled to use their SNAP benefits to purchase meals at participating restaurants. And each state can in fact set its own standard for that, but the restaurants have to agree to participate under certain conditions. And those include offering low-cost meals at a discount. Those meals have to cost less than what would normally be charged. Customers who don't use SNAP, and those meals have to be defined as meals that are ready. They're offered to certain customers, and they cannot charge a gratuity or a sales tax. We do estimate that there would be a significant lift with respect to implementing this program, but we're also finding, and I'll probably be testifying to that a little bit later in a different section, is that there is very little take up of this in other states. And where it is taken up, it's primarily in fast food restaurants, where SNAP benefits could be used. So currently, there are only 9 states that use the RMP program on a very limited basis. In Rhode Island, which is one that's really closest to us and probably the state that has the greatest comparison in terms of our geographic location and the number of people that live in the state, that they only have 8 Subway restaurants in 2 counties that are actually choosing to participate. And in New York, which we know is a different population, there's also fairly low take-up. That's about 104 restaurants, and 72 of those are considered fast food chains. There is a larger one. That one is in Arizona. You can see that in my written testimony. That has about 866, and 600 of those are fast food establishments. There are a number of steps that we'd have to take, which are outlined in the testimony, that we would have to do in order to be able to provide a restaurant meal program in the state. And we'd have to constantly monitor it. At this moment, the department is not set up to actually administer this program, but it does raise a very critical question. And that is, if we don't use the restaurant meal program, and this is the policy question that we'd really love to have a conversation with the committee, then how can we support those who want access to meals, who are SNAP recipients, particularly those that are unhoused, where access would really be very important. We have these discussions. I know sometimes it's hard for people to believe this, but we actually do have these policy discussions very seriously at DSS. And we were thinking, well, are there other ways that we could do this? But we don't want to make that decision or have that discussion unilaterally. So we appreciate the bill and actually would like to use it as an opportunity to continue to have more discussion about the ways that we can help people, particularly people who are unhoused, to get access to food on a regular basis. And so that is my testimony regarding that particular bill. Then I'd like to move to Senate Bill 1471, which is an act concerning a pilot program to provide community-based memory care program. We would very much like to work with the committee to build a pilot program. The challenge with the statute as it's written is that we cannot have a targeted catchment area under Medicaid. We can have sometimes targeted catchment areas and even targeted populations that we serve under a waiver, but we can't do it under the auspices of the program itself. That's prohibited. So, however, we know that the need for low-cost housing and affordable housing for elders is very important. So what we'd like to do is if the committee is amenable, we'd like to continue to have some conversation so that we could figure out a way that we could do this that might include ways in which Medicaid could support it. But as it's currently drafted, we couldn't do that because of what I just mentioned, but we would love to have more discussion about that and perhaps also bring in our partners from the Department of Housing as well. Next, I will go to Senate Bill 11, which we know is a very significant bill, and I'm only going to highlight certain parts of that because you do have my full testimony in front of you. I'd like to speak specifically to Section 7, if you don't mind, and that is the section that requires nursing home facilities to spend at least 80% of their Medicaid, Medicare, and all other forms of patient revenue on direct care costs. There are some challenges that we'd like to raise with respect to this bill. The first is that in 2022, thank you to the legislature, we were able, with your support, to incorporate what we call an acuity-based system. So this really does allow us to recognize the importance of having a continuity of care, aligning the Medicaid payments with the acuity of a facility's particular residents, and providing what we call value-based payment approaches to increase care. The challenge that we're having with this statute as it's currently written is that care in Medicaid for nursing homes falls into 4 categories. They are direct, they are indirect, they're capital and administrative, 5, and property or fair rent. In order for us to redirect all of those resources primarily to patient care, that would then require several things. One of which is that we would have to have every nursing home and long-term care facility actually segregate those dollars so that we could track them dollar by dollar. And then it would deprive them of the flexibility that they need to use the Medicaid dollars in the areas where it's needed to maintain the facility, to pay staff, to all of the things that they need to do to create a more holistic, healthy area and facility for where elders can stay. So if we devoted 80% of the Medicaid costs toward direct care, then that would only leave 20% for the other things like the dietary staff, food, laundry, resident supplies, all of the things that really contribute to the overall health, safety, and well-being, including paying taxes and rent and the like in nursing homes. So what we were suggesting here is that as it's currently written, and forgive us if we're being presumptuous, we think that the idea is that we want to make sure that there's greater accountability as to how Medicaid dollars are being used in the nursing homes, and there are other ways that we can account for that. We do have nursing homes, and I do have our nursing home finance expert with me today, so she may be able to answer some questions about that, where they do provide cost reports and we can see what it is that they are paying. So perhaps maybe digging into that a little more deeply might provide some more transparency and clarity. Next is Section 8 that I'd like to speak to that requires the establishment of a new definition of emergency medical condition. We do appreciate having this section in the proposed statute, but there are some parts of it that don't align with federal law, and that limits our ability to obtain Medicaid reimbursement for some of the things that we do. So there is right now a definition of what is considered a limited medical emergency, and that is specifically an emergency that occurs that requires treatment that is required after what is, quote, the sudden onset of a medical condition manifesting itself by acute symptoms of sufficient severity, including severe pain. So I'm reading directly from the statute. And there are other criteria there, including that it places the patient's health in jeopardy, it causes a serious impairment to their bodily functions, or to serious dysfunction of any bodily organ. There are a wide range of conditions and diagnoses that are already covered under emergency Medicaid because it's required for us to do that under the statute and not by a specific diagnosis. So our position here is that as the Medicaid rules already provide for, there is significant coverage that's provided as emergency Medicaid coverage is already defined within the Medicaid statute. And as we see there, we have not been able to find where those are not covered. So we continue to like to talk with the committee about how that might work, but we believe that the coverage there is adequate. Moving on to section 9 of the bill, this requires DSS to phase out the asset limits for Husky C over a 5-year period. The challenge with this particular section of the bill, and I know that this has been a discussion with the committee before, are the costs that are projected in order to be able to do that, which are not included in the governor's budget. You can see some of them in our testimony. They include $20.5 million if the asset limit is increased from 1,600 to 10,000, and also if it's increased from 2,400 to 15,000 for married persons. And it does not include the related costs for long-term care or services. Next, I will move to the Drug Task Force. An act implementing, this is House Bill, 7192, an act implementing recommendations of the bipartisan task force. We are in full support of this, and we appreciate the opportunity to have more discussion regarding the work that has been done by the bipartisan drug task force. And we also look forward to having more conversation as to the ways in which we can have more affordable drugs and access to drugs in the state of Connecticut, and hope we can continue to participate in that process. I have 3 bills remaining that I will be testifying about, and this is the first of the 3. This is House Bill 7188, an act concerning homelessness and the CHESS program. This section of the bill requires the Department of Housing to prioritize housing vouchers, both state and federal, for recipients of what we know as the CHESS program, which stands for the Connecticut Housing Engagement and Support Services. There has been a comprehensive study done of the CHESS program, and the recommendation from that study was to sunset the CHESS program. And the reason for that is that there aren't adequate providers to administer the program. There are only a few. They are at capacity. And in addition to that, there are no vouchers for those who are currently on the wait list for CHESS, no housing vouchers. And even if more housing vouchers were to be provided, there aren't any providers that are available in order to be able to help people administer the program. So it would just create a very long wait list. So this is the conclusion that was drawn from a committee that included the Department of Housing, DPH, and DSS, and a number of other agencies that support people, DEMIS and other agencies that support people who were part of the CHESS program. So our recommendation, which was also in the CHESS report, is that the state sunset CHESS in its current form, and then move those who have housing vouchers to DEMIS, the Department of Mental Health and Addiction Services. And we'll continue to work with those departments to determine how we can provide more supports to those who have a housing voucher and are currently settled within the program, but there aren't any resources to provide more people any more support under CHESS as it's currently defined. Also, with respect to section 2, we're asking for a few revisions. While we are certainly open to more discussion and forums regarding services for those who are unhoused, we would like to see an oversight council that is ideally coordinated with other existing committees, particularly the Department of Housing's Interagency Council on Homelessness, which includes all of the providers that are currently providing services for those who are unhoused throughout the state of Connecticut. We find that when we have active and encouraging engagement with stakeholders, that we're able to build better policy under those circumstances. Next to last, I will speak to House Bill 7191, which is an act concerning Medicaid rate increases, planning, and sustainability. We really do appreciate what is being is provided here under this statute. But what we would like to ask the committee to do is to consider the fact that the rate study phases 1 and 2, as well as the Medicaid landscape analysis, provides the state with a roadmap that allows us to to increase rates based on the needs and the research that has been done in both of those rate studies. That is something that we are ultimately responsible for. We know that to work with the Office of Policy and Management and our stakeholders to determine, based on what the outcomes of the rate studies were, how we should be increasing rates and under what circumstances and on what time frame. So while we do know that Medicaid rate increases do have to happen, we're asking if we could use the rate studies that we've already invested in as a state as our guide to determine when and how and under what circumstances those Medicaid rate increases should occur. And finally, I will speak to Senate Bill 1251, not all of the sections again, moving specifically to sections 4 and 5, which ask for a repeal of the one-time domestic violence benefit established pursuant to Public Act 2178. The challenge here, and I know I use that phrase a lot, that we've asked for, the reason that we've asked for this at DSS is this, that it is a program whose intent is wonderful. It is to provide direct resources to those who are victims of domestic violence. But at DSS, we are not experts in domestic violence. It is an attestation program, and that means that a person simply has to say that they've been a victim and they have to sign an attestation, then they can get access to resources. What we've discovered, and this is somewhat anecdotal, and I've testified to this before, is that in some circumstances, we believe that perhaps victims who are already in their circumstances are being coerced by their victimizers to approach the department and receive these resources. And we're also receiving requests and applications from those who we don't believe the program was intended to support. So rather than continue to have this imperfect way in which we can administer the program, we approached the Connecticut Coalition Against Domestic Violence and asked, as the state subject matter experts and the umbrella organization over all domestic violence shelters and programs, if they would be willing to take over the administration of the program so that they can make sure that the resources go directly to those who are impacted by violence. We don't have to make that decision as an agency, and we can make sure that the dollars are going directly to those who are impacted. And so with that, we were asking if those resources could be transferred to CCADV. I'm trying to see if I said I was going to say anything else about anything in this section. I think the last section I was going to reference in Senate Bill 1251, because we have testified on many of these things before, so I wanted to be very cognizant of the committee's time. But section 13, I don't think is one we've spoken of before, and that is the one that speaks to the cost sharing under the state-funded home care program. This does change the percentage of money that would be paid by those who are engaging in state-funded home care program, but it caps it at $175 as a monthly cap. This does actually incur results, in a modest savings of $400,000 in FY26 and $500,000 in FY27. And I use that word modest, as compared to some of the other cost saving measures, but overall in this particular Senate bill, there are cost savings that are in support of the governor's budget. I did want to raise this one up because I know there has been some concern about getting access to those who are elderly, and care to those who are frail, to require nursing home care, but don't necessarily want to. I don't think any of us would want to be institutionalized. So it provides some flexibility. We know that the cost sharing has varied, and really the goal here is to make sure that the cost share is capped so that there's predictability in the costs that each resident and each person who accesses this care would have to pay over time. And that was primarily the reason for that particular change. So that is the end of the testimony of the bills that I've chosen to raise before you. I'm trying not to be repetitive of those things that we've spoken about before in previous bills. And so we are here along with my team to answer any questions that you may have. And thank you.
Thank you, Commissioner. And thank you for your extended testimony as well. I know we have quite a few bills on the agenda. I'll start and then turn it to my colleagues. Want to discuss House Bill 7188, an act concerning homelessness and the CHESS program.
Yes.
So it's my understanding that we're able to have the CHESS program under a 1915, is it 1915I? Is that the official name of that waiver?
I believe so.
So if we are to sunset this program, how does that impact that waiver? Does
Yeah.
the waiver go away?
The waiver essentially goes away, right? So when we sunset the program, we then let the federal government know that we've sunsetted the program. We have to give the reasons why. Essentially, they give us permission to sunset the program. They may ask for more documentation as to the reason why. And they may also ask, it really depends on what will happen to those who haven't yet been served under the program. And then we usually provide that information and then we sunset the waiver. Yes.
Okay, I have two concerns. I mean, one concern has to do with eliminating chess
Mhm.
for a program that's intended to impact those experiencing homelessness. The other is, can we use a 1915 waiver, or 1915 I waiver for other things such as home and community-based services?
I'm going to ask Bill to join me,
Okay.
so I want to make sure I give you the right answer. I think yes, we can use waivers for those purposes. But I want to be able to give you full answers to all the
Yep.
things that the waiver can do. Okay.
Just please state your name for the record. Hello.
Hi, Bill Halsey. I'm the Medicaid Director. I also have Joel Norwood, our Deputy Policy Person that wrote some of these as well. So could you just repeat the question, Rep. Gilchrist, please?
Yes, can a 1915 I waiver be used for home and community-based services?
Theoretically, yes.
Well, and in fact, Representative, the 1959 portion of the Connecticut Home Care Program for Elders is continuing. It's a separate 1959 benefit under the state plan that's currently approved, and that wouldn't be affected by sunsetting chess.
Okay, so do they fall under the same 1915 I waiver we have in the state, or each one is its own separate 1915 I waiver? So like we do one for the home and community based, and then we did one for chess, or do they fall under the same umbrella?
They all fall, I'm sorry, they all fall under the same umbrella. So when I said to you that we would sunset it, it would be for that specific portion. We would tell them we're no longer providing those services under that waiver.
Okay,
Okay.
that's
Mm.
helpful
right.
because my concern was in not Medicaid rate study 1 or 2, but in the other study, I'm forgetting
Mhm.
the name of that one, that was done,
The
wasn't
landscape analysis.
the landscape
Yes.
analysis,
Yeah,
home and community based, right, was an area
that's
of
right.
interest. And so I
That's
was
right.
fearing that we were potentially eliminating something that
No,
we
no,
could use
I'm
as a
sorry.
pathway. Okay,
I apologize. I live with this every single day. I really should be more precise. I apologize.
Nope.
Yes. Okay.
that's very
All right.
helpful. And so then with the study that was done on the chess program, I did read it. I forgot to bring it today, but did did you all look at what's being done in other states with regard to waivers and how different waivers are used to impact those experiencing homelessness? Or was it specific to the chess program here in Connecticut?
So the study was specific to the chess program here in Connecticut. So
Okay.
their states use different types of waivers. They have different kinds of partners that they use. They may partner. Washington State in particular has a partnership with hospitals as well as other community-based organizations to provide low-income housing and affordable housing for first responders. Oregon has something very similar. So every state has a different way in which they're approaching access to housing and providing more affordable housing. And every state has a different way in which they are dealing with the increasing numbers of people who are unhoused. Some states are struggling, like California, right? Because affordable housing just is not something that's available anymore. And we're hoping that Connecticut won't be in that same place. But as our current chess program is constructed, we don't have enough providers, and they're not willing to step up at this point because they're at capacity, serving all of the needs of the people that they serve. And having tried to reorganize this program in so many ways, especially without the vouchers, without the housing vouchers and the availability of the housing, that's really the key here. There's no way to make the program viable at this point.
I guess my fear is that if we sunset it entirely, would it be more difficult down the road to try and work toward a new 1915 I waiver, maybe based on the work being done in other states versus taking what we already have and altering it in some way based on lessons learned from other states? Because then, the need is there,
That's
right? Like the program,
That's right.
agreed. I read that it's not working the way it was intended.
Right.
But rather than completely scratch it, is there an opportunity here to try and learn from other states and then submit a plan amendment, maybe I'm using the wrong terms,
Yeah,
to
no,
the
no,
federal
it's gotta-
government,
right, right.
to change it.
So
somewhat.
yes, there is. And that's part of what the recommendation that we made to move those that have the housing vouchers to Demas. Because we also find that there's a significant intersection between the people who need the help and have the vouchers and those that are already actually being supported by Demas, which is why we recommended that those who have a voucher and have supports within agency already be moved to Demas. So it wouldn't be a complete sunsetting that everybody's already receiving supports, those supports go away, and then everybody else has to just kind of figure out what to do. That's not what we're doing at all. But that's the current construction of the program. With respect to other things that we can do, yes, we are very much looking into what else we can do, but we're doing that with the partnership of the Interagency Council on Homelessness and the DOH Commissioner, who's very much aware of the challenge that we're having with the CHESS program and is really working with us in ways that either she can provide housing, she's working on figuring out different ways we can get access to maybe some different vouchers, just really trying to brainstorm with us in ways that we can continue to have more options for those who are unhoused.
Thank you. I'm still uncomfortable with
I
the
understand.
sunset, but I appreciate I appreciate your feedback on section 2, and maybe there is a way, it would make more sense to coordinate with established entities here in the state. And it's my hope maybe we can have more of these conversations before we sunset to see if we can kind of move in a different direction. Moving to House Bill 7191, the Medicaid rate increases planning and sustainability. With all due respect, I hope you know that. I do feel like phase 1 and 2 have made it clear that we do need to increase rates
We do.
across the board. But what I'll focus on is you didn't speak to section 4,
Okay.
but in different meetings we've had with you all, there were conversations about the program being done in Maine. And so section 4 speaks to kind of an ongoing review, and that
Yes.
would fall under, we thought it would be best to use an established entity. So that would fall under the medical assistance program oversight. Just wondering if you do have any feedback. If you don't right now, it'd be great to continue that conversation with you
Yeah,
all.
I'd like to do both. I'd like to provide
Okay.
some feedback and also continue to have the conversation in MAPOC and any of the other places we have it. So the last time I believe we spoke about this, we talked about the model that Maine used, where they had a regular schedule of review of different provider types, so that at least there was a review that provider types could rely on, rather than kind of dealing with the process in which we've had it, which has not provided a consistent manner in which providers can at least have an assurance that their rates are being looked at. We are actively working on that plan. So I can tell you that in all honesty and transparency. When that plan is complete, we will have an opportunity to be able to share that with the committee, with MAPOC, and after it's undergone its review internally and with our partners at OPM, we will be able to share that plan. But we have actively worked on that plan.
Wonderful, thank you. And then my final, and then I'll turn it over to others, has to do with 1251, the governor's recommendations.
Yes.
I fully recognize this is not the appropriations committee, but since this is the implementing language for the governor's budget proposal, focused on section 4 and 5, which have to do with the shifting of the program for victims of domestic violence.
Yes.
I'm not opposed to that shifting. My concern really is the funding. And
Yes.
it does seem like the funding that's included in the governor's budget doesn't match the need you all have been seeing at the agency. And so I guess my question is, are you anticipating that there'd be a reduction in the number of victims seeking these services, or is it going to be capped?
No, so the challenge here, Representative, is that we were having some questions about the applications that we were receiving, because the budget was a maximum of 2 million. Like, that was the absolute max. So to see it double and to see the types of applications we're receiving, it just raised some concerns for us. And so we had to just really be honest with ourselves and say, the way that it's currently constructed, we think there might be some challenges with making sure that those who are applying and the way in which we're paying is actually a way that makes sure that the money goes directly to the victims. And I don't want to say anything negative about anybody who's applied. I don't want to make any disparaging comments at all, right? Because the need is significant. But given that we were looking at twice our spend on the budget, and as I mentioned before, we know anecdotally, and this is really only one or two instances where we've had individuals who come back and said, a person has asked me to apply, right? And they may still be in the same circumstance. It really made us think that in order to make the best use of the state's resources and to make sure that money goes directly to the people, that we needed to have someone who really had strong subject matter expertise in this space. That's really what was driving it more than anything.
Thank you. Thank
You're
you for that clarification. Senator Lesser?
Thank you, Madam Chair, and thank you, Commissioner, for your testimony. In no particular order, the question about the restaurant meals program, you mentioned Rhode Island's experience and listed Rhode Island as a state that we are particularly close to.
Right.
We're also close to this Commonwealth of Massachusetts. Did you happen to have opportunity to review Massachusetts's
I
program?
don't have that in front of me today. We may have, Senator, but it's not part of the testimony I have available. I'm happy to get you those numbers.
Yeah, so Massachusetts does have a restaurant meals program. They've specifically targeted it to provide some diversity in the food options. I believe they have 15 restaurant.
Okay.
Oh, I see you've got a deputy commissioner who's
He
popped up.
came without prompting. He said he has information for you, so.
I wish that happened to me when I had questions answered, but I don't want your job. I want to be very clear. So no, my understanding is that Massachusetts has 15 or so restaurants and food trucks participating in the program, and it's particularly focused on food that is particularly important to diverse communities. And you know, as we're working to provide a bevy of options, including for people who are may be housing insecure, may not have the ability to cook food because they don't have a kitchen. I'm just curious why you would take that option off the table.
So Senator, it's a great question. I don't know if we're taking it off the table. I think what I'm asking for is, can we work together to find other ways in which we can do this? I agree with you. And we actually had a very robust discussion about, well, what happens to people who are homeless, who can't go to, let's say, a farmer's market as an example, and buy fresh produce? Because if that produce needs to be cooked, then where exactly does that happen? So how can we create a balance where people can get access to food who are unhoused? We would really like to have some more time to be able to explore that, because it's a really critical question. And we want to be able to support everyone in our community, especially those who are unhoused and have really limited options as to how they can get the food. So I guess I would say, Senator, we're not taking it off the table, but I'd really like for us to be able to work together and explore more ways that we can do that. And that might very well be that we speak more to the people in Massachusetts. But if you don't mind, I'll ask Deputy Commissioner Hadley to talk some more about that.
Thank you. I think actually Senator Lesser had the numbers that I was going to provide, which is the number of folks who were participating.
I'm sorry, Deputy Commissioner, I know who you are. Most people here do,
Yes.
but could you just introduce yourself for the record?
Of course. Peter Hadler, Deputy Commissioner at DSS. And I just wanted to reinforce that you have the same numbers that I do regarding the Massachusetts program. They currently have about 15 participating entities, including at least one food truck as part of their restaurant meals program. The little piece of information that might be helpful as well is just to say that the average meals coming in at about $11 based on Massachusetts experience. And just to put it in context of the larger picture of what a SNAP benefit can actually bring on average, it's closer to $2 per meal is what the average benefit contribution is for SNAP.
Absolutely. If anybody's asking where you get more bang for the buck cooking in your own home or going out to eat at a restaurant, obviously you get more bang for the buck in your home if you have a home, but that's the challenge that we're up against. So that's why that's an important conversation. I know that Representative Gilchrist asked some questions about the chess program issue. I have some more questions.
Okay.
And you know, my concern is, look, we're at a point where for a variety of issues, we've seen an increase in homelessness in Connecticut. We are looking for policy options, and yet I see in the governor's budget and this proposal to sunset the chess program, moving away from that commitment. And so we're going to have even potentially fewer options for fighting homelessness in the state. And that's why, we're trying to put our heads together to see if there's a way to make the program work rather than take the option off of it.
Yeah.
With respect to not enough providers, we agree that that's an issue. The question is, can we increase the number of providers? Can we solve the voucher issue? Are those ways to get the program to work? Can we look at the eligibility criteria to see what we can do to make that work? When I look at, that's more of a rhetorical question than an
Okay.
actual question, because I think Representative Gilchrist already asked the question.
Your rhetorical questions too, because we have explored all of those options.
Yeah.
We have spoken to providers, who's asked them what we can do to create more capacity. We've asked them, if they can just provide, pre-housing supports and help us to look for places. And I won't speak with any authority for the housing community, but this is generally the feedback that we get. The numbers of people that require housing supports in the state continues to increase. Their capacity is limited based on what they can do. And affordable housing is also a challenge as well. So even if they find a place for someone, then that place has to be affordable and they have to be able to sign a lease. So we've had extensive conversations with ways that we felt that we could try to keep the program viable, Senator. And it was not our desire to come back and make a recommendation that it be sunsetted. We really did try to explore every other option. We can continue to do that. But I would say that, I think the providers were very honest with us about their capacity to continue, and getting new providers into the program wasn't something that we were successful in doing.
Well, I don't think you can bring in providers where your reimbursement rates are so much lower than even other Connecticut programs. And so by folding the program into Demas's existing supportive housing program, it raises a question: why not try to look to that program, which is successful, as a potential model, adopting their eligibility criteria, adopting their reimbursement to providers, so that you have a level playing field and you're not forcing providers to out of the program by making the reimbursement artificially low. The other thing that program offers is it's well funded and it's a successful program. But it doesn't have a federal match. So could we sit as an alternative to sunsetting the program? Could we bring all of the stakeholders together? Understand that the worst thing you could do right at this point is to break something that is working. But figure out a way to hold them harmless and find a way to, align these two programs in a way that could potentially bring in some state funding for a federal match that would eventually, if it could double the amount of money that we have available and serve more people rather than fewer people, as I understand your proposal would allow.
Yes, we can, Senator. And truthfully, we have had extensive discussions with Demas as to how we might explore that option. So we're going to continue to do that.
Okay, I think you've heard from the chairs of this committee that we would be interested in being part of that conversation if we could. And we also understand that there are a lot of stakeholders and the providers that provide these services to the community. And we would love to help convene them if we could. And also, sort of assuming in advance that there might be some concerns about, again, breaking something that's currently working, we would want to work with them to ensure that they're confident about things like reimbursement and how we can make sure that they would not be unable to meet their commitments to their clients as a result. With respect to the arbitration clause legislation, I was disappointed to see your testimony or your concerns about it. My understanding is that there are already some rules in federal law restricting the ability of healthcare providers to provide consumer arbitration clauses, but that there's not a full gamut of protections. Is the concern from the department basically that you don't want to be a regulator, that you're a payer and you don't want to have regulatory supervision? Is that the issue?
I would say that is one of our primary concerns, Senator. Yes, it is. And we, as you know, we do have pretty extensive authority as a payer, and we're asking for more under the forensic audits for us to be able to oversee what happens in long-term care facilities and facilities that receive Medicaid. And we've seen a few bills come up in this session that I think seem to reflect the committee's concern about the ways in which Medicaid dollars are used and the ways in which Medicaid organizations that receive Medicaid dollars are behaving and acting as it relates to their employees and their staff. So we're looking at it not just bill by bill, but also seeing the themes that it seem to be arising within the bills. And what we'd like to do is to understand the challenge that is being raised by this, the challenge that's attempting to be addressed by the bill, and maybe speak to you about other options that we might be able to offer with respect to that. As we read the bill, it appeared that arbitration, and we know that there are lots of concerns about arbitration in many venues, tends to take away, this is the perception, the right of the person who's being aggrieved, because they only have one area in which they can actually be heard. And other than that, then obviously, you know, there's always the courts. But in this instance, when it comes to the private provider, we do have some restrictions under Medicaid, which we've raised in our testimony, and that Medicaid providers have to follow the rules under the way in which the statutes are drafted now. So we were hoping for an opportunity to better understand what the challenges were that the statute was trying to get to, so that maybe we could talk about some alternative solutions.
Thank you. And I appreciate, and sort of an analogous issue is with the non-discrimination provision,
Yes.
where, you know, the concern is that previously non-discrimination protections were ensured by federal law through, I think, Section 1557 of the Affordable Care Act and
Mhm.
through other federal legislation. But, you know, given some recent changes on the federal level, you know, the thought would be to provide some level of protection on the state level to ensure that that patients are not being discriminated against in the provision of healthcare. That might be, that state level protections might be necessary at this point, just given some uncertainty about whether or not the federal government even has the capacity,
Yeah.
with given limited staffing now and significant layoffs and firings that have made the news, to even enforce existing federal law. So,
Understood.
given that, I know that there's some questions about the wording, but the department broadly support that goal of ensuring that patients in Connecticut in Medicaid funded services are not discriminated against?
Absolutely.
Okay, great.
Yes.
Obviously, it's no secret, we're frustrated. You know, we passed a law with the support of the governor 2 years ago regarding coverage of certain weight loss medications through the Medicaid program. That law has still not been implemented to our minds 2 years later. And so, you know, frustrated that the current language before us seeks to repeal the law in many respects rather than follow the law. You know, I guess the other part of that is that the department has also provided now a number of bulletins and now a state plan amendment to that concern the law,
Mhm.
but we as a legislature have a longstanding interest in ensuring that we have an understanding of what it is the department is doing. And that's why we have, you know, MAPOC, which of course is
Mhm.
mandated by federal law, but that we also have legislative committee review of major changes. So what we're also trying to do is just to require timely notification of us of
Mhm.
any pending SPAs, so that we have the ability to understand what it is the department is doing, so we can ask the right questions when we have questions about whether or not the law has been followed. So I would ask that you work with us on those. And then just lastly, with respect to the Medicaid rate increase, you know, the department's done a lot of work on this, and appreciate phase 1 and phase 2 studies. But it's time to implement those studies. And we feel very strongly that this is the year to get that done. And, you know, with respect, I know that your job in large part is to support the governor's budget, but the governor's budget does not provide enough support to the Medicaid program to see those studies implemented. So would ask that if we are able to leverage some more funds, that we're able to solve this problem that your own department has identified as a really critical problem for the viability of the Medicaid program. So hope you'll continue to work with us on that. And if you have specific questions about the methodology that we're using to look at that, you know, we're happy to, you know, sit down either an open session or in a more private setting to sort of figure that out. And that is all I have for the moment, but I'm excited to hear from others if there are any.
Wonderful. Thank you. Representative Case, followed by Representative Johnson.
Thank you, Madam Chair. 1 minute. Good afternoon.
Good morning. Or
Good afternoon. Come on.
Yes, afternoon.
There it is, 12 o'clock.
Okay.
So some of these things we've looked at in previous before you were in your position. So
Mhm.
looking back on SB 1475, and we looked at the Rhode Island with Subway and others pretty intensely for about 6 years. What we found was there wasn't a lot of appetite, no pun intended, but for people and businesses to take this on because, correct me if I'm wrong, the businesses have to take on the DSS program on their computer system and house it and be able to be audited on how things are sold through their store. Is that correct?
You're correct.
So there is a cost to these small businesses. We tried to put this out to some small sandwich shops to start off and things like that. We didn't get any bites on it. Is that your recollection on that?
Yeah, there was very little interest expressed around that. And I wasn't here at the time, but I can certainly figure out, I can get the answers as to why. So yes, that is true.
Because I think we looked at it on going to small convenience stores and things like that and the cost of putting the system in their store. And honestly, some came back, I believe what we heard about 6 years ago was they didn't want to have to be accountable to an audit
Correct.
because it costs them the money to have to go through that.
That's right.
And I think if we find those ways to change that, which I don't know if we can, because any state and federal dollars have to be audited. It's about the system that the stores have to put in order to accept this. Because there are grocery stores that take this, but they're susceptible to audits as
Yeah.
they do it also. Is that correct?
That's correct, right. And then FNS also requires us to audit those that take SNAP benefits. It's just part of the agreement that we enter with the feds.
I mean, I think it's a phenomenal idea to try to put this out to more places.
Mhm.
It's about the small businesses, whether they can take it on and do it.
That's correct.
I think that's where it has a stop. We can, if it goes through, we can try it again, but I think we'll get the same thing because we have less and less small businesses out there.
Right.
So Commissioner, we'll keep working and seeing what we can do for that, but that's been going on for 6 of the 13 years I've been here and pushing that hard. I just wanted to touch base too on SB 1251, which we talked about in length at some time not too long ago on the dollars for domestic violence. I think you're absolutely correct that you're not actually admitting, but you are, that the expertise is not with DSS. And after looking at this, you're moved to CCADV, which is actually an agency that deals with this day in and day out. I mean, we have Susan B. Anthony up where we are. I know you and I spoke about that. There are many agencies that do that. But if you don't have the subject matter expertise within DSS, that's your concern because you want to be able to make these dollars get to work the best they can
That's right.
with the correct agency doing that. It's no discredit to the people in your agency. It's just
No.
that something new that we put on
Yes,
and you're looking for the right facilitator of those dollars.
that is correct.
Okay.
That's
And
absolutely correct. And we take no offense. We're the ones that came to you and said, we think it'd be better.
and I applaud that because you came to us because we dumped this on you I want to say 2020, 2021 into your agency out of a bill that came to try to help people who are in a situation who had no financial backing because they couldn't get into their finances. And this was to try to help them secure their future of their living with a little bit of money to help them get by. Is that correct?
That's correct.
So I think it's applaudable to move it to an outside agency that does this on day in and day out. You're on Senate Bill 11, Section 7, the 80% direct care. While we all want to make sure that the 80% direct care, obviously we want the best care to go to anybody that's within a nursing home. I think our nursing homes are struggling right now.
Mm.
If we do the 80% direct care, you only have purview over the state paid 80%. Is that correct? You would not have any purview over private paid
No.
in
we have-
nursing homes.
That's right. We have no purview over private pay.
So that private pay would go directly probably to the other things when the 80% kicks in. Is that monies would be shifted?
Well, Well, I think that really is the question, actually, Representative, is then how would each nursing home facility or long-term care facility actually make these adjustments? They would have to segregate those dollars, which we know would be a significant administrative lift for them to do that. And for a number of nursing homes, particularly in both in the for-profit and the nonprofit sector, many of the patients are Medicaid patients. So that means, right, that 80% of the dollars would go to whatever would be defined as direct care. So we know that, which would actually then leave little money, even from commercial payers or even those that pay privately, to cover all of the rest of the expenses in the nursing home. That's the concern that we have. We're very much supportive of Medicaid dollars obviously being used in the ways in which they should, and that money should go to direct care. But through, we think, the acuity-based system that we've used and that we've implemented, that is very successful and is supported by both our for-profit and our nonprofit entities that in the nursing home and long-term care space, there is a way for them to use the resources that come to them in a manner that allows them to provide supports where it's needed. So for example, if one of the homes wanted to purchase a different kind of food, and we said, you couldn't use Medicaid dollars to do that. You have to use that for direct care. If they wanted to buy rent different kinds of linens, if they wanted to make other kinds of changes to the facility, they would only be limited to the dollars that they have that is within that 20%. But we are very realistic in the fact that care for those that live in skilled nursing facilities is more holistic. And I know I said this before. So we really want to be able to give the providers as much flexibility as they need and accountability as well, which we do through audits and the cost reports that they send us to make sure that the monies are being spent as they should be spent. Our concern is really the constraints that this would put on the long-term care facilities so that they may not have enough resources to care for the other things that are happening that are just as important in providing a good quality of care for people who are in the homes.
And I thank you for that because I get concerned a little bit when we try to direct and what they can do and what they can't do. And I think looking at it, and I know I've had discussions with Nicole, your person who handles a lot of this, and we have some nursing homes out there that their reimbursement rate, their rate's $218 a night or $220 a night. It goes up to $235 in the Northwest corner. That's $6,500 a year. That's nothing. I mean, I just had an aunt that passed away in a nursing home last week, and it was $15,000 private pay.
Yeah.
So it's half we pay at a state level. How do we maintain the level of service in these places if we're going to restrict how they do it? And everybody talks about it. We're concerned because these nursing homes are going out to private equity. Why are they going out to private equity? Because they're the ones who have the capital money to make these places a better place. You can't live on $218 a day. That does not cut it for what has to be done within that nursing home facility. I think we have to be careful how we look at this. Nobody wants to go to, but I think, and Nicole will tell you, I don't want to put her on the spot, but the reason why they want to look at private equity because then their rates will change because they're doing so much improvements to their facility that they're eligible for a higher rate of return because that private equity company came in and did quote unquote renovations. Does it make sense? I don't know, but better place, more money, less place, going to make them 80% to care. The place is going to go farther downhill. I think we have a slope we want to be careful of. We want the best place for the golden years of somebody to live it out. My philosophy is that best place is at home. The more we can do care at home, some people don't have that ability to do that because medical conditions change and we have to take a look at that. I don't have much more from you. I thought we'd have you up here for about 3 or 4 hours, but I want to thank you because I do, Senator Lesser is on the prescription drug, and I think they've done a great job trying to mitigate through some of the things that we have going on. Anytime you can get a group together like that to do positive things to help not only your agencies, but the constituents in Connecticut when it comes down to something that everybody needs. I think it's a positive, and you supporting that says a lot on that bill going forward. The homeless chest, we got a problem, and I think you hit it on the head. The chest part, we don't have the housing. We have the housing, but those landlords aren't giving up the housing. So the dollars aren't out there with the vouchers. But the number of people out there that are homeless these days a lot of seniors and a lot of veterans and others. I mean, I know one community I've been working with is 100 kids that are living homeless in their school district. To me, in the state of Connecticut, that's gross. We need to start working to better ourselves within Connecticut and making things so that people don't have to live in their cars or out in the streets. When it comes down to budget and finances, it shouldn't be about money. It should be about people. I think the housing commissioner and others have to come forward. We have to start, and I know there were some extensive housing meetings. My good representative next to me over here serves on housing, and they've done so much stuff to try to mitigate and get more housing. The problem is, and you hopefully agree with this, you could have housing, but you need wraparound services because some of these people don't know how to take care of themselves when they're in the housing.
That's correct.
They don't have the ability to take care of the place. So I don't know, I think the statistic is 56% lose their housing within a year because they didn't know how to take care of it. And that's sad.
Yeah.
So you need to have wraparound services to get people on their best foot. I mean, I was always taught going through college to dress for success. How you get out there during the day and you dress is how you're going to succeed for the day. So, I mean, we have a drop-in center in Torrington where people can stop and take a shower, do their laundry and get a haircut because we want to give those people a leg up to try to go out that day and better themselves. And I think that's something that a small community has done. And have we seen an uptick? Yeah, but we're having a problem getting places for people to sleep at night. And I just want to thank you for your testimony. I know there's a lot of stuff on here today. You have a huge feat ahead of you with your commission and all your people because there is so much stuff on your plate, whatever's coming down the pike, but we have to worry about Connecticut. We have to make sure Connecticut has the right things. And I call it, people before projects. Let's build and make the people better so that we can be better here. I thank you for coming forward and thank you, Mr. Chair.
Thank you, Representative.
Thank you, Representative. Are there questions or comments for the commission? Yes, Representative Johnson, all the way down there. On the far,
you, Mr.
on the
Chair.
extreme left of this room, from my perspective.
It is for you.
Well said. Thank you so much, Commissioner, for your hard work and for all the testimony you provided today. I have to echo the concerns about the chess program. I remember when I was going to some of the Medicaid programs nationally, and the state of Arizona was the first state to come out with chess. And then Chris McNamara, who was the Medicaid person back then, helped us get to chess. And I was absolutely thrilled that we were able to do that because I saw it as a way for us to take care of a lot of people who could be in the community but needed those wraparound services. So I'm going to be quite hesitant in terms of supporting any elimination of chess at this point, particularly since I don't think we've explored all the alternatives that we might be able to look at in terms of housing access. There are a number of places in our urban areas that have housing that, because it's historic, they've been limited in terms of their capacity to develop it because they have to meet all the standards. But I think that we should work with the State Department of Economic Development, the Department of Administrative Services, and take a look at whether or not we can look at those things. I have a bill in the Planning and Development Committee to coordinate these services with the COGS so that they can work with the new systems that we put together and stop these buildings from staying empty for 10, 20 years. I have a building that's empty for 50 years now in my community. And when we tried to do something with the State Historic Preservation Office, stopped it. So they're not concerned with the timeframes here, but we have timeframes for people's lives. And I hope that we're going to be able to work together and take a look at other ways to do that. But the wraparound services are crucial, and they're a way to get people into a better cost and a better life in terms of what the state can do for them, and also what the communities and the other agencies, not just putting everything on you, but I'd love to work as a group to try and find ways to utilize these empty places so that they could be put together with the kind of wraparound services, not to be left, but to give the people the chance to work on those. So I just wanted to say that, and I want to thank you again for your really thoughtful work that you're doing. Thank you, Mr. Chair.
Thank you, Representative. Almost called you commissioner. I'm need another cup of coffee. Other questions or comments from members of the committee? Seeing none, thank you for your
No,
testimony.
I think Representative Shake.
I apologize, Representative Shake. I did not see.
That's okay. Thank you so much, Mr. Chairman. It's good to see you, Commissioner. I appreciate the extent of the testimony, the written testimony that you had submitted. But I'd like to actually go over something that you didn't verbally share with us, but it is written. It's the House Bill 7189, an act concerning Medicaid cost savings.
We'll find it if you don't mind. It's in order. I'm looking.
No, it's okay.
Let's try this out.
I think it's page 25 of your
All
written.
right. Which would be incredibly helpful if my pages were actually numbered, so.
Oh.
I appreciate it. 7189. I don't think I have it, but I'm sorry, while I look for it, I will listen. I apologize. I don't want to hold.
Oh,
you
it's
up.
okay.
Okay. I have 7192. I don't think I have 7189 in my testimony. So let me see.
This is House Bill 7189, an act
Mhm.
concerning Medicaid cost savings.
Mhm.
It's the third to last page of what you had submitted
All
to
right,
us, if that's helpful.
That might help. Well, do you have that? Yeah, it's not among the pages that I have. Thank you, yeah. So, thank you. I was looking for a section that's not in here, which explains why I couldn't find it. All right, so thank you. I appreciate your time. All right, I do have it now.
Oh, absolutely.
Okay.
So the title of this bill versus the intention of the bill, and what you were able to write in your testimony is an initiative to study and learn more about medication administration and impacts delegation that would be impacted in nursing homes. So my question is around the requirements regarding nurse delegation of the medication and potential cost savings. Could you define for us the nurse that you are describing in this? Is it a registered nurse? Is it a licensed practicing nurse?
I'll do my best, and I may
Sure.
ask my Medicaid director to come back. So we're talking about the large category of nursing. It's starting with the registered nurse, the APRN, the LPN. So that's where that's the category of nurse that we're talking about.
Thank you. In regards to this particular bill, I am a registered nurse. So when there's legislation that comes up regarding expanding or trying to expand scope of what we can and cannot legally do, it piques my interest.
Sure.
And in the delegation of, and I acknowledge the struggles that long-term care facilities are currently going through, geriatric facilities, rehab facilities, around not having enough staff. And with the possibility of expanding the delegation responsibilities, do you know or have an idea of what legal implications would be applicable to the registered nurse if said staff unfortunately have a medication error or a near miss? Would the registered nurse whose license is at the top
Right.
be held responsible for any legal implications?
I don't know the exact answer to that, but
Okay.
I can find that out for you.
Thank you. I appreciate that in what you had submitted, that it would also include DPH to be included in the study. I have concerns that, in the I guess, original language of the bill, that it was just DSS and not DPH. I don't understand how we're in 2025, and that's not something that was originally considered. In the other testimony that had been submitted, written testimony from some of the organizations or companies or healthcare facilities, the majority of them are going back to the concern of nursing agencies to try and attract staff and the cost of that to said facilities, not the actual concern of being able to expand the delegation of medication administration. So if in fact this is something that does move forward, I absolutely agree that it should be DSS and DPH. And quite frankly, the CNA, the Connecticut Nurses Association, and other stakeholders as part of the conversation. Because in the scope of nursing for the state, I can't speak for every single nurse, but whether we're talking about long-term care facilities or rehab facilities or hospitals or other outpatient ambi facilities, nurses are, in my opinion, already expected to do far more than what our jobs are. And if there's any possibility of putting nurses in situations that would potentially really avert interest and then impact the whole process of what the state did well in trying to bolster education and recruitment for registered nurses here in the state. I could see this as being another deterrent where it's not something, it's not an environment that would be supportive of us in our practice. So I would just ask that you and our commissioner from DPH and others would extend the invitation or request the invitation to have more of nursing voices directly at the table as this impacts, because our priority is patient safety, number one. So we can't do our jobs unless we have the resources in order to do our jobs. Do you have any other comments on this particular bill that you would like to share that you would think would be helpful, or recommendations of how else to proceed?
I'd like to take back the recommendations that you've raised today and the concerns that you've raised and share them with the DPH commissioner. I think the intent here was to be able to have more flexibility and environments for med administration. But the concerns that you raise are very significant ones. So we will go back and think about how we can incorporate what you raised as a concern. I will tell you that I spent 10 years at HARP, which supports people with intellectual disability, with a few nurses and a lot of delegation, because there weren't as many nurses as you would like to have had in those in similar environments. And so the idea of med administration by individuals other than nurses is not unfamiliar, but some of the concerns that you've raised were always concerns. Is the person who's administering the medication, are they properly trained? Have they had their certifications updated? Are they, do they know about perhaps the side effects or the contraindications of different medications? Who's supervising them? Those are all the things that were actually a part of the discussion in drafting this particular legislation. But bringing that back, in addition to what you've raised as well, I think will allow us to have a more comprehensive and thoughtful approach to this particular bill. So I appreciate that.
Thank you. And then if you know the answer, then share. And if not, we can revisit it, or it could be an email. One of the leading causes of near misses or outcomes are medication errors, whether we're talking about hospitals and other healthcare facilities. Do you happen to know, with the delegation of medication administration that currently does exist in certain facilities here in the state, what the rate of medication errors currently are? Do we have any actual data?
I
that we could
don't.
point
I'm not
to?
sure if DPH might, but we can go back and ask. that.
Okay.
Yeah.
So medication errors or near misses. And then if there's a cause effect study for that, I'd be curious.
Okay.
Thank you.
Mhm.
Thank you, Representative. Representative Butler, who's joining us on Zoom, go right ahead.
Thank you, Madam Chair. And thank you, Commissioner, for coming before us and your testimony. Last week, you actually shared some information about federal waiver that was no longer available to us, which prompted me to actually request that if there's any other federal funding that is not, that is discontinued, that you prepare a report for us to let us know how that would impact the bills that we have before us today, and any of your departments that actually will lose federal funding, as we will have to shift our state funds around to actually propped up a lot of the departments or policies or consider the new bills before us. So I would just ask that you, as soon as you can put together something when you hear about federal funding that may be lost, and let us know so we could prepare as best we can, as soon as we can, to address those areas.
Yes, I can do that.
Thank you. And thank you, Madam Chair.
Thank you, Representative. Any other questions? Yep, Representative Case.
Thank you, Madam Chair, for the second time. And Rep. Butler brings up a good point, and I just want to say your team was good last week in bringing us what the possible picture would look like. Not everything that's coming forward, but I just want to say to Rep. Butler that the chairs and rankings have been brought into the table to try to make things look to see what might happen. So I want to thank you and your team for doing that. It hasn't been something that's gone out to everybody, but you're trying to keep us abreast of what is going on and what the potential is. So when it comes time where you want us to put that out all over, we will do that. But it's a fluid situation, and being brought in to be briefed on all that is helpful. We should be better at putting that off to our team members here. But you're being proactive on that. And I just want to say thank you, Madam Chair.
Thank you. And I echo that. Thank you so much. Thank you for your time and your testimony today.
Thank you.
We have passed the hour mark, which means we are now going to go between the public and our state officials. And so first up is Yvette Highsmith.
Good afternoon excuse me for a second. Thank you to Senator Lesser and Representative Gilchrist and the distinguished members of the Human Services Committee. I am Yvette Highsmith, Vice President of the Eastern Region at Community Health Center, Inc. And I'm speaking today in support of raised House Bill number 7191, an act concerning Medicaid rate increases, planning, and sustainability. Community Health Center, Inc. is the state's largest federally qualified health center, and we've been providing healthcare to generations of families in our state since 1972. Currently, we care for more than 110,000 patients at our locations throughout the state, and that includes brick and mortar primary care centers, shelters, and our robust network of school-based care locations. We're a critical component of the state's healthcare system, providing medical, dental, and behavioral health services for all ages in every corner of Connecticut, regardless of ability to pay. About 60% of our patients are Medicaid members. Now, for nearly 20 years, though, the state has failed to live up to its obligation to provide cost-based reimbursement for Medicaid medical visits. And the shortfall is significant. As CHC, we currently lose $110 on each of these visits. We are, in effect, subsidizing the care of Medicaid medical patients, diverting resources, securing grants and donor funds in order to compensate for this state-created deficit. And this was never how the system was designed to operate. The intent of the original legislation creating federally qualified health centers was for these monies to support the needs of uninsured and underinsured patients. With the potentially devastating funding cuts coming to Medicaid and the federal government, these losses are unsustainable. So we enthusiastically support House Bill 7191 in accordance with the recent rate study commissioned by the Department of Social Services. As we heard from the commissioner, this bill rights the wrongs of the past and puts FQHCs on the path to financial sustainability. It lays out a clear process and timeline by which DSS will review and rebase rates that better reflect the true cost of care and phased in over time so as not to unduly burden the state's finances. Without the clear and reasonable approach set forth in this House bill, Federally qualified health centers will be unable to fulfill their mandate of delivering quality care for all, keeping those most in need healthy and productive residents of our state. We're already seeing some cutbacks and layoffs that are happening at our health centers, and the future would require further reductions in order to access care if we stay on the current path. I urge your support for this important and timely legislation, and thank you for your consideration. Also happy to answer any questions.
Thank you so much. Thank you for your work and for your testimony. I don't
Thank
see any.
you.
Thank you. Have a great afternoon. Next, we'll hear from Commissioner Deirdre Gifford.
Good morning, good afternoon. Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case. I'm Deirdre Gifford, the Commissioner from the Office of Health Strategy. It's very nice to be back with the Human Services Committee. I have just brief testimony this morning on a few of the bills before you. First of all, beginning with Senate Bill 11 and House Bill 7192. Thank you for the opportunity to testify on these important bills that address prescription drug affordability. As we all know, prescription drug prices have increased substantially in the last decade. We report on this in our Healthcare Benchmark Initiative annual report. We know that those who struggle the most with rising prescription drug costs are those on multiple medications, those who are younger, those with lower incomes. And we've seen price increases of 15% per year on drugs which can amount to $590 per drug product. So a real challenge. The Office of Health Strategy benchmark report found that PMPM commercial per member per month commercial spending has gone up by as much as 14% per year. So we appreciate and support Senate Bill 11 and House Bill 7192, which both take important steps to address these prescription drug cost increases, including studying the feasibility of establishing Canadian drug importation, and also limiting price growth for generic and off-patent prescriptions. These initiatives align with proposals made by the governor in HB 6870, which would also limit price increases for generic and off-patent drugs to the annual rate of inflation and establish a pathway for safe Canadian prescription drug importation after an assessment by DCP. OHS had a look at the impact of the generic prescription drug increase proposal. We identified more than 400 generic prescription drugs that would have had their wholesale price limited by the governor's proposal. And we also looked at off-patent and biologics, and our initial estimates are that had the governor's and these proposals been in place, we would have seen reductions in wholesale costs by about $9 million per year. We also note that both bills allude to provisions in the Pharmaceutical Benefit Manager report that the legislature asked OHS to produce and that we transmitted to the committee and the Prescription Drug Task Force. Regarding Senate Bill 1477, an act concerning a covered Connecticut trust fund. OHS appreciates the intent of this legislation. As you know, Covered Connecticut was conceived to reduce further our state's uninsured rate and make coverage affordable. The program, as you know, offers no cost health insurance, dental insurance, and non-emergency medical transportation to qualifying individuals. With incomes between 138 and 175% of the federal poverty level. We're very proud that as of January, the program has now enrolled 42,000 individuals. Although the program is administered through DSS, OHS has had a role in the development, implementation, oversight, and doing outreach for Covered Connecticut. This bill would establish a trust fund with the purpose of promoting sustainability of the covered Connecticut program, and would require OHS in consultation with CID and DSS to write a strategic plan on how to use the funds. Unfortunately, the creation of a non-lapsing fund for dedicated purposes would further limit the state's ability and needed flexibility to implement other programs within available resources. It would also bind the hands of future administrations and legislatures to balance competing needs. Since the funds were not required, funds required were not included in the governor's budget, the agency does not support the bill as written. And finally, regarding Senate Bill 1480, an act concerning private equity and real estate investment trust, ownership of hospitals and nursing homes. We also appreciate the intent of this legislation, which seeks to limit new ownership interests by private equity or real estate investment trusts in hospitals or nursing home facilities that receive Husky Medicaid reimbursement for services. We strongly support the transparency and review of healthcare transactions and believe that these are important tools for addressing consolidation and financialization of healthcare. As you know, to address this rapidly shifting landscape in the healthcare industry, the governor has also proposed House Bill 6873, which would cast a wide net to ensure that the full spectrum of healthcare transactions receive review, transactions that currently do not, such as those involved with private equity and real estate investment trusts. The governor's bill would allow the Office of the Attorney General to place conditions on transactions that have been identified as having the potential to do harm. And it also gives the state regulatory oversight without an outright prohibition on any particular type of investment strategy or vehicle. OHS shares the committee's interest in further monitoring and, where appropriate, placing conditions on transactions that have the potential to cause financial instability and lower the quality of healthcare. And we look forward to working with the committee to explore how the governor's proposals and those of SB 1480 can be harmonized to address the challenges that SB 1480 aims to solve. That concludes my testimony. Thank you very much, and I'm happy to take any questions.
Wonderful. Thank you so much, Commissioner, for being here.
You're welcome.
I'd love to speak to House Bill 7192, the recommendations of the Bipartisan Drug Task Force, and in particular, the attempts in this legislation to get to transparency surrounding PBMs. Can you speak a little bit on what you've done through your agency and how this bill will strengthen those efforts, or maybe build on the work you've been doing?
Happy to. So first of all, I would start with the Healthcare Benchmark Initiative, which is charged with not only measuring and monitoring healthcare cost increases year over year, but also identifying the drivers of those increased costs. Consistently, since the benchmark program was put into place, what we've seen is that drug prices, particularly retail pharmacy, is a key driver of healthcare cost increases year over year. The all-payer claims database, which is housed at the Office of Health Strategy, has been used to look at some of the details underneath these increases in retail pharmacy prices. That's some of the data that I cited in my testimony has allowed us to look at specific drugs. But what we've learned through our hearings and dealing with stakeholders is that it's very challenging to understand drug price increases because of the interplay between all the different parts of that very, very complex financing system. And PBMs are a very significant part of that. You all charged us last year with doing a study of PBM practices. We transmitted that to you all a month or two ago. And several of the recommendations in these bills align with some of the recommendations that were highlighted in that study. In particular, the fiduciary duty of PBMs was highlighted in that study, and prohibiting spread pricing arrangements, And just in general, giving CID more ability to have transparency into the activities of PBMs.
Wonderful. Thank you very much. Senator Lesser.
Thank you so much, Madam Chair, and Commissioners, good to see you. And particularly be able to work with your office on the important issue of prescription drug price reform, and appreciate the governor's interest in this issue. And I'm hoping we can have a meeting of the minds, supporting, building on, as well on the bipartisan task force that we're hearing today. Just a question, when you spoke, and I apologize, I don't know if I have your written testimony, but obviously anxious to see it. But with respect to the $9 million savings for generic drugs that you referenced, is that a savings that we will be able to book? Can you just speak a little bit more to that and what that entails?
Yes, and you do have our written testimony. It was delivered with not enough time for you to probably read it before my appearance.
And just because I don't have it, doesn't mean that the committee doesn't have it.
Yeah, okay. So that 9 million was an estimate using our all-payer claims database, and it looked at drugs that we estimate would have increased over the inflation benchmark in the governor's bill that we had the ability to see in the APCD, and estimates what the savings would have been if that increase had been limited to the benchmark that's in the proposal. Where that savings happens, Senator, is at the level of the wholesale transaction. So when you ask, could we book it? It would be booked by reducing the prices in the whole chain of transactions through the system where the multiple entities touch on the sale of a drug.
And would that accrue to, but that would not, so that would be an economy-wide savings, or would that be specific? You think that would be specifically to the general fund?
Well, the idea is that those savings would also be passed on eventually to the consumer, because those purchasing the wholesale drugs would be purchasing it at a much lower rate.
Okay, that makes sense. With respect to Covered Connecticut, you helped get that program conceived and through the feds, and it's been a wonderful thing. We have here a lot of great things from the consumers who are relying on it. We've also, as a state, actively worked to shift people over to it. And I'm specifically thinking of in the last budget, we reduced Husky A parent eligibility and within the budget, with the assumption, which I think was a good one, that folks would be able to get coverage in almost all cases through Covered Connecticut. Obviously, there are just a lot of questions right now based on the expiring federal tax credits about the future of Covered Connecticut. And I just wanted, if you had thoughts about how we can sustain the program going forward, given the uncertainty at the federal level, and sort of navigate the fact that we're nudging people over onto the program, but we want to make sure that there's a program for them to be able to access.
Understood. And we obviously share the support of the program and its continuation, and agree that if the tax credits are not extended and or there are other changes at the federal level, as you all have been discussing this morning, that we will need to understand what those impacts are on the Covered Connecticut program and the impacts to those 42,000 individuals' ability to maintain coverage. So no disagreement on the need to understand the impacts of federal changes. I think our testimony, Senator, reflects the fact that there was not specificity in the proposal as to the source of the trust fund. And since there is nothing identified in the governor's budget to support such a trust fund, we're not able to support it at this time.
I understand that. I know that all executive branch officials have to support the governor's budget, and we'll work with you on it, because I know that that's an area of shared concern as well, in addition to our work on prescription drugs. And Thank you so much for your testimony this afternoon.
You're welcome.
I will also look forward to reviewing our written testimony when I can get a hold of it. But thank you so much for being here this afternoon, and thank you, Madam Chair, for the time.
Thank you.
Thank you.
I don't see any other hands. Have a great day. Thank you. Next, we'll hear from Ben Shaken, followed by Commissioner Amy Porter.
Good afternoon, Madam Chair, members of the committee. My name is Ben Shaken, Director of Government Relations at the Connecticut Community Nonprofit Alliance. We have testimony on a number of the bills on your agenda today. House Bill 7187, the bill regarding recommendations for people with disabilities, 7188, the CHESS program, 1470, Senate Bill 1470, community health workers, and Senate Bill 1251 opposing the rate freezes for intermediate care facilities for people with intellectual and developmental disabilities. Wanted to spend my time today talking about two other bills, however. The first is Senate Bill 1472, which would propose to reopen regional centers that the Department of Developmental Services offers. We are opposed to this bill. Nonprofits in the state currently serve, as of September, 4,184 people in residential settings, people with disabilities in Connecticut. State-operated services, including the regional centers, serve 365. 120 of those live at the regional centers, 106 at Southbury Training School, the two institutional levels of care that the state still operates. So that's 92% of services delivered to people with disabilities in the nonprofit community. That's the best place to serve people. And it's the best place for this legislature to invest resources to expand services to meet the needs of the state. I also here to talk about House Bill 7191 about Medicaid rates, here to talk about Medicaid behavioral health rates. The plan that the department has put forward, the governor's budget is short on resources, and the plan still, as far as I know, doesn't have details about which rates in the rate study the department is planning to prioritize. But I do know that the rate study showed that clinic-based behavioral health services are grossly underfunded. The study looked at 5 comparable states and found that the rates for behavioral health services in those states were 117% higher than those that Connecticut pays. That's higher. That's a disparity higher than any of the other components of the state's Medicaid program, according to the study. There's been talk about need to evaluate this further and study it further. We've been sounding the alarm about these providers for years. In 2015, one of our predecessor organizations, the Connecticut Community Providers Association, published a study showing that the annual loss in Connecticut for the top 10 behavioral health procedure codes by volume was more than $27 million. That was 11 years ago. Since then, rates have stayed relatively flat while costs have skyrocketed. Compounding these losses specific to nonprofit outpatient behavioral health providers, they're almost entirely reliant on Medicaid to fund their programs. To the extent that they exist to serve people with low incomes, and as a result, about 70% of patients in those clinics receive their healthcare from Medicaid, some as high as 90%. Unlike other healthcare providers, nonprofit behavioral health clinics cannot make up financial losses for Medicaid with private insurer rates or self-funded payers. And they're at a breaking point. We've seen clinics closing, we've seen them consolidating. As you know, since COVID-19, the market for clinical salaries has exploded in nonprofit.
Your time is complete. Please summarize.
I will. They cannot provide competitive salaries with private practice, telehealth, school districts, hospitals, the state, you name it. So we really urge this committee to move forward with this bill to provide funding to prioritize the $40 million that the study recommends to get the rates up to comparable states. And we also support the provision of the bill that would require regular review of these rates so that we don't get in this place again in the future. Thanks very much. I'm happy to take any questions.
Thank you so much, Ben. In particular, citing that study from 11 years ago, because couldn't agree more. I think we've reviewed this enough and we know we need to increase these rates. I'd love to hear your thoughts if you're prepared. Sorry, I don't know what's going on the CHESS program. What is your organization's take on that piece of legislation?
So the CHESS program was started right before the pandemic, and sought to cover a large portion of homelessness response services for a relatively small portion of the population, that the chronically homeless population. It has struggled to produce the outcomes and find the providers. I think that that it sought to originally cover. And so just from the bill and from the testimony that we heard, I know the department's planning on reevaluating it. I also heard, I think, some concern about changes in the federal government and their ability to cover the program. And so I think generally our position is to make sure that whatever funding might be going away by changing that program continues to be available for providers in the homelessness response system, because as we know, homelessness is unfortunately on the increase, on the uptick in the state of Connecticut, and the resources that the state has been able to provide to the system have been unfortunately limited and are and have largely over the last few years been able to be filled by federal dollars that are going away. And so I just urge the committee to be very careful about eliminating the program without a plan, and working closely with your partners in the Appropriations Committee to make sure that homelessness response services are funded.
Thank you very much. Any questions? All right, seeing none. Thanks so much for your testimony today.
Thank you.
Next, we'll hear from Commissioner Porter, followed by Maggie Moffett, who's in a panel with Marta Moret.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, and distinguished members of the Human Services Committee. My name is Amy Porter, and I'm the Commissioner of the Department of Aging and Disability Services. I'm here to offer comments on 3 bills being heard today: Senate Bill 1251, Senate Bill 1482, and House Bill 7190. So Section 1 of Senate Bill 1251, the Health and Human Services Implementer, transfers the administration of our driver training program for people with disabilities from ADS back to the Department of Motor Vehicles, as well as transferring the program's budget. This program provides free driver training to individuals with disabilities who require adaptive equipment to drive. And it was originally housed within DMV for about 35 years before it was transferred to our agency back in 2011. The ultimate goal of the transfer, when I've been talking with Commissioner Guerrera and the teams from our agencies, the ultimate goal is guaranteeing the same access for people with disabilities to licensing services that people without disabilities have. So right now, individuals who need specialized equipment need to come to our agency. It's an extra step in the process for somebody who has a disability. And so we want to make sure that DMV has that full access for individuals with disabilities, and we can support them. We have 3 tremendous staff. It's not a really big program. We serve about 300 people, just under 300 people a year. And we have 3 tremendous employees who provide the services to folks. Bringing their expertise back to DMV not only continues to provide the specialized training that folks need, but it also helps DMV expand their reach, be able to make sure that folks who don't need training but have special equipment, maybe somebody who comes from another state, can have immediate access to licensing services. So we believe that this transfer is better aligns the services, better aligns the training curriculum with our road readiness driver training. The second bill, Senate Bill 1482, would require our agency to consult with DSS to maximize the use of federal SNAP funds. And we heard Commissioner Barton Reeves speak to this earlier today. As you heard from the commissioner, we did work together after Public Act 24-99 passed to develop a plan to maximize SNAP benefits to support senior nutrition. That plan including meetings with CAFCA, who works with DSS to provide SNAP outreach. It included identification of key stakeholders, presentation at stakeholder meetings for agencies that work with older adults, and really being able to identify referral paths for individuals who might be eligible for both programs. This proposed legislation seeks to continue and potentially expand these outreach efforts. Similar to what you heard from the DSS commissioner, we share the committee's interest in leveraging funding to improve the nutrition of older adults, and we welcome further discussion about how we might be able to accomplish this administratively. And then third is a study of senior needs. House Bill 7190 would require ADS to study the needs of older adults for long-term care, transportation, housing assistance, nutritional assistance, and opportunities for socialization. The needs of Connecticut's older population are continuously being studied. We, in fact, in ADS have a state plan on aging that is updated regularly. Each of the area agencies also have a regional plan that they do at the Area Agency on Aging to assess these needs. Our long-term care ombudsman program issues an annual report, and we were fortunate enough in Connecticut to have the Connecticut Healthy Aging Data Report available to us, which is being updated this year as well. We believe that the information you're looking for is already housed in those reports. And so for this reason, we don't believe the bill is necessary, but as always, we welcome further discussions with the committee. And on behalf of ADS, I want to thank you for your time and consideration of issues faced by older adults and people with disabilities in Connecticut, and I'm happy to answer any questions.
Thank you, Commissioner. Just one, I only have one question having to do with the transfer of the ADS driving training program.
Yeah.
Do you know why back in 2011 it was moved to your agency to begin with?
I think for a couple of reasons. One, I think there were some budget issues that the state was looking at, but when we were originally created as a disability agency. And so a lot of the disability services were brought together under one roof, including the driver training program, which we've appreciated having, but our belief is that each agency needs to be able to meet the needs of people with disabilities for the services that they provide, rather than having them go to a separate agency. So that's the rationale behind the move back to DMV, the proposed move.
And to clarify, because currently folks need to go they need to still go to DMV. What are they going there for?
They go to DMV, and then if they need specialized equipment, they get referred to our agency, either to do training if the individual needs training, or for us to certify that they are able to use the equipment and we certify. We are not able to license. We're not a licensing agency. So we certify that for DMV. So with the transfer, they would be able to do all of that under one roof.
Thank you. That's very helpful. Anyone else? All right. Seeing none, thank you so much. Have a great
Thank you.
afternoon.
Thank you.
Next, we will hear from Maggie Moffett and Marta Moret. Hopefully I'm saying that correct. Just need to push there we go. The one is on and then the other, yep.
Good afternoon.
Good afternoon.
Thank you, Chair Gilchrist, Chair Lesser, and distinguished members of this committee. And thank you for the opportunity to testify in strong support of HB 7191. My name is Maggie Moffett, and I serve as Chief Advancement Officer of Fairhaven Community Health Care. Today, I am here not just as an advocate for our health center, but as someone who works every day to secure funding that bridges the gap between what it costs to provide care and what we are actually reimbursed. My small but mighty development team spends countless hours seeking private funding to fill the gaps left by insufficient Medicaid rates, funding that is never guaranteed and should never be expected to replace sustainable, predictable state support. With that, I will turn it over to my friend and colleague, Marta Moret, who is a board member of our federally qualified health center.
Thank you, Maggie.
You just need to push your button. There you go.
Oh, it's on. Okay. Thank you, Maggie. And I'm delighted to be here in front of all of you. It was many, many years ago that I was a deputy commissioner for the Department of Social Services under Lowell Weicker. So I clearly understand some of the push and pulls that you are dealing with as you try to address the plethora of needs in the state of Connecticut and certainly in Medicaid. Since that time, I have become a researcher and policy expert on underserved populations. And I am a long-term member of the board of directors for the Fairhaven Community Health Center. It's very clear that all of us and you, are facing some unique challenges in this term of the government. And those unique challenges include touching and reassessing some of our sacred cows. And for us at Fairhaven Community Health Center, one of those sacred cows is Medicaid. We cannot do our work without proper reimbursement for Medicaid. And we, the people that come into Fairhaven Community Health Center are people that have all of the issues that we in research call social determinants of health, which means they're poor, they're living in terrible circumstances, they cannot get good health care and pay for themselves. Jobs that they get are minimal and do not provide the kinds of fiscal support that can help them support their families. We call these elements of healthcare that have an effect on the ability of underserved people to recover.
Your time is complete. Please
From
summarize.
poverty. And so I want to leave you with two things. There are two research problems that are out there and that everyone in my research field is looking at. And that's social determinants of health and how they are affecting people. And more importantly, how community health services and community health centers, such as you have been supporting for many years in the state of Connecticut, do the work they do to keep people as away from poverty as possible. I also want to leave one more thing with you. There are a number of studies out there put out by Commonwealth Foundation, by the National Institutes of Health, by universities at every level who have public health schools that say that community health centers are efficacious and they are effective. They help people in the way that they need to, and that without them, are the people that we serve would be in great loss. Thank you very much.
Thank you so much, and agreed. And so look forward to working with you all on this legislation.
Any questions?
I don't see any. Thank you. Oh, yes, I'm sorry. Representative Comey, go right ahead.
Hi, thank you so much. Thank you, Madam Chair. Thank you, Maggie and Marta. Thank you for the work that you do in my community, both in our schools and in our neighborhoods, right? And I think what I have seen when visiting both your Fairhaven property and the Branford location is that these are not what you might think a community health center would be like.
Yes.
They are, high class, they're clean, they're quality medical facilities that take care of the people who walk through those doors with respect, and you don't feel like you're getting a less than quality healthcare. And so I know that going forward, we don't know what's happening with the Medicaid thing at the Medicaid situation at the federal level, but I just wanted to thank you for your incredible dedication to really the whole systems of caring for our communities.
And thank you for recognizing this extraordinary staff and Executive Director Suzanne Lagarde that we have at Fairhaven, and they do an awesome job. I teach at Southern Connecticut State University, and many of the students I have are low-income students who become nurses and technicians and who end up at places like Fairhaven Community Health Center and do a tremendous amount of good. So you see the outcome of that kind of support.
Yeah.
Thank you, Representative. And you're right, we can't know what's going to happen. But we do know that there is a freight train coming out of Washington and that we need Connecticut to support us now more than ever. So thank you very much.
Thank you. Thank you.
Thank you very much. Next, we'll hear from Kathleen Holt from the Office of the Child Advocate, followed by Mark Maselli.
Thank you, Representative Gilchrist, Senator Lesser, Representative Case, Senator Harding, and members of the Human Services Committee. I am Kathleen Holt, healthcare advocate for the state of Connecticut. I'll focus on sections 16 and 17 of Senate Bill 1251, an act implementing the governor's recommendations. I'm concerned this could fundamentally change the consumer-focused mission of the Office of the Healthcare Advocate, OHA. For the past 25 years, OHA has diligently served all the healthcare insurance needs of consumers in Connecticut, including for behavioral health, mental health, and physical health. We never discriminate between helping someone with one type of healthcare issue or another. We address all requests equally. So if I am de facto behavioral healthcare advocate, as the healthcare advocate, people have asked me, why do we need another one? It's confusing. The clarifying title for this role as it was envisioned should be the Behavioral Healthcare Provider Advocate. The office was created in 2023 by Public Act 23101 with a provider-focused mission to help mental health and behavioral health providers enroll in insurance plans and navigate provider issues. That office is not yet operational, but an advisory committee has been formed made up of 6 members who are all providers. It would be a mistake to intertwine OHA's consumer advocacy mission with a provider-focused mission. While helping providers may ultimately promote service access for consumers, provider and consumer interests do not always align. The elimination of a clear boundary separating the 2 offices could lead to confusion and conflict as to which party, provider or consumer, is being supported in a given case. It is critical to OHA's mission that our independent agency remains consumer-focused, trusted by consumers, acting on behalf of consumers, and speaking out from the consumer perspective. This is what makes our office unique from other state agencies and counted on by consumers. Our office and our advisory committee consists of individuals fully focused on the consumer experience. Providers and insurers have associations and lobbyists. Consumers have OHA. Ultimately, if OHA is to absorb the Office of the Behavioral Healthcare Provider Advocate, there would need to be a clear firewall between the work for and on behalf of consumers and for and on behalf of providers. Otherwise, if not implemented properly, it will jeopardize OHA's mission and reputation and unfairly be disruptive for consumers and to the strong reputation OHA has cultivated as a highly competent and successful voice for healthcare consumers. Thank you.
Thank you so much, Kathleen. Yeah, I mean, the Office of the Healthcare Advocate is really the one place that I can tell, you know, my constituents to go to when they have problems, many times with either insurance companies or with providers directly. Do you have an idea as to why this is being proposed? Do you have any background information on that?
So the only background information I have on it is that the Office of the Behavioral Healthcare Advocate was established a couple of years ago. Since it hasn't been implemented yet, I think there's some confusion because of the title that it is a consumer driven agency. And I think we want to make clear our understanding is that we already do the work for behavioral issues in our office. And this is a totally different focus. And so I think we just want to make sure that message is understood.
I understood it. It was very clear. Thank you. Anyone else have any comments or questions? Representative Kit.
Thank you. This is more of a comment. Thank you for the work you do. I too send my constituents to you all the time, and you have literally been lifesavers for them. And you bring up a good point in your testimony that providers have lobbyists and consumers have Office of Health advocates. So thank you for vocalizing that and bringing this to our attention. And I will be reading this bill with a fine-tooth comb, and hopefully we can get that message through. Thank you.
Appreciate it. Thank you.
Okay, does anyone have the Zoom up? I don't have it up to see if there's someone else.
Representative Hughes has her hand up.
Thank you so much. Representative Hughes.
Thank you, Kathleen, for your incredible work. Like the chair said, I often send consumers to your
Representative Hughes, you're very difficult to hear. Can you get closer to your computer or phone?
Can you hear me now?
Much better.
I'm standing in the, can you hear me now?
Absolutely. Yes.
Okay, hold on. Sorry, I just stepped out of another hearing. I wanted to say to Kathleen that part of the reason that I'm hearing from behavioral health providers is that they're not getting reimbursed, they're not able to serve clients because of the administrative and bureaucratic red tape and insurance carriers dropping them, that it's way too difficult. And that's why they're asking, especially for mental health providers, especially for, therapists, those kinds of things. That's why they're asking for some sort of help or streamlining how they can work with, as individual contractors, I should say, providers that don't quite frankly have any kind of lobbying against, to get to be able to serve their constituents. So many are now just private pay because they can't afford to wrangle with pre-authorization and insurance companies. So can you speak to that? Have you heard that?
Absolutely. Yeah, and we get calls from providers and we help where we can, unless there's a conflict between what's happening with the consumer and what the provider is asking us to do. There's only so much work we can do for providers. And I would say that the intent of this office for the behavioral healthcare provider advocate is very clear and is very necessary. The problem is it's gotten confused with the behavioral healthcare advocate as a role that we already perform within the Office of the Healthcare Advocate for Consumers. So we just want to make sure that it's very clear that this new role is not one that we're not already doing. This is a new role to fill a new need. It's not a new need, but it would certainly address what you were just talking about. And I think that's mostly what we want to communicate, is that there needs to be a clear distinction so that consumers aren't confused, that providers aren't confused, and that the roles are sufficiently filled.
Thank you. Through you, Madam Chair. I don't know if you can.
Rep Hughes, your volume's doing something weird again.
Trying to wrestle with this. Yeah, that's exactly right. So we might need to change the title. We might need to make sure that that there is a firewall, but ultimately our consumers are harmed, our patients are harmed when they cannot access behavioral health services because of the barriers to big insurance companies. And I just want to note that for the record. Thanks.
Right. Thank you. We absolutely want that to happen for providers as well, particularly for consumers from our perspective. I will say one of the issues that we are encountering with this is also trying to understand the funding. If this were to happen even with a firewall, because the Office of the Healthcare Advocate is not funded through the general fund, it's funded through insurance assessments. And so that probably wouldn't reach to providers, and that would have to be determined as well.
Wonderful. Thank you. Rep Hughes, do you have more? Okay. Now your hand went up. Something's going on with your. I'm sorry I stepped out, but I've caught up and I appreciate your testimony. And we'll reach out should I have any follow-up questions. Thank you so much. Next, we'll hear from Mark Maselli, followed by Mairead Painter.
Well, thank you, Chairs Lesser and Gilchrist, and Ranking Members Harding and Case, and the distinguished members of the Human Service Committee. My name is Mark Maselli. I'm President and CEO of Community Health Center, Inc., with over 160 locations across Connecticut, and I'm here in support of the raised House Bill number 7191, an act concerning Medicaid rate increases, planning, and sustainability. And I want to thank the committee for their support of cost-based reimbursement. This is a historic piece of legislation, and I appreciate the support that you're lending to health centers across the state of Connecticut. And my testimony lays bare the long journey we've been on to get back to a place where Connecticut was once a leader. But I do want to focus on a concern that I have, and I hope one that we can collectively address as we see the direction that health policy is taking shape in Washington. I'm worried that there will be a segment of the population that we currently care for, that we will be prohibited in providing health care for. And while I hope my assessment is wrong, I think we would be foolhardy not to start planning for how our state might establish a delivery system to address this potential crisis. We all are witnessing some of the effects that executive orders are having on healthcare organizations and the sanctions that have taken place so far against those who fail to strictly follow these directives. This is a unique problem to try to solve, as our entire health system depends on federal grants and also the Medicaid and Medicare system. So the solution probably can't be found in the existing players, like our federally qualified health centers, and frankly, anyone else who takes Medicaid or Medicare. We need to pull together healthcare leaders, community organizations, and private philanthropy community and develop what we started off when I started our health center back in 1972 as a free clinic operation that did not receive any state or federal dollars. These new entities will need support from private philanthropy or directly from the state, although that might pose problems for the state itself, as they may not be immune to sanctions. Having spent many years working to design an efficient, effective, and elegant healthcare system, this is not where I thought we would be headed. But there are some really hard, cold realities that we need to face about health policy are being made in Washington, and how a segment of the population may not be able to access our services either because of how they identify themselves or their inability to show citizens papers. And while I still am hopeful that public policy out of Washington does not take this route, I know the difficulty of standing up a healthcare organization, and it requires people coming together and planning now. And we will have a situation that only people in dire health straits will be able to get emergency care, and that is a maybe. But they will need to get primary medical, dental, and behavioral health services unless we can come together now and contemplate, plan, and be prepared to execute a Connecticut response. Again, I want to thank the committee for all of your hard work and effort on trying to ensure that healthcare is a right and not a privilege for everyone.
Thank you so much, Mark, for your testimony and for the work you do. I don't see any hands. Have a great afternoon. Next, we'll hear from Mairead Painter, our state long-term care ombudsman, followed by Jean Mills Aranja.
Good morning, afternoon, Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, and distinguished members of the Human Services Committee. I'm Mairead Painter, the State Long-Term Care Ombudsman, and I'll be testifying on several bills today. The first one being SB 805, an act concerning nursing homes to spend not less than 80% of revenue on direct patient care. While I appreciate the intent of this legislation and fully support a defined percentage of how Medicaid and other public dollars are allocated, it's important to consider how direct care is defined here in Connecticut. Compared to other states, Connecticut has a very narrow definition of direct care, and it doesn't include several critical support services like laundry, housekeeping, social work, and meal services that are all essential components of high quality care. but not included in the definition of direct care. Other states have higher requirements as far as percentages going to direct care. However, they have much broader definitions of direct care. I believe it's important to keep this narrow definition in our state and then define what is indirect care and capital expenses and the requirements around them, having a clear understanding of where all public dollars are being spent. It is important to have this clear understanding where public dollars are going. This will improve the quality of care, provide higher wages for staff, and ensure that necessary improvements to physical plant are done. Currently, we have buildings where they have received funds year over year, yet little to no improvements have been made to the general maintenance of these buildings. This can lead to evacuations and closures. Ensuring that nursing homes and all of their public dollars are used to enhance the care and services for residents is our goal. I support efforts to create greater transparency and accountability in how these funds are spent. However, requirements must take into account the full range of services and necessary expenses to ensure only high quality of care in our nursing homes. The next bill is SB 1479, an act concerning arbitration in healthcare. This bill provides safeguards to residents of Medicaid recipients, particularly in nursing homes, by prohibiting healthcare providers from requiring mandatory arbitration for billing disputes as conditions of Medicaid reimbursement. Mandatory arbitration clauses are often embedded in complex agreements that residents and their families may not fully understand. These clauses strip individuals of their right to seek legal counsel in court and instead forces them into private arbitration systems that overwhelmingly favor providers. This bill ensures that Medicaid recipients retain access to the judicial system and can contest unfair billing practices. The next bill is SB 1480, an act concerning private equity and real estate investment trust ownership of hospitals and nursing homes. Private equity firms and large real estate investment trusts have increasingly acquired nursing homes, often prioritizing profits over resident care. The business models of these entities frequently includes aggressive cost-cutting strategies, staffing reduction, and focus on short-term financial returns, all of which negatively affect the quality of care, staffing levels, and resident outcomes. As evidence from multiple studies that I've referenced in my written testimony demonstrate the harm that private equity and real estate trust owner facilities inflict on nursing home residents. For example, research published by the JAM Health Foundation found that private equity ownership of nursing homes led to a 10% increase in short-term mortality rates among residents. Over a 12-year period, this translated to more than 20,000 additional resident deaths. Additionally, residents in PE-acquired facilities were 11% more likely to visit emergency departments and 8.7% more likely to be hospitalized for avoidable conditions, highlighting a concern of declining quality of care. Staffing reductions are another major concern that is a consequence of private equity ownership, as these homes saw a 3% decline in nursing staff hours per resident day, with the greatest reduction occurring among registered nurses. Given that RN staffing is a key predictor in positive health outcomes, these reductions present serious risks to residents. A study by the Center of Medicare Advocacy, Tony Edelman, found that PE-backed nursing homes were more likely to have higher numbers of deficiencies and violations, including inadequate infection control and insufficient direct care staff. Financial strategies employed by private equity firms further divert the resources away from resident care. These firms often engage in sale leaseback agreements, selling the nursing home properties and leasing them back at higher rates, which drains financial resources from operational and care expenses. Funds that could have been reinvested into direct care and instead funneled into management fees, dividends, and debt servicing. One analysis found that private equity firms extracted $1.3 billion in profits from a major nursing home chain while simultaneously facing staffing shortages and declines in resident outcomes. The lack of transparency in ownership structures further exacerbates this problem. By prohibiting private equity firms and real estate trusts from acquiring and increasing ownership and control, this bill helps protect residents from the instability, financial restructuring, and profit-driven decision-making that often accompany these ownership structures. I provided, as I said, all of the links in my testimony to this research and the findings I referenced. I appreciate your time and I'm available if you have any questions.
Wonderful. Thank you so much for all of your testimony. I pulled up your written and plan on reviewing it more. But so interesting about the definition of direct care versus indirect care, and then the private equity, which is quite a problem. So thank you. Any questions? All right, seeing none. Thank you very much.
Thank you.
Next, we will hear from Jean Mills Aranja, followed by Representative Rebecca Martinez. Is Jean with us? No. Okay. How about Dr. Greg Shanghold? I did see him. Hello.
Good afternoon, Representative Gilchrist, other members of the committee. I think this might sound familiar to you since it was about a week ago, I think we were talking about Medicaid. So thank you for the opportunity to speak today on behalf of the physicians and the Connecticut State Medical Society, as well as the Connecticut College of Emergency Physicians, about the vital need to increase Medicaid for physicians. We are in support of House Bill 7191, an act concerning Medicaid rate increases, planning, and sustainability. My name is Dr. Gregory Shanghold. I am a board-certified emergency physician practicing in Connecticut for the past 23 years. I lead a group of 90 emergency physicians and advanced practice providers, staffing 7 of Connecticut's emergency departments, where we see about 600 patients a day. I would like to thank the committee for raising this bill this year. Hopefully this year we can go beyond raising it and actually pass something that is meaningful. In summary, the most important part of the bill is how to index Medicaid. It should not, in my opinion, and the opinion of our organization, should not be tied to Medicare, as my testimony explains further. Rather, the Medicare Economic Index, which is in the bill, should be the sole benchmark. Additionally, waiting 3 years to get to a rate, which does not even cover cost for 2025, will be insufficient to enact a meaningful change at the heart of this bill. Medicaid rates directly impact access to healthcare. Research consistently shows that increasing Medicaid payments closes gaps in access, particularly for vulnerable populations. Yet in Connecticut, Medicaid reimburses physicians at some of the lowest rates in the nation. Meanwhile, costs for running a medical practice have risen dramatically, and physician payments have been flat since 2007. This mismatch is unsustainable. The consequences are rather severe. When patients lack access to primary and specialty care, they come to emergency departments with advanced disease, leading to worse outcomes and higher costs. Chronic conditions go unmanaged, leading to preventable complications and higher healthcare expenses overall. Connecticut's emergency departments are already stretched thin, and without action, access to timely emergency care will be at risk. That is why the ED Boarding Task Force, created by the legislature, recommends increasing Medicaid rates. This is now the 3rd year we've discussed this issue. While there is a consensus that Medicaid rates are too low, we remain stuck in the debate. We must develop a sustainable system independent of federal Medicare decisions to ensure that Medicaid reimbursement keeps up with inflation and the true cost of care. From 2001 to 2025, there's been a 33% reduction in Medicare relative to the cost of living. And for the past 5 years, Medicare rates have actually been cut to physicians. This year, it was a 2.8%.
Your time
reduction.
is complete. Please summarize.
Emergency physicians are proud to serve 24 hours a day, 7 days a week, but we cannot sustain this commitment without proper support. The time for action is now. Strengthening Medicaid rates strengthens the entire healthcare system for Connecticut residents Thank you for your time.
Thank you, Doctor. And I do see a hand, Representative Pizzuto, who's on Zoom.
Thank you, Madam Chair. To the good doctor, just a quick question. Doctor, do you find a correlation between the urban areas such as Waterbury, Hartford, New Haven in recruiting emergency room physicians and the Medicaid reimbursement rate? I know that overall it's terrible since 2007, but do you find that we're in a crisis mode with respect to recruiting emergency physicians because of these rates?
Well, thank you for the question. Yes, Connecticut is having a recruiting issue, whereas, so we train some of the top emergency medicines in the country, both at Yale and at UConn, but we're 47th out of the 52 in retaining those residents for staying here in Connecticut. Furthermore, many of our surrounding states, as the Medicaid report that was issued recently showed, are better than us. So when people want to move to the Northeast, they're choosing states where they can get reimbursement. Many doctors are coming out with $500,000, $600,000 in loans. And so they need to pay those loans back. So they're looking at options other than Connecticut. And so we're not just competing here in Connecticut, we're competing globally. And without Medicaid, that's a big part. Most emergency departments, about 40% of the patients we see are Medicaid. So it ends up being a big part of the payer mix. And then when you throw in that Medicare is having cuts and people without insurance, you get to 75% of all of our patients. And that's one more reason that what's, I guess, being decided downstairs in the insurance committee is capping out a network at 240% would completely destroy. If we don't get a Medicaid increase and then you put downward pressure on the other aspects, then we won't be able to successfully recruit anyone at the rates that they're expecting.
Outstanding. I appreciate the comprehensive answer. And I know our most significant and most needy populations will or if they're not already underserved, will surely be. So thank you for your work, your efforts, and your testimony. Thank you, Madam Chair.
Right. Thank you so much. And I look forward to following up on the conversation about the Medicare and how that's not been increasing. So thank you.
Thank you.
All right. Next, we have Representative Rebecca Martinez joining us on Zoom, followed by John Anathara. Representative Martinez, are you there? Her Zoom's on, but she might be in another meeting, so maybe I'll keep going. Okay. And John looks ready to go. Go for it, John. Thank you. You just have to unmute. I'm sorry, you are muted.
Oh,
There
good
you go.
afternoon. Thank you. Good afternoon, Representative Gilchrist and distinguished members of the Human Committee. My name is John Ananthraj. I'm the Corporate Director of Clinical Services for Riders Health Management, which has 8 facilities in Connecticut and serving the community for the last 75 years with 736 beds and approximately 1,257 employees working at our facility. I would like to thank you for this opportunity to testify in support of HB number 7189, an act concerning Medicaid cost savings. Our nursing home recommends the committee adopt a policy that will save Medicaid resources and improve nursing home quality of care by capping a temporary nursing services agency rate so it can charge a Connecticut nursing home. The proposed cap would be 200% of the median hourly wage for nursing personnel by type of nursing personnel in the state, as published in the most recent state occupational employment and wage estimates for the state by the United States Department of Labor, Bureau of Labor Statistics. And the rate has to include all charges for administrative, contract fees, and other special charges. The proposal is modeled from Rhode Island law that passed in 2023. The practicing of the staffing agencies are creating costs that are not sustainable, which is why we are asking for these fees to be capped. Not having a cap on the agency fees directly impacts the facility by causing care and financial strain. From a clinical perspective, the effect of quality clinical care when using agency staff in healthcare settings can be multifaceted. Key clinical points to consider can range from continuity and quality of care, inconsistent training and orientation, standards of care and skill levels, accountability, regulatory compliance, and staffing mandate. We can increase Medicaid cost savings and the quality of care by hiring our own staff, which can reduce costs associated with agency fees and invest more in the quality of care provided to our beloved patients. This could improve health outcomes and prevent rehospitalization, impacting Medicaid cost. Agency staff often are not familiar with the functionality of each facility, leading to potential disruptions in continuity of care due to the provision of a different staff every time. In addition, agency nurses vary widely in their expertise and skill levels. While some may be highly skilled, many agency staff do not meet the required standards, affecting patient safety, quality of care, and patient satisfaction due to inconsistent staffing, as residents and family prefer familiar caregivers who understand the needs and preferences of their loved ones. Agency staff have also reportedly provided inadequate handouts as they are hurrying to leave the facility to go to another job, which can impact team dynamics and patient outcome, again leading to potential rehospitalization. Furthermore, once we have an agency staff committed to coming to work, the staff calls out and they pick up at another facility with a different agency as they offer a higher rate. The presence of agency nurses can affect the morale of permanent staff who may feel overburdened and undervalued, as the agency staff are not shy to share the hourly rate with the facility staff, thereby recruiting facility staff promising higher wages, which leads to our staff leaving. The staffing mandate issued on December 2nd, 2022 requires us to staff at 3.0.
Your time is complete. Please summarize.
And while we are trying to staff for this, the agency cost makes it more stressful for us, both from a clinical and hospitalization point. When hospitals are in surge, we're unable to take this 40% of Medicaid patients because of staffing challenges. While nursing agency can fill gaps and provide necessary support, their impact on nursing and quality care is complex. A thought I would like to leave behind is whether we have a staffing shortage or whether there are too many agencies that are attracting the staffing away from the facilities, thus causing a 36 to 50% increase in the payroll. In conclusion, our nursing home needs your help to control this unsustainable staffing agency cost as we rebuild our workforce. Please pass HB 78189 with a Medicaid cost savings language to cap the fees of temporary nursing staffing agencies. Thank you for this opportunity. I would be glad to take any questions.
Thank you. Thank you so much for your testimony today. I don't see any questions. Greatly appreciated.
Appreciate it. Thank you.
Next, we will hear from Representative Martinez, followed by Ellen Andrews. We had you, and then you turned it off and muted. Representative Martinez, can you unmute? There you go.
Oh, got it now. How are you? Okay. Co-Chair Gilchrist, Co-Chair Lesser, Vice Chair Comey, Vice Chair Mayer, Ranking Members Harding and Case. My name for the record is Rebecca Martinez, State Representative for the 22nd District, representing Plainville, Southington, and Farmington. I am a nurse with 24 years of experience in the healthcare field. Today, I'm here to urge you to increase the Medicaid medication administration line, a critical need for ensuring quality care and safety for our behavioral health nurses. Approximately 25 years ago, the state of Connecticut made the forward-thinking decision to deinstitutionalize psychiatric patients. This transition was based on the understanding that patients would thrive in community settings when supported by nurses who are educated and have the skills to administer daily medications and conduct thorough assessments. Not only was this decision more effective for patients, but it also saved the state significant costs compared to institutionalized care. However, in 2016, the Medicaid medication administration rate was reduced by 15%, and an essential add-on for additional services, such as providing an escort to nurses for their safety, was eliminated. This rate has remained stagnant ever since. Despite the rising challenges faced by nurses and agencies, today the reimbursement rate is $53 per visit, and that's what's paid to the agency. And if a nurse sees two patients living in the same address, it's $26 per visit. These rates are unsustainable for agencies that must provide nurses with necessary resources, including escorts, to ensure safety. The risks healthcare workers face have only grown over the years. And last year, we endured the devastating loss of my coworker, Joyce Grayson, who was tragically murdered while on duty. In response, the legislature enacted SB 1, which addressed critical safety measures for nurses, including provisions for escorts. While these measures are a huge step in the right direction, they cannot be effectively implemented without proper funding. How can agencies afford to send nurses with escorts at the current reimbursement rate? Nurses are leaving the field in droves, and if we do not provide the basics, the supports they need to just keep them safe, we will not be able to work on any recruitment or retention efforts. Our neighboring state, Massachusetts, provides a successful model for addressing these issues. Their Medicaid rate for medication administration rate is higher. Additionally, Massachusetts does not reduce the rate when a nurse provides individual care to multiple residents in the same address. And Massachusetts also offers an administration line that reimburses for essential services such as providing escorts. Home care nursing for behavioral health patients has been shown to reduce hospitalizations and incarcerations, also saving the state money. Taking care of these patients in the community is far more cost-effective than institutionalized care, but this care must be supported by an adequate reimbursement structure to ensure its sustainability. I am asking you to support modeling the Connecticut medication administration rate by modeling after Massachusetts, which includes increasing the rate, eliminating the reduction rate, and reintroducing the administration line to provide agencies with the funding for safety measures such as escorts. We already know this model works. By mirroring Massachusetts, we can provide nurses with the resources they need to deliver high-quality care while ensuring their safety. Connecticut has saved significant costs by transitioning patients to home care, but the state must not ignore its responsibility to the healthcare workers who make this system possible. Thank you for your time and consideration.
Thank you, Representative. Thank you for your dedication to this issue, and it's really helpful to have your knowledge on this subject matter. Seeing no questions, have a great afternoon.
Thank you.
Just want to kind of make an announcement. If Representative Reyes is ready and available, he should prepare himself. Now we'll hear from Ellen Andrews.
Thank you. Yes, all prepared. I thank you very much for the opportunity. I'm Ellen Andrews from the Connecticut Health Policy Project. I'm going to be talking about SB 1483 and Bill 1791. I will start with PCMH Plus. PCMH Plus has been troubled from the start. Our analysis of the program's first year performance found little evidence of quality improvement, and rather than saving the state money, PCMH Plus had significant net costs to taxpayers. Advocates raised alarms at the time and called for an end to the program from the beginning, and it hasn't improved since. It's time to end PCMH Plus and work with all stakeholders to build an equitable, sustainable program to improve value. I'll start with the cost concerns. In conversations with policymakers at the time, we learned that PCMH Plus was developed to increase funding for community health centers, but there is already a significant disparity in payment rates between community health centers and other Medicaid providers in base rates, and PCMH Plus subsidies are on top of those rates. Medicaid base rates, these are medians, for a medical visit paid to a community health centers are 7 times the rate paid to other Medicaid providers for a doctor's visit with an established adult patient. Community health center rates are also more than double Medicare's rates and 87% higher than private insurance rates in Connecticut. They're higher than commercial. There are serious concerns about the quality of care in PCMH Plus, and it's not getting better. While quality and access measures are good and rising across our national model Husky program, PCMH Plus and specifically community health practices are lagging and having trouble keeping up. It's a particular problem for broad-based outcome measures like emergency departments. PCMH Plus patients are 35% more likely to end up in an emergency room than other Medicaid members. But the CCMC, the non-community health center patients, are 19% less likely than the rest of Medicaid to visit an ED. This has been an ongoing problem that has not been addressed. We've talked about it in the Care Management Committee for years. let's see, PCMH plus community health centers have lagged behind community health centers, other providers on several other measures, including readmissions to the hospital and preventable hospitalizations. Switching to the Medicaid rate increase, which seems to be the theme for today, Connecticut Medicaid has been plagued by a chaotic system for provider payment rate setting. Updates have been driven by targeted lobbying and lawsuits. The largest and most profitable groups can afford those activities, perpetuating the problem. For the integrity of the program and to ensure adequate resources for care, Husky needs to develop an evidence-based process for determining rates. DSS started that with their two-part independent analysis of payment rates, and the bottom line was that behavioral health rates were by far, in quotes, the most out of range, averaging only 44% of comparable states.
Your time has expired. Could you please summarize your testimony?
Sure. According to the consultants, raising behavioral health rates to the benchmark would cost about $23 million, and that's an excellent investment for Connecticut. And I'm happy to take any questions.
Thank you, Ellen. Thanks for your continued work in this space. It's really helpful to have the information you provide. I don't see any questions. Have a great afternoon.
You too.
Is Representative Reyes with us? All right. I'll also put in an announcement to President Pro Tem Martin Looney, if he'd like to come on down. But with that, we'll move on to Paul Kidwell.
Good afternoon, Co-Chair Gilchrist and members of the committee. My name is Paul Kidwell, and I'm here representing the Connecticut Hospital Association this afternoon. Thanks for the time. I'm going to reserve my comments for SB 11. My colleague Mark Schaefer will be here later this afternoon to speak on HB 7191. We support many of the provisions of SB 11, but want to reserve my comments to sections 17 and 18 of the legislation related to 340B. CHA supports section 18 of the legislation, but asks that the definition of covered entity in section 17 be amended to reflect the federal definition of covered entity in section 340B(a)(4) of the Public Health Service Act, rather than the bill-specific definition that excludes hospitals. Under federal rules, 340B covered entities, which include hospitals, are allowed to contract with one or more pharmacies to provide pharmacy services and 340B drugs to authorized patients. There are comprehensive federal guidelines and audit and registration requirements that govern a covered entity's use of contracted pharmacies. Pharmaceutical manufacturers have sought to undermine and impede covered entities' use of contract pharmacies in contravention of federal guidelines and advice. These actions have been to the detriment of hospital patients and the communities hospitals serve, lessening the benefit of the 340B program, which is used to support the unreimbursed care for low-income Medicaid beneficiaries, uncompensated care, and the community investments hospitals provide each year. Unfortunately, hospitals and the patients and the communities they serve would not benefit from the protections in Section 18 because the definition in Section 17 of covered entity excludes hospitals except for the UConn Health Center. In 2023, hospitals in Connecticut provided more than $270 million in uncompensated care and were underpaid for care provided to Medicaid beneficiaries by $1.4 billion. Access to the 340B program is a core part of supporting care for the community and for continued community investments. Without this change, we are concerned that by enshrining protections for only certain covered entities, the legislature is implicitly authorizing discriminatory practices against hospitals, something that we don't believe is the legislature's intent, but which could be the ultimate result. We appreciate your time this afternoon. Happy to answer any questions.
Great. Thank you so much. Don't see any questions. Thank you for your
Great,
testimony.
thank you very much.
I don't see Representative Reyes or President Pro Tem Looney. All right. Grace Brangwyn, followed by Louis Luna.
Good afternoon to the chairs, ranking members, and members of the Human Services Committee. My name is Grace Brangwin, and I'm a Public Policy Associate at the Connecticut Business Industry Association. Thank you for the opportunity to testify in opposition to Senate Bill 11, an act concerning prescription drug access and affordability. Connecticut's competitiveness is challenged with items like energy, childcare, housing, and certainly the cost of health benefits for employers and their employees. In CBIA's annual survey of Connecticut businesses, member employers identified the cost of health benefit coverage as what should be top priority for this legislative session. Sadly, SB 11 does the opposite by significantly raising the cost for employees across the state. This bill imposes mandates on employer-sponsored self-funded health plans, making small employers liable for assuming a significant amount of medical risk. Section 12 of this bill creates two detrimental proposals that directly impact the business community. First, it mandates stop-loss policies used in conjunction with self-funded plans to provide specific coverage outlined in the general statutes. This is a mandate on self-funded plans, which may violate ERISA. CBIA encourages the committee to seek legal counsel to ensure this language is ERISA compliant. Second, this section also increases the aggregate attachment point to $250,000 for all businesses, regardless of size. But I like to emphasize that the drastic effect this will have on small businesses specifically. And I'd also like to provide you an example of these increased attachment points in practice. Let's say I own a small manufacturing company that employs 25 full-time staff enrolled in a self-funded plan. Under the current aggregate attachment points, I am liable for at least $20,000 of medical claims before my stop-loss policy is triggered. Under SB 11, I am now liable for $250,000 of medical claims before my stop-loss policy is triggered. The effects of this proposal will be devastating. Under this legislation, small employers will be liable for hundreds of thousands of dollars in medical expenses. The bottom line is that increased healthcare costs could force small businesses to withdraw benefits completely, move to the more expensive fully insured market that they once left, or cut costs in other essential areas of their budget, leaving them in dire straits. In sum, CBIA encourages the committee to strongly oppose SB 11 due to the increased costs on the business community. Thank you very much for your time, and I'm happy to take any questions.
Thank you for your testimony. Yep, Representative Mastrofrancesco.
Thank you, Madam Chair. Thank you so much for your testimony. I certainly have absolutely concerns with this bill, and I'm curious. I know there are a lot of municipalities that are self-insured, self-funded. Would you happen to know what that number is by any chance?
Unfortunately, I do not, but there is testimony from at least one municipality on the CGA website. So I do encourage you to look at that. In terms of the business community, 50% of businesses in Connecticut are self-funded. So I do want to let that stat sit there for a minute.
And do they all, through you, Madam Chair, and do they all have a stop loss on that when they're self-funded?
Typically stop loss is paired with self-funded, but it's not a requirement.
Okay, and then the amount of the stop loss that you mentioned would start at did you say it was 20,000?
Yes, and I do actually have a chart with me that describes the current attachment points for small businesses under 50 employees. So it's typically the greater of $20,000 or $4,000 times the number of covered employees, or 120% of expected claims. What SB 11 does is that it sets a blanket attachment point for all employers, regardless of size. So all employers, large and small, would need to have an aggregate attachment point of $250,000.
Thank you. Yeah, it's concerning that this could absolutely devastate our businesses here in Connecticut and our small business and our municipalities with that.
Absolutely.
So I thank you for the information, your testimony. Thank you for coming in.
Thank you so much. And I do want to emphasize too that this is an insurance issue. I testified last week in the insurance committee on a very similar proposal. So I do want to emphasize that as well.
Thank you. Thank you for your testimony today.
Thank you so much.
Next, we'll hear from Luis Luna, followed by Tracy Wodach.
Thank you, Representative Gilchrist and esteemed members of the Human Services Committee. Thank you for the opportunity to provide testimony in support of Bill 7191. My name is Luis Luna. I am a healthcare advocate. I am a patient. I'm a member of the Board of Directors of Fairhaven Community Healthcare in New Haven. I'm here to urge the state to immediately address the inadequate Medicaid reimbursement rates that threaten the sustainability of community health centers. Fairhaven serves over 36,000 patients, the majority of our patients from minority communities facing poverty, food insecurity, and housing instability. We provide essential medical, behavioral health, and dental services, but our ability to meet dental is constantly strained by low Medicaid reimbursement rates. Every year, we face difficult decisions about what services we can sustain for our Medicaid patients. For over 2 years, I led the Husky for Immigrants Coalition, advocating for Medicaid expansion for undocumented individuals. Through years of organizing, we won incremental expansions, securing coverage for undocumented children up to age 15. And on July 1st, I remember, of last year, one of the first children enrolled under this expansion was at Fairhaven Community Healthcare. It was a milestone moment, but ensuring lasting access to care requires more than just policy wins. It requires sustainable funding. Community health centers are the entry point to care for immigrant communities, yet Connecticut health centers are reimbursed significantly less than those in neighboring states. The Medicaid rate study showed that our centers receive only 75 to 80% of what similar states pay. This underfunding results in financial losses, $85 per Medicaid medical visit and $121 per Medicaid dental visit, straining resources and limiting expansion. At Fairhaven, we recently expanded our Brantford location due to growing patient needs, adding 5 clinical rooms and additional providers. Despite clear evidence of increased service demand, our request for a Medicaid rate increase was denied. This broken and inconsistent process puts healthcare centers in an impassable position, forced to stretch already limited resources to serve patients who depend on us. HB 7191 would fix this. Sections 2 and 3 ensure that fair reimbursement for healthcare centers and timely cost of living adjustments for Medicaid rates. These changes are essential to keeping our doors open and maintaining critical services for our communities. We need a system that supports.
Your time is complete. Please summarize.
We need a system that supports rather than undermines the healthcare providers serving our most vulnerable populations. And I urge you to pass HB 7191. Thank you so much for your time and consideration.
Thank you so much. Thank you, Luis, for your continued advocacy for being here today.
Thank you.
Next, we'll hear from Tracy Wodach, followed by Senator Gordon. Oh, Tracy, you're muted. Someday we'll get it.
Oh, okay. Can you hear me now?
Yep, you're good.
Yeah, I had to switch to my phone because of connectivity issues. Sorry. So let's see. Let me start over. Distinguished members of the Human Services Committee, my name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. We are the united voice for our licensed home health, hospice, and homemaker companion agencies. The association applauds and supports Human Services for raising HB 7197, which addresses the immediate need for investing in our Medicaid providers to sustain future access to care, especially with the looming potential federal Medicaid cuts. However, we urge you to consider improvements to ensure long-term provider viability and access to care at home services. Specifically, licensed home health providers urge you to accelerate the implementation of Medicaid rate increases beyond the proposed phase-in timeline. Ensure that all relevant Medicaid home health billing codes, especially Medicaid administration, as Representative Martinez mentioned, are included in rate adjustments. Eliminate the home health subsequent visit rate penalty, which unfairly reduces reimbursement by 50% for the same level quality care. A significant flaw in the Medicaid rate study is that it failed to account for key home health reimbursement rates most notably medication administration, which accounts for over 50% of the Medicaid home health expenditures. Leaving it out of the rate study is inexcusable, especially when our border states of Massachusetts have a similar visit type and reimburse at $71.52 per visit versus Connecticut at $53.78. Our priority asks for care at home providers are detailed in my written testimony, but our highlights are for licensed home health, implement 10% Medicaid rate increase for all visit codes for each of the next 5 years. But for the medication administration, we ask to eliminate the 50% subsequent rate and re-implement the 15% higher than current rate from 2016 and implement an add-on rate for high-risk and rural cases. Homemaker companion providers, 13% rate increase this year and next to address the 26% wage gap for self-directed PCAs. With regards to HB 7189, Medicaid cost savings, and the reference to nurse delegation, we had a law passed specific for home health in 2012, and I am happy to answer any questions the committee may have about that law. And thank you for the opportunity to testify. I'm happy to answer any questions.
Thank you so much, Tracy. I don't see any hands. Thank you for your testimony and for flagging this important issue. Next, we will hear, is Senator Gordon with us? All right, then we'll go on to, let's see if I can get your last name right this time, Richard Famiglietti. Tried so much.
Thank you, Representative Gilchrist. Yes, my name is Richard Famiglietti, and I'm here to speak in favor of Senate Bill 807, an act concerning the elimination of asset limits for Husky C beneficiaries over a 5-year period. Senate Bill 807 is a great beginning to end the discrimination purposely crafted into the Connecticut's Husky programs, limiting access to Husky C for people with real disabilities. These are people who cannot work due to their disabilities. Raising the asset limit will only end half the discrimination. The other half of the discrimination is the much lower income limit than other Husky programs for healthy working non-disabled people. While having a higher asset limit might allow savings for emergencies and other life goals, it does not do any good unless the income limit is also substantially increased. Having a Husky C low income limit of roughly just under $1,300 a month does not allow for savings for emergencies. In fact, without utilities, rent in New Haven is between $1,600 and $1,900 a month. And people with disabilities and Husky C are getting evicted left and right. Why is Husky C for the rich? I know that sounds kind of weird, but if you are over income by thousands of dollars in Husky C, you can hire an attorney, create a pool trust, hide your excess income, and get Husky C. But if you are just $1 or a few $100s over, you're screwed. You can't afford a trust, so you have to spend down on medical bills, leaving with you approximately $500 short of rent. We have been asking Husky C income and asset increases for about 5 years now. We cannot wait 5 years to phase it out. Fix both now by increasing income and asset limits. Let's not do this half-assed. I don't understand why people with disabilities, in order to get around the income and asset limit, we have to pay fees for able accounts, pool trusts, just to be eligible for Husky C. This doesn't make sense. Currently, I'm on MedConnect. If I stopped working tomorrow because of my disability, literally, I will not be eligible for Medicaid because I'll be thrown into Husky C non-working. I lose all of what I worked for, and because of my income, I'm going to be in assets. I won't be eligible for regular Husky C. This is ridiculous. We actually fixed it, but our governor declared war on people with disabilities, and he removed it. I urge our legislator to stand up against this governor, pass it so that we remove this discrimination for Husky C income and asset limits and make him veto it. Thank you.
Thank you so much for your testimony. I don't see any hands. Thank you. Next we'll hear from Senator Gordon. Oh, do you two want to come up together? Or, okay, Senator Gordon.
Thank you. Sorry for being late. I'm in the midst of a Veterans Committee meeting. So, but happy to be here.
Me too, Senator.
Chairs Gilchrist and Lesser, ranking members Harding and Case, and members of the Human Services Committee. I'm here to testify on Bill 7192, which is the act implementing recommendations of the Bipartisan Drug Task Force. We had the press conference today, and I'll make another shout out that this is indeed was not just a bipartisan task force, but a nonpartisan task force. So we should get a medal for that because it's not often we see that. But thank you to both of you for being co-chairs, and also to Representative Maurer for also being a co-chair, and I'm happy to have been a co-chair as well. I know we're familiar with the bill, so I won't go through all the details of it, but this is certainly a very strong effort and a needed effort to see what we can do to strike at what is unfortunately a growing and worsening part of unaffordability for people. Just not here in Connecticut, but we're seeing that in many, many states. And this is why many states have looked to do things like this to see what we can do to try to address prescription drug price affordability. So I'm glad to see us in Connecticut moving forward. This task force certainly brought many, many different stakeholders together, many meetings, and we took that all into account and put our recommendations into this bill before you. Certainly some people may say that more could be done, but this is certainly a very realistic and I feel much needed step forward to address prescription drug price affordability. One of the issues with that is, what do we do with the pharmacy benefit managers, PBMs? And what we're looking to do, and why this bill is very important in this regard, is number one, we got to hold them to a fiduciary responsibility. Absolutely. We're not the only state that's looking to do that. Other states have been as well. And it's time we do that in Connecticut. We need to make certain we have transparency and accountability in what they do, especially all these different deals and negotiations they make with the pharmaceutical manufacturers, distributors, whatever pharmacies in their networks that they affiliate with, that really we don't see and patients don't see when they have to buy their drugs, including what happens with regards to the prices they charge or the savings they get, and how that gets passed down or not passed down to patients who have to get these drugs. I can tell you, as a doctor for 33 years, this is a problem I see getting worse and worse every year, where more and more of my patients can't afford basic medications. Medications have been out there for many, many years, not the real new fancy expensive stuff, but what I call the bread and butter type of medications that they need every day to live and to survive. And this is a problem that we need to get our handle on. So trying to do reform for PBMs is extremely important. And I'm very happy to see in this bill we're moving that forward. But we also recognize that there's other things as well that we need to do, such as making certain we're protecting and keeping going the local pharmacies that many times get boxed out of these affiliation networks. And that is unfair, very much so. It seems to be geared more for the big chains sometimes. And as we know from 2 Federal Trade Commission reports, including one that came out in January, there's only a few big PBMs in this country. They account for over 80% of dispensing of these drugs. They make billions of dollars off of this. They do certainly generate a lot of savings for themselves. We need to pass that down and make certain also that there's a fair deal for the local pharmacies that our constituents rely on. And last but not least, we also are looking to see what we can do to address drug shortages. That's not an easy thing for a state. We certainly depend upon our federal colleagues very much so. And I know the FDA every year issues an updated report, and the list of drug shortages increases every year. I see it every day in my practice. But what can we do in a smart way here in Connecticut, investing into things through DECD, for example, to try to leverage state resources and state funding to deal with manufacturing and distribution locally? What can we do with importation of drugs from Canada, which is allowed if the state does seek that? Florida got permission to do that, the first state in the nation. So I believe there's smart things we can do to think short term, but also think long term as this problem isn't getting any better. And so all the recommendations that are in the bill before you, I strongly support. I thank my co-chairs for working with me, but also working on behalf of the people of Connecticut. Again, this is a step forward, one of many steps I hope we'll take in the years ahead. But you got to start somewhere, and this is a very strong, good step forward. And I hope the committee will support it, and I hope to see this get passed into law and signed by the governor.
Thank you very much, Senator. It was a pleasure getting to work with you as well. Senator Lesser.
Thank you so much, Madam Chair, and good to see you, Senator. It was a real privilege, one of the most informative and validating experiences in my time in the legislature to be able to work with you, Representative Mara, Representative Gilchrist on this task force, and of course, all the committee members, looking at how to make prescription drugs more affordable and ensure access to patients in Connecticut. And I just want to appreciate your work in putting your patients first, listening to their experiences and their experiences affording these drugs. So there's an awful lot in the report, and I'm not going to quiz you on it, but I just want to express my gratitude to you. It was a real important work that we're doing, and I'm hopeful that we'll be able to get all the members of the legislature to support it. I know you mentioned Canadian importation. I know we're still waiting to see whether or not Florida is able to actually secure those drugs. I know they've gotten federal approval. Any other areas that you want to particularly highlight as something that we should be focused on?
Well, certainly drug importation is extremely important. We'll see what happens with Florida's effort. I know there was pushback from Canada. We'll see what the soon-to-be new Premier of Canada will say about it and what happens with that. But certainly the drugs in Canada are on par with the drugs we have here. High quality, vetted through. The same companies basically make them there that make them here. So I don't have a problem with importation. It'll be very interesting to see how that works out internationally. I think one of the big things that we need to make certain that has been, there's many priorities in this bill for me, but one of the big priorities has always been putting people over profits. And we really need to make certain that we're shining light on what's going on with the whole PBM process. I'm not looking to run them out of business. I'm not looking to say that they can't do things here in Connecticut. But as we've seen in Connecticut and elsewhere, there is reform that's needed. And when you shine light on things, and we've seen this many times at the federal level with the Congress, shining light on, for example, prices of insulin, lo and behold, things do seem to get done and get done for the better. And I believe that this is very much important to keep in mind, that if we can have transparency and accountability, we're not looking to wreck the process or get rid of the process. The process actually can work better for what it's intended to do, which is the people who need to get these drugs. And that's really what it comes down to, the way that I look at it. So to me, that's one of the highlights of this effort is transparency, accountability, fiduciary responsibility, but also making certain we're holding people's feet to the fire, that if they're not going to do the right thing, we have the backing of the state to make certain that they are going to do the right thing. And that's certainly not bad as all, to make certain that we can enforce what I hope will become law in this regard.
Well, thank you for that. I just remember last year, I was working on some drug reform legislation, and you approached me and expressed your interest in it and your willingness to work on those issues. And that sort of, those conversations became the germ for our broader work. And I'm just grateful to be where we are right now, to see all of the thoughtful back and forth, all of the ideas. I think none of the things that I was working on last year are now in this bill, but that's actually a good thing, right? It's an iterative process. And And that's where the back and forth comes, and that leads to a better product. So very excited to see it, and hopefully this bill can move forward, and we'll keep working together on this and other issues in the Senate. And with that, I want to thank the committee for its time.
Great. Thank you so much, Senator.
Well, thank you. And again, it's been wonderful to work with both of you, Representative Gilchrist, Senator Lesser, and with Representative Mara. This really has been a wonderful process working through things. And thank you for the opportunity. And I appreciate testifying here today. Thank you.
Thank you. Next, we'll go to Ed Schreiner, followed by Representative Mara.
Good afternoon, Representative Gilchrist, Senator Lesser, and members of the committee. My name is Ed Schreiner, and I own Stoll's Pharmacy in Waterbury, Connecticut for 35 years. Last spring, I sold my pharmacy, and I'm now the Vice President of Network Development for Northeast Pharmacy Service Corporation. We provide business development services to pharmacies throughout New England, and our network includes 113 participating pharmacies right here in Connecticut. I'm here today to testify in strong support of the PBM oversight language in House Bill 7192 and SB 11. I'm very encouraged by the legislature's desire to find creative ways to reduce drug costs for the citizens of our state. These two bills are designed to create transparency in drug pricing, and that is critical. If we're ever going to find opportunities to reduce drug prices, transparency has to come first. So I support that immensely. I appreciate the opportunity to be able to participate in the RX Drug Task Force, which was led by Representatives Gilchrist and Senator Lesser, Senator Gordon, and Representative Mara. In 35 years, I can't ever remember working so closely with the legislature to help people understand how my industry works. And I really appreciated that opportunity. The task force concluded that PBMs have contributed to higher prices, often benefiting their corporate stakeholders over patients. Various trade groups representing PBMs have suggested, and I'm sure will continue to suggest today, that implementation and the policies in these bills are going to drive up costs. I'd like to take a closer look at these proposals. So spread pricing increases costs for insurers with no additional benefit for the patient. I ask, why should a PBM profit by billing insurers more than they pay the pharmacies to dispense the prescriptions? A service the PBM doesn't even provide. They don't dispense the prescriptions, the pharmacy do. I can't understand how eliminating that additional markup for nothing, doing absolutely nothing, is going to cost money. PBMs state they're going to be less effective at negotiating rebates if their compensation is delinked from that rebate calculation. Yet they've also stated that 99.7% of rebates are passed on to their clients. So I can't understand, why would you be less effective if you're already passing 99.7% of the rebates through? How would that change? 0.3% is not a very big change. Finally, examples of why we should delink profit from drug costs and how it saves patients money. In 2023, when I still owned my pharmacy, there were 3 major insulin manufacturers that announced list price cuts of 65 to 80% that were going to take effect on January 1st of 2024. And what happened on January 1st of 24 was that multiple PBMs removed those very products as preferred on their formulators.
Your time is complete.
In
Please
favor of more
summarize.
expensive drugs that had higher rebates. So PBMs do offer take it or leave it contracts, and they're never going to negotiate fairly unless mandated with legislation. My testimony has a number of things that I would ask you to consider, if you could please read it, that would strengthen this law to protect pharmacies. Just this past week, there was PBMs, the 3 largest PBMs contract with basically through 4 wholesaler contracting groups. One of those groups last week said, the rates aren't sustainable for our pharmacies, we're not going to contract. So this PBM in question, which is one of the 3 largest, on Monday sent a fax, just a fax, sent it to the pharmacies saying that this is the contract we're going to give you. And if you don't opt out within 20 days by sending an email to this address, we're going to assume that you're in. So I looked at the financials for that rebate, and we run a buying group, so I know what pharmacies buy at. 90% of my network was going to be reduced, paid 4% below their cost on every single brand name drug in that contract. The generics, they might break even, but there was no dispensing fee. The fee was zero. So it's not a realistic contract. There is no negotiation. The negotiation was, you're going to take this unless you opt out, and then you're just out. So this is the kind of tactics we're talking about. So again, please look at my, comments about various comments about things that we need to support the pharmacies to make sure they're here to provide those medicines. Finally, I'd also like to mention that not all PBMs are the same. So we're primarily talking about 3 large PBMs who, as Senator Gordon mentioned, manage 80% of the covered lives. But I'm aware of 5 transparent PBMs whose business models include many of these policies that we're talking about, many of the policies that are in my testimony. And how is it that those 5 can run businesses that create savings for their clients when these large 3 PBMs can't? So I'd like you to consider that. So I appreciate your consideration of my comments today. And again, the details are in my written testimony. I hope you really consider adding them, but I'd be glad to answer any questions.
Thank you. I've learned a lot from you over the course of the task force, and I'll definitely take a look at your testimony. Senator Lesser.
Not too much to add other than just say thank you. It's been a real pleasure to work with you and really appreciate your testimony. We will look closely at it, but very happy to have the voice of pharmacists hit this conversation. And so really appreciate your suggestions, and we will keep working with you.
And I do appreciate all of the efforts of all of the legislators running that committee. You did a wonderful job. Thank you.
Thank you. Have a great afternoon.
Thank you.
Next, we'll hear from Representative Mara, followed by Karen Nemaya.
Good day. Thank you so much. Thank you for the opportunity to speak in front of you today. My name is Tracy Mara, and I had the pleasure of being on the task force and chairing it. And I think I guess I just second what Senator Gordon already said. It was a pleasure to serve on that task force and chair with you guys. And I felt like we really did dig into some very meaty topics. So I am here today to speak in favor of HB 7192. I know, pharmacies are the most accessible healthcare that we have. Not just in the state of Connecticut, but anywhere. When you are looking for a healthcare provider, they're the one place that you can go. We know now that when we walk into pharmacies at lunchtime, there may not be a pharmacist there. When we walk in, there's long lines and there's one pharmacist working their butt off in the back trying to get things done. So when we looked at this task force, one of the goals was to make sure that we keep pharmacies and pharmacists accessible, because healthcare needs to be accessible to be effective. So we looked at, of course, the cost of prescription drugs, but it was definitely something that I was pushing forward to make sure that when we're looking at cost of drugs, that we don't do that and sacrifice our healthcare workers, that needs to be kind of front and center, because we think we have high cost of drugs now. When we start weeding off pharmacists and pharmacies, then that's when we really have problems. So I appreciate that while we went through this process, that was one of the things that we looked forward to. I'm not going to read any of my testimony. I just want to reiterate some of the things that Ed Schreiner just talked about when he was talking. Some of the issues that we see in pharmacists, one are that spread pricing, but the other issue that we see is that pharmacies and pharmacists are not reimbursed at a rate sustainable for their practice. So when they submit their drug reimbursement, they may not get the full price of what they paid for the drug. Whereas if you have these vertical integrated healthcare systems where you've got the pharmacy owned by or in with the insurance, in with the PBM, they may be able to get a special price for that drug. So they may be fine, but the pharmacies that are not in that integrated system aren't able to get those prices for the drug. So one of the things that we put in here is that you would have to reimburse the pharmacies the wholesale acquisition cost. And maybe some of the discussion today, we did go back and forth, whether it be wholesale acquisition costs or NADAC. There's a couple different costs that you can use when looking at that. But the point being is that a pharmacy should be able to be reimbursed at least for the cost that they have already paid for the drug. It doesn't make a very good business model if you are constantly ordering drugs in and you are dispensing them at a lower cost. And that is what is happening. I realize that my time has gone really quick, but I do want to, I'll quickly highlight one of the other points at the end. And we talked a lot about drug shortages as well. And so one of the, honestly, there's a lot that we cannot do here at the state level. There's a lot that has to be done at the federal level. When we talk about manufacturing of drugs, yes, we need to make sure we manufacture drugs here in the United States. And that is really important. And I hope that our federal government is understands that and is pushing forward with that. In the meantime, some of the things that we can do is when there are shortages, especially when these drugs are already generic, that we might be able to have companies come in here in the state of Connecticut and boost our supply. So one of the things that we did look at is adding, there was a shortage grant that DECD put out, and we wanted to add to that grant to say that pharmacy could be, or the production of pharmaceuticals could be part of that grant. So I'll stop there because I hear my ding twice.
Well, interestingly, that wasn't even our ding. I don't know what's going on.
All right, who's dinging me? Nice.
You're good. Any questions from folks? And I want to echo what I said earlier. Just it's been a real pleasure getting to know you more and learn from you on the task force. Senator Lesser.
Yeah, I likewise. I was really impressed by your thoughtful insight into a whole bunch of different healthcare issues, and it was a real joy to work with you, Representative. And I just want to express my gratitude to you. Can you talk a little bit more about the spread pricing component? Because I know this was an issue that you were particularly focused on and why it's important. And I know one of the many considerations we're looking at is vertical integration, where PBMs are trying to, in some ways, dictate which pharmacies we go to and which ones not. And so I just wanted to see if you could talk about why that provision is so important.
Right. And that is why that's why we put in both the fiduciary component and the wholesale acquisition cost so that there's not going to be a kind of a higher cost reimbursement that then goes to someone else, right? That way we know that if it's based on wholesale acquisition costs, you're not going to have kind of a fake cost in there that's built in that creates a profit that one pharmacy may be able to get and other pharmacies can't get. I look at there's so many things that we have looked at in here that these are not novel. These are things that other states have already done. So I hope that when everybody looks at what we have done here today, and when we look at this fiduciary component, there are other states that are already doing this. When we look at this price reimbursement based on wholesale acquisition costs, we know that other states are already doing this. So we're not trying to throw anything novel out there. We're trying to be very thoughtful. And I do believe we had a lot of other great ideas too, but we felt particularly with this task force, particularly with us coming together in a bipartisan manner, that we should take a step forward. We don't have to take leaps and bounds. We just want to take a step forward, and we want to see where things land. A lot of people are going to be very concerned when they look at this saying, oh, well, all of a sudden you're going to do wholesale acquisition costs instead of, this vertically integrated system. They're able to get a better cost. So our price is going to go up. We actually just had a study come out of West Virginia that was looking at this particular issue. And they did show that using the wholesale acquisition cost did not show higher costs into the patients, which I think is very important to see.
Well, thank you for that. And again, thank you for your work. There's a lot in here, and I'm hoping we can get quite a bit done.
And then I do see Representative Bizzuto on Zoom.
Thank you, Madam Chair. Hi, Tracy. Thank you for your testimony, your hard work, your experience as a pharmacist. Just quickly, I know that with the 60 or 70,000 state employees were forced to use Stop and Shop or CVS. Do you feel that we're boxing out the independent pharmacists almost out of business, to putting them out of business? And will the vertical integration help?
So, yeah, thank you so much. I've gotten a lot of questions about this. I think what we're putting in here is going to help that, because a lot of the boxing out of the pharmacies is because you're forcing contracts upon pharmacies that can't agree to the prices. If you heard Mr. Schreiner, who was just on here, he's saying, you've got these PBMs that are coming and they're giving you a contract and saying, this is what you will accept for these drugs. And you are either, yes, I will accept them, or no, I'm not going to take any of anyone that has you as a carrier. And that's an issue. The other thing that we're going to see, we will start collecting some rebate information that's going to go to the Commissioner of Insurance to see if there's any poor practice with some of these rebates. So I do believe that while I know you and I have talked about this issue with boxing out some of the local pharmacies, I believe while this doesn't hit it straight on, I believe because we're asking the insurance companies and the PBMs to reimburse based on that wholesale acquisition cost, that will mean that many pharmacies are able to accept and use these insurance carriers as well.
Great. Thank you for chairing the committee and the committee's work. Thank you, Madam Chair.
Thank you, Representative. Thank you so much.
Thank you.
We've been joined by Senate President Pro Tem Martin Looney and Majority Leader Bob Duff. So I'd like to invite them up, and then Karen Amaya will go to you right after.
Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Martin Looney, represent the 11th District, parts of New Haven and Hamden, and I'm accompanied, of course, by our great Majority Leader, Senator Bob Duff, from the city of Norwalk. And I want to talk first about SB 11, and I will pass it over to the Majority Leader after some introductory comments. And there are a few other bills I want to mention as well, but SB 11 it tackles an issue that's familiar to too many families in Connecticut. That is, of course, the cost and availability of prescription drugs. And one of the most significant components of this bill is the comprehensive reform of pharmacy benefit managers that play a major role in determining prescription drug prices and access. And SB 11 introduces key provisions to address these concerns, including the key one of the establishment of a fiduciary duty for PBMs to act in the best interest of consumers and health plans. That's something that's desperately needed. Far too long, PBMs have operated with little oversight, profiting from a really convoluted rebate system. And SB 11 continues the momentum of previous efforts where a few years ago we capped the out-of-pocket cost for insulin and also prohibited PBMs from imposing gag orders on pharmacists to prevent customers from saving money on certain lower cost generics. And the bill addresses this affordability crisis by expanding state agencies' ability to negotiate bulk purchases of drugs, and also strengthens collective bargaining power to drive down costs for public programs and taxpayers, and reinforces Connecticut's commitment to fair pricing, and also strengthens protections for the 340B contract pharmacies, ensuring that discounted drugs intended for vulnerable populations are not undermined by predatory PBMs or manufacturers and their practices. And also, the bill establishes a framework to limit excessive pricing on prescription drugs and tackles the problem of anti-competitive practices by addressing pay-to-delay agreements wherein pharmaceutical manufacturers intentionally delay the release of lower-cost generics to maintain high prices artificially. Also introduces a Canadian drug importation program to lower prescription drug costs and enhance market competition. All of these are key elements of this far-reaching bill, high priority for our caucus, and would turn it over to our majority leader.
Thanks, Senator Looney. Good afternoon to Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. I appreciate the opportunity to testify in favor of Senate Bill 11. And I'll focus a little bit on the pharmacy benefit managers, and which has really been the discussion so much, not only here in Connecticut, but across the country. Whose benefit are they here for? Certainly not the consumer. And I want to thank this committee for all their work that they've done in the past on trying to tackle high cost healthcare. Senator Lesser, you and Representative Gilchrist and others who have really tried to bring down the cost of healthcare for residents of the state. And as all of us do when we're out campaigning in our districts, where we see residents at various functions, it's probably not a day that goes by where we don't hear about the high cost of drugs, especially from senior citizens. And with the kind of the unknown factors of what may happen in Washington, D.C., this bill has probably never been more important of saying that PBMs have to actually act in the best interest of consumers and health plans. I mean, who would ever think that we'd have to write legislation that said that they would have to act in the best interest of consumers? It seems like that we would not have to spend that time writing that as a law, but here we are. So I want to thank Senator Looney, because these are issues that he has been fighting for a number of years and decades. He's well versed in these issues, but also for many members of the legislature who have heard from their constituents, who see the kind of this game of whack-a-mole where you solve a problem and then another problem pops up and exists. And so again, I think that these issues are more important than ever, of trying to bring down the cost of healthcare, trying to bring down the cost of prescription drugs, trying to make sure that we don't have third-party companies or organizations or entities that are taking advantage of consumers, and that we are doing everything we can to not use taxpayer dollars when it's not needed, because we're trying to make sure that we keep companies honest to what they need to do. So again, thank you for the opportunity to testify in this committee, and thanks again for your hard work and moving these issues forward each and every session.
If I might just add commentary on a few other bills on your agenda today, and again, want to commend this committee for all of the important work that it does. I had the great pleasure of being a member of this committee when I was a freshman state rep in 1981 and 82. And they were doing great work then and now. So a few other bills. Senate Bill 805 would require nursing home facilities to spend at least 80% of Medicaid, Medicare, and other funding on direct care. This is important too, to make sure that we have the right distribution of funding to go into the quality of care. 806 would expand our state's definition of emergency medical condition under the Medicaid program. This is while Connecticut did expand its policy to include outpatient dialysis a couple of years ago, our state still has a narrower view of what constitutes an emergency medical condition than some of its surrounding states have. Senate Bill 807 would increase and then phase out the asset limits for the Husky C program. House Bill 7192 deals with the issue of pharmacy benefit managers and their responsibility in good faith in dealing with other parties involved. And Senate Bill 1480 tackles the issue of dealing with private equity and real estate investment trust ownership of hospitals and nursing homes, which, as we have seen, is an ever-increasing problem as their reach into for-profit healthcare results in terrible consequences. thank you to the members of this committee for considering all of this important legislation.
Well, thank you both for your longstanding advocacy for these important issues. Senator Lesser.
Thank you, Madam Chair, and good to see both of you. And I just want to thank you for making consumer protection and healthcare affordability centers of focus for our caucus, the Senate Democratic Caucus. And I just want to express that the conversations around the bipartisan prescription drug bill that we're also hearing today stem from a previous Senate Democratic bill from last year. And so that a lot of that language is in SB 11 now, as well as additional measures to control the cost of prescription drugs. And so that wouldn't happen were it not for the strong support of Senator Looney and Senator Duff. I did also, additionally, we're also working to raise Medicaid rates this year. Senator Looney, when you mentioned your work here as a freshman state representative in 1981, is that what you said?
81 and 82, yes.
Yeah, we have raised Medicaid rates since then, but not
Not a lot, right?
not that recently.
No.
So we have work to do. So probably a lot of the same issues then as now, and it's just been a pleasure to work with the two of you, and we're hoping to get as much of this into law as possible. So very grateful to you both.
Thank you, Mr.
Thank
Chairman.
you. Thank you.
Madam Chair.
Wonderful. Thank you so much. Have a great rest of your day.
Great.
Next, we'll hear from Karen Namaya, followed by Jim McCollum.
Good afternoon. My name is Karen Amaya, and I'm the Director of Annual Giving at Fairhaven Community Healthcare, a federally qualified health center in New Haven. Thank you in advance for your support and for the opportunity to tell you our story about House Bill 7191. Fairhaven Community Healthcare has been the cornerstone of Fairhaven Community for 54 years, not only in its role as a health center, but also as it supports the community in so many ways. And since we opened our doors in 1971 for 3 days a week to support women and children. Today, we stand strong with 20 locations in the greater New Haven area. And as ever, we are dedicated to providing accessible healthcare services to the individuals in our community, currently caring for over 36,000 unique patients annually. To put a frame around who we care for, let me give you a snapshot about our patients. Over 90% of them self-identify as minorities, and nearly 70% are Medicaid recipients. In comparison to all of Connecticut, a state where 2 in 10 residents are on Medicaid, this means 7 out of 10 Fairhaven patients rely on this critical state-funded program. For far too long, Connecticut Medicaid has been out of compliance with federal law, which mandates that states reimburse health centers based on allowable costs. Given that our neighboring states, such as Massachusetts, New York, Rhode Island, and Maine, manage their programs within compliance, it is particularly distressing that Connecticut, a state currently with a budget surplus, be providing health care faced with a challenge such as this. To put a finer point on it, a recent Department of Social Services Medicaid rate study identified that the average Connecticut health centers receive 75 to 80 cents for every dollar of fees received by health centers in neighboring states. That's 25% less than our New England peers. Looking through a wider lens, embarrassingly, Connecticut's Medicaid reimbursement rates to health centers is the lowest in New England states, the lowest in the Northeast, and places Connecticut in the lowest third of state reimbursements across the country. I think we can all agree that the residents of the great state of Connecticut deserve better. I know that our patients deserve better. Under the current Medicaid rate plan, each day we open our doors, and right now that's 6 out of 7 days a week, our health center loses over $100 or more on each Medicaid visit, with the actual dollar amount varying based on the type of visit.
Your time is complete. Please summarize.
Because we rely on this heavily, must rely heavily on grants, which are bound by time or use restrictions, and gifts from grant foundations and donors, which is my area, offer cash infusions of various sizes, but only one gift at a time. And this support only allows us to take care of things on an as-needed basis, but does not provide long-term sustainability and growth. Ensuring that health centers are paid with in compliance with federal law is key to providing essential access to healthcare for so many of the Nutmeg state's residents. Federal threats to health center funding and to Medicaid, together with the increased demand we are seeing in our practice, put additional strains on our ability to provide excellent healthcare given the low reimbursement rates. Fairhaven Community Healthcare remains committed to our mission and to serving our committee, but we can't do it in a vacuum. It is critical and well overdue that Connecticut's Medicaid rates reflect the true cost of care. Today, I join with 15 of my Fairhaven colleagues who have taken time away from patient care because this is so important, and those from FQHCs around the state to urge you to support this crucial bill. I thank you for your time and consideration.
Thank you very much for your testimony. Are there comments or questions? Hold on one second. We got to ask the members if they have any questions. Are there comments or questions from members of the committee? Okay, now you can go. Thank you so much. We look forward to continuing to work with you and the team member. Next up, we have Jim McCollum from the Center for Disability Rights, followed by Kathleen Garrity from the State Dental Society. Is Jim around? No Jim. Kathleen? Kathleen is online. Kathleen, you have to unmute. Great. Hi, Kathleen.
Thank you, Senator Lesser, Representative Gilchrist, and members of the Human Service Committee. I am Kathleen Garrity, Executive Director of the Connecticut State Dental Association, and I am privileged to represent the oral health care providers in our state. I'm here today to express our strong support of SB 7191. I appreciate the committee's continued work to address Medicaid reimbursement rates and pursuing the goal of ensuring adequate and sustainable rates for healthcare providers, including dentists. As I have done often when I appear before you, I would underscore to the committee again today the unique challenges involved in setting dental Medicaid rates. Since most dental procedure codes are not covered by Medicare, it is unreliable as a reference point for dental reimbursement. While I appreciate the effort to compare Connecticut to peer states such as Maine, Massachusetts, New Jersey, New York, and Oregon to determine rate increases, I would like to emphasize that each of these states uses different methods to set dental rates, methods that are often shaped by their own state budgets, cost structures, and policy decisions that do not necessarily reflect the realities of providing care in Connecticut. A far more accurate and sustainable approach for dental rates would be to use Fair Health, a nationally recognized independent database that provides real claims data, including dental procedures. Fair Health data can be broken down by zip code, allowing Connecticut to set rates that reflect the true cost of care in different parts of our state. This ensures rates are based on what dental providers actually are going to be paid, not what neighboring states decide to pay under unrelated systems. This issue is particularly urgent because dental providers across Connecticut are seeing an increase in cavities and dental disease, particularly among children ages 6 to 11. Without fair reimbursement rates, fewer dental providers will participate in the program, further limiting access to care for the families who need it most. We are already seeing this impact at community health centers, which are reducing dental services due to low Medicaid reimbursement rates. For example, Community Health and Wellness Center ceased dental care at the end of February this year, citing a $350,000 loss of major procedures last year. Also, Staywell Health Center has halted costly procedures like crowns and root canals, which are necessary for oral health. These cuts affect over 400,000 residents who rely on these centers, with more than 60% of those being covered by Medicaid. Using Fair Health to set dental Medicaid rates would also create a predictable, data-driven process for updating rates in the future. It removes the uncertainty that comes from trying to compare to other states whose systems and policies may change unpredictably. Fair Health provides a stable, transparent, and objective method to ensure rates keep pace with the actual cost of providing care. I encourage the committee to support Raise Bill 7191 with the recommendation that Fair Health data be the primary source for determining dental Medicaid rates. This change will strengthen the sustainability of Connecticut's Medicaid dental program while protecting access to care for vulnerable patients. Lastly, we are increasingly concerned that the imposition of tariffs on vital dental supplies coming
Time is complete. Please summarize.
will increase and compound the problem. The economic burden caused by these extra duties on dental devices and products will add to the increased cost of healthcare and thus negatively impact patient access to care. Any delays to dental care leads to greater problems in overall health, and these tariffs are a looming factor that will limit patients their ability to afford essential oral health care. Thank you for your time and consideration.
Thank you, Kathleen, and thank you for your suggestions. I'll be sure to go back and look at your testimony.
I appreciate it. Thank you.
Any questions? Have a great afternoon. Next is Tom Swan, followed by Emmanuel Martinez Alcaraz. Is Tom with us?
Mr. Swan is not accepting his promotion to panelist. Oh, he just did.
Okay.
Hello?
Hello, go right ahead.
Okay, thank you very much. I had not seen the panelists pop up. Senator Lesser, Representative Gilchrist, distinguished members of the Human Services Committee, my name's Tom Swan. I'm the Executive Director of the Connecticut Citizen Action Group, and I'd like to comment and offer our support for 4 bills before you today. SB 11, an act concerning prescription drug access and affordability. HB 7192, an act implementing the recommendations of the Bipartisan Drug Task Force. SB 1479, an act concerning arbitration in healthcare. SB 1480, an act concerning private equity and real estate investment trust ownership of hospitals and nursing homes. I'm going to try to be quick today, both because I know you've had a very long day, but also I got kid pickup, so I'm going to move. We strongly support Senate Bill 11, as it is arguably the most comprehensive approach to healthcare before the legislature this year. Sections 1 to 5, implementing a reference drug pricing program on prescription drugs, is sorely needed. The Council outlined in Section 6 can play an important role in driving down drug costs. The increase in asset limits for Husky C, I believe that is in Section 9, is long overdue and the right thing to do. We support Sections 10 and 11, but have to say it's outrageous that a bill like this is needed at this time, that people have to have legislation to get anesthesia. We strongly support Section 12. Stop loss insurance has played a major role in destabilizing the small group market and leaves many patients with a false sense of security. These are important consumer protections, and we urge its adoption. It's telling that the opponents are arguing against covering essential health benefits as an unnecessary, costly mandate. It's one of the best reforms that came out of the Affordable Care Act. I would like to take a few seconds of your time to talk about sections 13 to 15. The drugs outlined here have had a tremendous impact on people's health. The process here outlined here for trying to get lower cost reminds me of an effort several years ago in Louisiana, where there was a deadly outbreak of hepatitis C in their prison system. The drugs to stop the outbreak were very costly, meaning that many people were unnecessarily dying and that the whole state population was going to be put at risk. The Commissioner of Public Health in Louisiana had similar powers as outlined in this bill. She announced she was going to invoke her powers that forced the manufacturers to table where the prices were negotiated to a much lower level, saving lives and the state a great deal of money.
Your time is complete. Please summarize.
Okay. Want to commend you all for 7192, the bipartisan nature in addressing PBMs, much overdue. The task force did a great job, worked really hard. 7149 is a great patient protection bill in terms of in terms of protecting consumers on a more level playing field and patients. And we support SB 140, and elders will say how Prospect Healthcare has proven the need for this important bill. Thank you, and I'll stop there.
Thank you, Tom, and thank for your continued advocacy. I don't see any questions. Good luck with kid pickup.
Bye.
Next, we have Emmanuel Martinez Alcaraz, followed by George Curry.
Thank you for the opportunity to provide support to the House Bill 7191. My name is Emmanuel Martinez Alcaraz. I'm the Director of Clinical Quality at Fairhaven Community Healthcare in New Haven. Today, I'm testifying to support for this proposed Bill 7191 to urgently fix the insufficient Medicaid reimbursement to FQHCs. At Fairhaven, we serve thousands of patients, many of whom face challenges of poverty, food insecurity, and unstable housing. With each passing decade, we've worked to expand and better integrate our services, offering comprehensive primary care, behavioral health, dental care, school-based care, and substance use treatment for our community. I chose a career in community health center to practice medicine for all patients as a team with mission-oriented coworkers. Across the country, FQHCs form the largest and most cost-effective primary care network, and our clinical quality is comparable and sometimes exceeds those in private care, due to our commitment to integration and coordination of care for our patients, which allows us to provide this excellent high-quality care for our most marginalized and medically complex patients of our state. However, Medicaid in Connecticut doesn't fully cover the cost of their care, and I'm deeply concerned that inadequate Medicaid funding combined with policy changes from Washington threatens this high-quality care we can provide to our beloved residents of our state. As a primary care doctor, I care for over 1,500 patients of all ages, from children to the elderly. And for me to provide the best care for these patients, I need to co-manage patients with dentistry, school-based providers, behavioral health specialists, who are also under-reimbursed for their care. This firsthand experience paints my view of the immense impact and sense of stability that Medicaid has on their lives. In the setting of rising social needs and challenges, thoroughly already discussed today by committee members and other panelists, I think prudent investment in this vital safety net health insurance program directly impacts patients' ability to maintain stable employment when they're able to, and to keep housing. Furthermore, improving the reimbursement after years of stagnation will help FQHCs like Fairhaven be able to retain and recruit more providers to meet the increasing health needs of the state of Connecticut. I strongly plead the Connecticut General Assembly to pass HB 7191 into law to ensure that the Department of Social Services can fulfill its mission and that community health centers can finally rely on Medicaid funding, providing parity to other payers and stability for the primary care healthcare system of Connecticut. Thank you for your time and happy to answer any questions.
Thank you so much, Dr. Martinez Alcaraz, for being here and for your testimony. I don't see any questions. Have a great afternoon.
You too.
Next is George Curry, followed by Brian Lynch.
Can you hear me?
Yes, we can. Go right ahead.
Good afternoon, Senator Lesser and Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Dr. George Curry, and I am here on behalf of the Connecticut Chiropractic Council and urging your strong support for House Bill 7191 as it pertains to Medicaid rate increase for chiropractic services across our state. Many Medicaid recipients rely on chiropractic care to manage pain, improve mobility, and maintain their quality of life. Adequate reimbursement rates would make it financially viable for chiropractors to accept Medicaid, which is now really not currently the case. I happen to practice in Windsor, Connecticut, and I've done so for 43 years. And I'm the exception, not the rule. I've accepted Husky and Medicaid patients for years and years and years. And some of the doctors who come out and graduate college today with high student loans, they at a reimbursement rate of $17 a visit, they just can't take the loss. And chiropractic care is an essential part of helping the community with things like neck pain and low back pain, as you all probably know. Cost-effective treatment options such as for musculoskeletal pain, like neck and back pain, is one of the most common reasons for Medicaid visits. This includes studies at Yale University that showed there's a marked reduction in opioid use for people who utilize chiropractic care first. Increasing reimbursement can reduce the need for more expensive care like surgeries and long-term pharmaceutical use. Studies have shown that early chiropractic intervention for back and neck pain can lower overall healthcare costs, reducing emergency room visits, hospitalization, and opioid use. I could tell you that at least once a month I have a patient who has suffering from some type of a low back condition, and we're able to help that patient and help them avoid physical therapy and surgery. And they'll say to me, "Hey, I've got a cousin who's in Bristol, and can you recommend a chiropractor who can help them?" And there isn't any Medicaid providers in Bristol because there's very few. With the reimbursement rates as low as they are, I understand why there's limited enrollment in the program. So we very much support this initiative to bring the Medicaid rates. What's for chiropractic? It's been 3 decades since there's been an increase. So we very much support this, and we appreciate your time and allowing me to testify on behalf of the Connecticut Chiropractic Council this afternoon. I'm here for any questions.
Thank you so much, George. I don't see any questions. Thank you for being here and for your testimony.
All right, thank you.
Next, we'll hear from Brian Lynch, followed by Neil Garland.
One moment, there's a technical issue with the panelist promotion.
Okay, am I on?
Yes, you are. Go right ahead.
Great. Good afternoon, Senator Lesser, Representative Gilchrist, members of the committee. I'm Dr. Brian Lynch. I'm an optometrist practicing in Brantford, Connecticut for just a few years, as you can tell by my gray hair. And I'm here to comment on House Bill 7191. You have my written testimony. What I'd like to do, with your permission, is to paraphrase it to shorten up your afternoon. Both nationally and here in Connecticut, optometrists are the Medicaid providers for primary eye care. 70% of the eye care delivered to the Medicaid population is through optometric offices. We co-manage their diabetes disease alongside their primary care docs. We care for their glaucoma, eye infections, other eye diseases, as well as providing routine eye care. Also, helping out in emergent situations to take care of those emergent eye injuries that otherwise would overburden our emergency rooms. Last fall, I requested a survey of the Connecticut Association of Optometrist members to see how many actually participated in the Medicaid plan and were accepting Medicaid patients. 89% of our members currently accept Medicaid. In 20% of the offices that were surveyed, they had admitted that Medicaid made up 50% or more of their typical patient load, and 5% of them, 75% of the patients, were Medicaid. That means 9 out of 10 optometrists are doing the right thing by accepting Medicaid patients. Department of Social Services data for fiscal year 2024 showed that optometrists saw 119,000 non-duplicated visits, for which they were reimbursed $13.1 million in that same year. Despite our commitment to this underserved community, a Department of Social Services regulation is in place that devalues our service. Optometrists are only reimbursed 90% of what our ophthalmological colleagues are paid when billing for the same procedure using the same CPT codes. No other payer, Medicare, Blue Cross, Cigna, United, differentially reimburses providers. I believe that in House Bill 7191 or proposed House Bill 7091, lines 21 to 31, where their intention was to establish parity between providers. Unfortunately, this does not resolve our problem because of this regulation that speaks to optometrists only being reimbursed 90%, which is why I've attached proposed language to fix this inequity. We are proposing the same fix that was used to remediate the problem between the nursing midwives and the OB-GYNs, as well as the podiatrists and the orthopods. ODs have always been there on the front lines, caring for Medicaid patients. We're not providing our patients with 90% of the care that they deliver.
Your time is complete. Please summarize.
So that's why I would like you to accept the suggested language as a fix for this problem. Thank you very much.
Unfortunately, we've lost your audio. Maybe speak closer. I don't know.
Am I back?
Yep.
There we go. Our hope is that you will accept the proposed language that I've attached to my testimony to fix the inequity that exists between optometry and ophthalmology. As I had shared, we are not providing our patients with only 90% of the care they deliver, but we're giving them, I could arguably say, 100% plus.
Well, you've made very strong arguments. In particular, I like that last one. Thank you so much.
Thank you very much.
Have a great afternoon.
You also.
All right. Next is Neil Garland, followed by Jim Schmerling. Is Neil with us? Okay. Jim Schmerling, go right ahead. Jim, I see you on Zoom. Yep, there you go.
There we go. Thank you.
You're welcome.
Senator Lesser, Representative Gilchrist, members of the Human Service Committee, thank you for the opportunity to share my thoughts on House Bill 7191. My name is Jim Schmerling, and I'm the president and CEO at Connecticut Children's. We're grateful that the committee raised this bill because the status quo is unsustainable. We're experiencing a financial crisis that is precipitated by Medicaid underpayment, and I detailed our need for Medicaid parity in testimony that I submitted last month. We're proposing this change because Medicaid rate parity is not the same as payment to cost parity, cost ratio parity. Caring for kids in a hospital setting requires more staff, more time, and more services given the size and age range of our patients. All of these additional inputs result in more cost, which is why paying the same rates does not lead to parity in the percentage of costs that are actually covered. In fact, given the higher costs in pediatric medicine, paying pediatric providers the same rates as adult providers could result in pediatric Medicaid payment cost ratios getting even worse. Although pediatrics is generally more expensive than adult medicine, Connecticut Children's is not expensive compared to our children's hospital peers. In a report published by Goldman Sachs last year, Connecticut Children's cost per adjusted discharge was the 5th lowest out of 38 children's hospitals and 22% less than the median. Now, some may say that Connecticut Children's does not need improved Medicaid rates because our base rate for inpatient care is already one of the highest in the state. This statement is misleading and neglects the fact that the base rate is not inclusive of costs associated with services provided by our medical staff, which are actually paid by the hospital. I would like to share some thoughts with you about the Medicaid rate study and its applicability to pediatrics. This rate study proposes a five-state rate benchmark for services that do not have corresponding Medicare rates, but we don't believe that this offers a meaningful metric for comparing pediatric payments. While the study addressed hospital payments for pediatric stays in children's hospitals, the report appears to have only analyzed published fee-for-service rates. As I noted in my submitted testimony, most children who live in the study's comparison states participate in managed care arrangements. Providers can often negotiate higher rates and supplemental payments with managed care plans, so the study findings likely do not offer a true comparison of the total payments that pediatric hospital providers receive. Connecticut Children's Medicaid results lag those of the average children's hospital nationally, but that discrepancy grows significantly when supplemental payments are included. In 2024, Connecticut Children's Medicaid system results show that we receive less than 60 cents for every dollar that we spend on care. The average children's hospital received more than 82 cents with all supplemental payments included. Since the study analysis excluded supplemental payments, the benchmark approach will understate total payments in the comparison states, and thus it cannot effectively assess the adequacy of pediatric hospital payments.
Your time is complete. Please summarize.
Children deserve the best that we can give them. A more equitable investment in their safety net is an essential first step toward transforming children's healthcare delivery, promoting each child's optimal healthy development. Please support Medicaid cost coverage parity for Connecticut Children's to help ensure that all children have access to healthcare services that they deserve. Thank you.
Thank you so much, Dr. Schmerling, for the important work you do and for testifying today.
Thank you.
Have a great afternoon. Next, we'll hear from Adrian Benjamin, followed by Kathy Zoll. Is Adrian with us? I don't know. Okay, going on to Kathy Zoll, followed by Heidi Lubchikin. Sorry.
Good afternoon, Representative Gilchrist and all the committee members. My name is Kathy Zoll, and I am the Executive Director of the New London Homeless Hospitality Center. We have been working with CHESS since its inception and continue to do so today, and I appreciate the opportunity to testify before you in support of HB 7188, an act concerning homelessness and the CHESS program. CHESS represents a bold attempt to wade into the challenge of translating research on the link between housing and health outcomes into a workable program that moves the needle on these health outcomes. This has been a challenging process, and the DSS report provides an excellent analysis of the issues encountered. The key question, however, is whether these challenges are opportunities to learn and revise or cause to give up on CHESS completely. I would like to propose additional consideration of the possibility that we can learn, revise, and continue this critical work. First, I think it's so important to celebrate that the DSS report documents that housing impacts healthcare costs. In the 12 months post-housing, healthcare costs for the housed cohort in CHESS declined by 14%, or over $1 million in less healthcare costs than the previous 12-month period. In other words, housing works as predicted to reduce healthcare costs. The DS report does a very effective job of documenting the very significant challenges that were faced, however. Many of these challenges are reported with CHESS are tied to the initial decision to include a housing voucher with CHESS services. Clearly, continuing CHESS with the assumption of a housing voucher is not viable. A key question, however, is whether providing a housing voucher is the only way to help CHESS participants access housing. Our program at HHC currently has about 50 enrollees. Half of them have vouchers. An additional 40%, however, are no longer experiencing homelessness, but they are not counted as housed in CHESS. With our CHESS staff's help, they were able to secure at least some income and are housed in shared housing with family or friends or in setting like sober houses. Clearly, anyone in this 40% would prefer a voucher that allowed them to access their own apartment. But like so many other very low-income households, they are finding housing options that provide a stepping stone to better housing as their income increases. Given the reality that addressing the affordable housing crisis will take a significant amount of time, couldn't it make sense to consider redesigning CHESS requirements to recognize that for many, their next housing option may not be their own apartment, but some other type of housing that is a cost-effective stepping stone?
Your time is complete. Please summarize.
Second, on administration, we're extremely grateful to all the help from DSS staff, but we now feel that CHESS is manageable. But finally, the financial challenge. CHESS was designed based on value-based payments tied to housing. With the lack of housing vouchers and the inability to count other kinds of housing, achieving the value-based payments has been very difficult. That leaves providers to rely only on the hourly rate, and that rate is currently too low. But wouldn't it make sense to consider raising the hourly rate to make participation more effective, more attractive? The DSS report on CHESS shows a cost of $1,000 per person per year for services. That compares with almost $9,000 a year provided for services in our DEMIS contract.
Kathy, I am going to have to ask you to summarize. Sorry.
Okay, sorry. So I'm just hoping we can find a way to continue to work with this important program. Thank you for your time.
Thank you. Did you submit written testimony?
Yes, I did, which goes into much more detail.
Okay, fantastic. Thank you so much. This is greatly appreciated. I do see Senator Lesser has his hand raised.
Thank you, Madam Chair. And Kathy, I'm not sure if I don't know if you heard my back and forth about this provision this morning with the commissioner. Specifically, I was raising the question about whether or not if we align the eligibility and reimbursement standards with the existing DEMIS supportive housing program, would that be a way for us to potentially serve the people currently in that program and also, you know, make the program really be able to sustain itself? Would that be a model or approach that you might welcome? I know there'd be a lot of details that would need to be ironed out to support the current providers.
Okay, so I think the primary issue that the DEMIS programs are based on a very valid model for people with very high mental health needs. I think we want to remember, though, that CHESS is focused not just on that population, but also people with health-related issues that are impacted by housing. So I honestly believe as important as supportive housing that DEMIS does is, CHESS could be something different. And I think the opportunity for CHESS to reach a broader population of people with very expensive health issues that would be addressed by having housing, I think that's where there's a tremendous opportunity for savings. And so I think we should be thinking about a model other than, in addition to, permanent supportive housing as DEMIS currently operates it.
Okay, that's very helpful. But the challenge, I guess, is that DSS has failed to identify a source of the federal match that would allow that to work. So do you have thoughts about that? I don't know. I think you're right. I mean, I see excess, just the impact on our hospital system of folks with healthcare needs who are unhoused is pretty enormous. So there's got to be a way to book that, but I just didn't know if you had thoughts about how to actually do that as we go forward, and some of us are on appropriations and trying to figure out how to stand this up.
Yeah, I put more detail into my testimony, but there are ways to help people get housing, and that's why I was trying to say 40% of the people in our CHESS program are no longer homeless. They're not housed in the way that CHESS defines it, but they are no longer homeless. And so I feel like we need to be thinking about creative other ways. And I want to say many other states that are addressing the same problem have done it with a more flexible approach to thinking about how to help people access housing.
Okay, great. I will take a look at your written testimony, and I really appreciate your thoughtful support of this program.
Yes, thank you so much. Very helpful to have your experience. All right, have a great afternoon. Next is Heidi Lubitkin, followed by Lacey Whitmire.
Hi, good afternoon. Can you hear me?
Yes, we can.
Very well. Good afternoon, Honorable Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Dr. Heidi Lubetkin. I'm the Vice President of Clinical and Senior Services for the Community Renewal Team. Thank you for the opportunity to present my testimony today regarding Bill 1471, an act concerning a pilot program to provide a community-based memory care program aimed at establishing a pilot program for a community-based memory care initiative. CRT is the designated community action agency serving Hartford and Middlesex counties. We are very proud to operate the Retreat Assisted Living in Hartford, the first of its kind in Connecticut, to offer an affordable assisted living community. The Retreat has been operating for over 20 years, all of which I have worked since its inception. The Retreat features 100 apartments, offering a mix of studio and one-bedroom layouts, all equipped with private bathrooms, step-in and roll-in showers, kitchenettes, 24-hour emergency response system, and on-site medical services. The eligibility for the Retreat is blended from 2 different programs, low-income housing tax credits and the Connecticut Home Care Program for Elders. Today, we seek to partner with the state of Connecticut to develop a groundbreaking model for assisted living services specifically tailored for individuals living with dementia or memory impairment. Connecticut is an aging state without enough facilities or people to take care of this older adult population. As you may know, there currently is no option in the state of Connecticut for low-income residents seeking subsidized assisted living services with memory impairment. As highlighted in the proposed bill, effective July 1st, 2025, the Commissioner of Social Services will develop a 2-year pilot program to provide a subsidized memory care program for low-income older adults in Hartford, with the intent to replicate other areas in Connecticut. We support this initiative as we think it is crucial for supporting low-income individuals with this need. We believe the Retreat is an ideal candidate for this pilot for individuals facing memory care challenges who are aging in place. Here in Connecticut, low-income elders don't have the services or care available to them. Only people with higher incomes are able to afford this luxury. By creating a dedicated memory care floor within the Retreat, we can offer 20 apartments specifically designed to support individuals, rather than relocating them to a costly skilled nursing facility. The design of this separate floor will address the unique barriers experienced by this population, incorporating safety features, a controlled environment that minimizes risks, and promotes security within an established assisted living facility. The layout will include secure entry points, clear signage, and spaces that foster cognitive engagement while reducing confusion. Staff trained in memory care would be available around the clock to provide aid and support, ensuring that residents are well cared for. This model not only promotes dignity and quality of life for older adult residents,
Your time is complete. Please summarize.
But also represents a significant cost savings for measures rather than placing them in skilled nursing facilities. The bill emphasizes the importance of compliance, maximizes resources, and we are eager to contribute to it. By investing in this community-based memory care pilot program, the state can realize substantial savings while ensuring that older adults with special care needs can be in the environment that fosters their well-being. Further, the bill calls for the establishment of a working group.
Please summarize, sorry.
Yes, ma'am. That can establish, a working group that can help to promote stakeholders and create a pilot program for a subsidized assisted living that currently does not exist in the state of Connecticut. Thank you.
Thank you so much. And I do see Senator Lesser has his hand raised.
Thank you, Madam Chair, and thank you for your testimony in support of this. So currently what happens for low-income folks who are in need of, this level of care, they're just required to go to an assisted living facility, to a skilled nursing facility. Is that correct?
Sure. So in the state of Connecticut, we have proprietary assisted living and we have some subsidized assisted livings through the demonstration pilot project. For individuals that have proprietary or have affluent funding, they can go to an assisted living facility that does have secured living in a specialized dementia unit. Currently, there is no subsidized assisted living facility for people of low income that can live in an assisted living with a secured unit. So at the Retreat in particular, people who are low income and then unfortunately have an aging in place scenario and have to move in order to protect wandering issues, they now have to go to a nursing home. Or individuals that are in the community who couldn't afford to go to a proprietary assisted living don't currently have an option to go to a subsidized assisted living where they can receive those services and prevent their wandering.
Got it. And have you had an opportunity to chat yet with DSS, or is that
We have had some very preliminary conversations, but I think that this bill here would help to foster that continued conversation in order to really just blend two programs that currently exist. That this is not a huge lift, but more so having an opportunity for low-income older adults to now have an opportunity to live in an assisted living whereby they can have a secured building, no longer wander in the community, and have options that they currently don't have.
Well, I appreciate that. I think it's up to us to determine what's a
Yes,
heavy
sir.
lift or not, but
Yes. I apologize.
no, but it does sound like a really interesting model and a conversation I'd love to have with the department and see if it's something we can, if it makes sense. But thank you so much for your testimony, and thank you, Madam Chair.
Thank you, Senator. Thank you, Doctor. Have a great afternoon.
Thank you. To you as well.
Lacey Whitmire, followed by Stephen Colagnolo.
Hey there. Can you hear me, Representative Gilchrist?
Yes, go right ahead.
Okay. My name's Dr. Lacey Whitmire, and it's a pleasure and a privilege to address y'all today in support of House Bill 7191. I'm here as a primary care physician in Connecticut. I work at Fairhaven Community Healthcare in New Haven at an FQHC. I see newborns through adults. My oldest patient is 99 years old. Medicaid cuts will destroy what we do. So I'm a Harvard trained, Yale trained, UC Berkeley trained physician. I'm double boarded in internal medicine and pediatrics. And people ask sometimes, why do you work where you work? Why do you do what you do? And I learn as much from my patients as I have at those hallowed institutions. And I get to change people's lives every day in primary care, regardless of their ability to pay me for my services. Cutting Medicaid destroys that. Primary care is not glamorous. Primary care is not high paying. Primary care takes care of the most vulnerable people we have in Connecticut. It's a moral and ethical decision to work where I work and do what I do. And I want the people of Connecticut and the legislators on the call to understand that it is a moral and ethical choice to cut Medicaid. We already have lower reimbursement rates than our neighbors in New England and the Northeast. We are one of, if not the wealthiest states in the wealthiest nation on earth. It is a moral and ethical decision that sits before you to promote and protect the work that myself and my colleagues do every day. The children we share with the children we treat, the adults we treat, they are the same as you and I. They have less money. My belief and the beliefs of all the physicians that I work with is that healthcare is a human right. So I think especially in these times, it's an incredible moment for Connecticut to make the right choice and say, we agree, we have the ability to make this choice and stand up in these troubling times as a healthcare worker and say, we actually do care about those that simply have less money than others. That's what Medicaid does. It protects the futures of these kids and it makes the present of these adults healthier and, more economically available to work. All of the things that make Connecticut a good place, to live and be. So again, I'm open to questions, but that's my assertion for the group today. Thank you for your time.
Thank you so much, Doctor, for your work and for being here. I don't see any questions. Have a great afternoon.
Take care. Bye-bye.
Next is Stephen Colagnolo, followed by Dr. John Satterfield. Is Stephen with us? Okay. Dr. John Satterfield, followed by Dr. Frank Vesey.
Board Chairs Gilchrist and Lesser, distinguished members of the Human Service Committee, thank you for the opportunity to testify today. My name is John Satterfield. I'm a practicing anesthesiologist in Connecticut for the last 34 years, past president of the Connecticut State Society of Anesthesiologists, the chairman of the CSSA Advocacy Task Force, and a longtime resident of Southington. I'm here to request that you increase Medicaid rates paid to Connecticut anesthesiologists. We have not had a rate increase since 2006, and every hospital patient that comes to a hospital in Connecticut, regardless of their ability to pay, is treated by an anesthesiologist. First and foremost, let me begin by explaining the current ongoing issue anesthesiologists face with Medicare. Tying any form of reimbursement to the Medicare system is flawed. The Medicare system is broken for us. In the process of developing the Medicare payment methodology almost 40 years ago, a tragic calculation error was made, and it is now well recognized that anesthesia services are woefully underpaid. Physician specialties typically experience Medicare payment rates that are about 20% lower than their average commercial rates. In 2007 and again in 2020, the Government Accounting Office, the GAO, found that anesthesia payment rates to anesthesiologists from Medicare were 70% lower than commercial rates. And today, that number is actually closer to 75% below commercial rates. Even an adjustment to 300% of Medicare rates for anesthesia services would represent a significant underpayment, one that is well below the cost of providing anesthesia care. Furthermore, the AMA has identified that when adjusted for practice costs from 2000 through 2025, the real value of Medicare payment to all physicians has decreased by 33%. I use all this information to highlight the fact that underpayment by Medicare to anesthesiologists is only compounded by current Medicaid reimbursement rates in Connecticut. Kindly review all the supporting information in our written testimony. It provides very valuable and factual data. On behalf of the CSSA, I respectfully request that you adopt our proposal to increase Medicaid rates. Please understand that even if anesthesiologists are paid at Medicare rates, this still represents a significant underpayment and will not cover the cost of providing anesthesia services to Medicaid patients in Connecticut, but we will still be in the hospitals taking care of them. Regardless, a rate increase is a reasonable step in the right direction. Thank you very much.
Thank you very much. And I will be sure to go back and look at your testimony. Thank you for providing that information.
Thank you.
Next is Dr. Frank Vesci, followed by Natalie Shirtlip.
Good afternoon, Senator Lesser and Representative Gilchrist. I'm Dr. Francis Vesci, a chiropractic physician practicing in New Britain, and am representing the Connecticut Chiropractic Association today to comment on House Bill 7191, an act concerning Medicaid rate increases, planning, and sustainability. The chiropractic physician treating a Medicaid Husky patient will typically bill the CPT code corresponding to a 1 to 2 area spinal manipulation or a 3 to 4 region spinal manipulation. These codes are reimbursed by Medicare at $23.14 and $35.60 respectively, while Medicaid Husky reimbursement is $15.12 and $20.72 respectively. As a result of this low reimbursement, chiropractic physicians in the state are reluctant to become participating physicians in the Medicaid Husky program or have disenrolled from the program altogether. We appreciate that as drafted, House Bill 7191 will phase in an increase in Medicaid reimbursements over 3 years up to 75% of the Medicare rate. The CCA would also like to comment on Section 3 of Senate Bill 1474, an act concerning the Department of Social Services. This provision will have Medicaid prescribers become familiar with alternative to opioid drugs in the treatment of a patient's pain. We support this change. An August 2022 study published by Canadian researchers in the Journal of Manipulative Therapeutics found that patients with non-cancer spinal pain who underwent chiropractic care were less likely to obtain a prescription for opioids than those who did not. Additionally, a 2020 study published in Pain Medicine showed that patients with spinal pain who saw a chiropractic physician had half the risk of filing an opioid prescription. Further, if the patient sought chiropractic care within 30 days of diagnosis, the risk reduction was greater as compared to those with their first visit after the acute phase. Right now, the role of chiropractic in providing non-pharmacologic strategies for pain reduction is recognized in section 20-14S of the general statutes. We believe additional language in section 3 will make it more effective. Our suggestion as follows, new text beginning on line 63. Prescribers may consider the options for referring or prescribing appropriate non-opioid treatment alternatives that shall include but are not limited to medications, restorative therapies performed by a chiropractic physician or other appropriate medical professionals. Thank you for considering the views of the Connecticut Chiropractic Association.
Thank you, Doctor, for being here and for your testimony. Have a great afternoon.
Thanks.
Next, we'll hear from Natalie Shirtliff, followed by Liz DuPont-Deal.
Good afternoon, members of the Human Services Committee, Representative Gilchrist, Senator Lesser, and thank you for having me here today. My name is Natalie Shirtliff. I am an Associate State Director with AARP Connecticut. So we submitted extensive written testimony, and so on many of the bills on today's agenda, but today I'm going to focus primarily on my spoken testimony on addressing the high cost of prescription drugs, as well as the Medicaid asset limits for Husky-C. So we know that the high cost of prescription drugs is a major barrier for so many people in Connecticut. It's one of the primary concerns that we get from AARP members. We hear often stories about individuals that are not able to afford their prescription medications and often have to make really difficult decisions. Do I refill my medication, or do I pay rent or buy food? Do I not take my medication as prescribed? Do I try to spread it out so that it lasts longer so that I can better afford it? And all of these decisions are because the cost is so high. And we know that if people aren't able to take their medications as prescribed, it ultimately can lead to some really negative health effects. I mean, even it can be deadly if people aren't able to take their medications as prescribed. And it can also lead to other health expenses down the road and kind of be short-term savings. So there are a number of provisions in both Senate Bill 11 and House Bill 7192 that we support. I'll highlight a few of them. So we support state importation of prescription drugs. We know that drugs in other countries, including Canada, are much cheaper than they are here in the United States. And we know that we already live in this world with a global supply chain. Most of our drugs are already imported from other places. So allowing a program where we can purchase wholesale drugs from Canada would put downward pressure on the price of drugs in Connecticut. We also support some of the efforts within those two bills that would increase transparency. One provision would limit increases on drug prices.
Your time is complete. Please summarize.
Yep, to the rate of inflation. We definitely support that. We support the provision that would restrict pay for delay provisions. So like I said, there's a lot more detail within our testimony, but I really just wanted to highlight the need for us to do more and to continue to do more to address the high price of prescription drugs.
Thank you so much, and thank you to AARP for being such a strong partnership, partner in this, and doing so much to reduce the price. So thank you for your testimony. We'll be sure to take a look.
Thank you.
Have a great afternoon. Next, we'll hear from Liz DuPont-Deal, followed by Rick Bachman. Is Liz?
I my camera's not working. Can you hear that?
We can hear you and you can go
Great.
ahead. Yeah.
And I don't have a snazzy little picture. My apologies. Good afternoon, Lester, Representative Gilchrist, and esteemed members of the committee. My name is Liz DuPont-Deal. I'm the Associate Director of the Connecticut Citizen Action Group, CCAG, and our members work to make Connecticut a more fair and just place. I testify on behalf of our thousands of member families. Our Executive Director, Tom Swan, has already testified for CCAG on SB 11, SB 1480, and 1479, and 7192. We submit additional testimony in support of several bills. SB 1470 and Act concerning Medicaid reimbursement for community health workers. Community health workers have proven to be a critical element of healthcare delivery, helping people navigate confusing systems of healthcare, providing context and improving care and outcomes. SB 1477 concerning covered Connecticut Trust Fund was developed as an alternative to Medicaid coverage when people were pushed off it and on the exchange to save the state money. This appears to be an attempt to reduce harm to people on the exchange covered CT from the impending federal cuts to exchange subsidies, which we support, although a better, more efficient approach would probably be to just place those people back into the Medicaid program. 806, an act expanding Medicaid coverage for treatment of certain emergency medical conditions, would upgrade policies of emergency Medicaid by expanding conditions eligible for EMC to include treatment of chronic conditions in an outpatient setting, and allow people to apply in advance for an emergency Medicaid so they can receive outpatient treatment instead of waiting until their condition requires emergency room treatment. These updates will help make sure that Connecticut's uninsured residents, such as our undocumented population, have better health outcomes when facing life-threatening conditions. HB 7191, an act concerning Medicaid rate increases, planning and sustainability, would phase in increased rates of reimbursement to Medicaid providers over 3 years in accordance with the rate study commissioned by DSS to help ensure our family planning infrastructure is able to withstand incoming federal attacks on reproductive health care. Finally, we also support SB 805, requiring nursing homes to spend not less than 80% of revenues on direct patient care, which would require nursing homes to spend at least 80% of Medicaid, Medicare, and other funding on direct care, and SB 1469, an act concerning medical debt. Others have testified about the very challenging federal funding landscape, which requires its own response, but which makes it even more important that we make improvements such as those before you today. Thank you for hearing our testimony in support of these bills. Welcome to questions.
Thank you so much, Liz, for your testimony and your advocacy. Don't see any questions. Have a great afternoon.
Take care.
Next is Rick Bachman, followed by Adam Musinkas.
Good afternoon, and thank you for allowing me to testify. My name is Rick Bachman. I'm here on behalf of my 25-year-old daughter, Melanie. She weighs 236 pounds, is 5'2", and has a BMI of 41.8. You know, obesity has 3 classes, as you may know, 30, 35, and 40. I'm strongly in support of Section 13 of Senate Bill 11, and in opposition to Section 6 of the Governor's Senate Bill 1251. Obesity is an epidemic, widespread epidemic, not only in Connecticut, but in America. It is and will lead to a plethora of illnesses for both children and adults. To cover only persons with diabetes type 2, as the governor's proposal does, turns a blind eye to the nationwide and Connecticut problem. This is not a thoughtful approach. As the law stands today, people like my daughter who are pre-diabetic and have a BMI of 41.8 should be treated. In fact, DSS has not enforced the law as it stands today, denying coverage to all Connecticut residents with obesity issues. Senate Bill 11 recognizes this. You have heard and will hear from many people today, but they offer no individual stories. Let me tell you about my daughter, Melanie. She has suffered from 6 concussions, has short-term memory loss, has ADHD, has OCD, depression, PTSD, has been sexually assaulted, and was manipulated by a sexual predator online. Despite this, she graduated from the University of Hartford. Since graduation, she has developed agoraphobia, which is the inability to leave the house, and has spent 2 weeks at Yale Psychiatric Hospital for suicidal issues. Much of these latter problems can be attributed to her weight and her shame she has felt. Section 13 of Senate Bill 11 will allow her to get the treatment she so desperately needs. She receives psychiatric and therapy treatment weekly. The sponsors of Senate Bill 6 will tell you theirs is a thoughtful approach. I disagree. They tell you the drugs, Wegovy and Ozempic, are generally lifelong drugs. This also is not true. You can ask Oprah Winfrey if you can get her in here. In any event, it will be the generic equivalent that is given, and there will be a lesser cost as a result of that. If you have any humanity, and I think the people on your committee do, you will allow a vote, you will vote for Section 13, Senate Bill 11, to help as many people as possible, whether you are diabetic or like my daughter, or all persons who have a BMI of 35 or higher. They should be allowed to receive these life-saving drugs.
Your time is complete. Please summarize.
Well, I'm just going to say thank you. So that was it.
Perfectly timed. Thank you so much, Rick, for being here and for sharing your story and the story of your daughter. I'm sorry for what she's been through, but she's very lucky to have a dad like you.
Thank you.
And thank you for being here and testifying.
I would just say one other thing. I know the governor's bill offers more money for his diabetes only, type 2 diabetes only. I think you should take that part of his legislation and put it into SB 11, so even more people are treated.
Thank you. We will consider that.
Yes, thank you.
Have a great afternoon.
Yeah.
Next, we'll hear from Adam Musinkus, followed by Mark Schaefer.
Hi, thanks. Can you hear me?
Yes, go right
All
ahead.
Well, thank you, Representative Gilchrist, Senator Lesser, Senator Harding, Representative Case, and the members of the committee. My name is Adam Musinkus. I'm a doctor of podiatric medicine, and I practice here in the state of Connecticut. I also serve as the president of Connecticut Podiatric Medical Association, and I'm here to offer our comments on HB 7191 and that concerning Medicaid rate increases. Personally, I own a medical practice in Cromwell, Connecticut, and actually I'm one of the few podiatrists in my area who actually contracts with and accepts Medicaid assignments. I also provide on-call services through Middlesex Hospital, and through these two programs I interact with, and really pleased to help with a lot of those and serve a lot of those people in our community that are really underserved and underprivileged. That being said, I'm also a small business owner here, and the unfortunate truth is that Medicaid reimbursement rates are so low, and I know you've heard this time and time again as I've been listening today, that every time I see a Medicaid patient in my office, I lose money through the cost of overhead, staff, and supplies. In the past, I've been able to absorb those losses because the balance of payers was skewed towards higher reimbursing insurances. Unfortunately, there's so few practices left accepting Medicaid patients that my office became kind of overwhelmed with appointments and appointment requests for Medicaid beneficiaries, and they were coming from every part of the state. That balance got very, very skewed, and I have actually had to change my policies. I can no longer accept new patients through the Medicaid program. It was just impacting me too much financially at that point in time. So truly with this, in order to stay financially solvent, increasing the fee structure would not only allow me to open that back up and see people, but it would also allow other practices to do that. So no one practice is completely overburdened by seeing all of those people. And I don't want to say that seeing the people is not the burden. The burden is figuring out how to pay the bill. Seeing the people is what we do this for. This is why we do this. It's what we want to do, is make people better. And so we appreciate that, as drafted, HB 7191 would increase reimbursements for Medicaid And really insufficient reimbursements really characterize the program in the state of Connecticut at this point in time, as we've heard time and time again, when it's been compared to reimbursement rates in adjoining states. One last example, if we take a Medicare patient that comes in for a diabetic foot ulcer, we're typically going to get reimbursed, and it's not a huge amount, but $114.32 for that patient through the Medicare program, whereas the Medicaid program is going to reimburse, in and around this $32.39 for that same type of service there. I mean, truly, in order to see the same, type of revenue, and we consider Medicare one of the lower reimbursing programs, as we've heard, then I have to see 4 times the amount of people, in order to make my ends meet on this end, and that's just not sustainable. Now, I know I'm preaching to the choir here about that, but I really am appreciative of your support for this bill, and we look forward to the approval of this bill. Thank you for considering the thoughts of the CPMA.
Thank you so much, Doctor. And it's helpful every time we hear from folks because these numbers are staggering.
They're very staggering, yes.
Yeah. Thank you for your testimony. Have a great
You're
afternoon.
welcome. Thank you.
Mark Schaefer, followed by Gretchen Richardson.
Good afternoon, Representative Gilchrist, Senator Lesser, Representative Case, Senator Perillo, and members of the committee. My name is Mark Schaefer, Vice President of System Innovation and Financing at the Connecticut Hospital Association. I appreciate the opportunity to testify concerning House Bill 7191, an act concerning Medicaid rates, rate increases, planning, and sustainability. CHA supports the intent of this bill, which is to address the significant Medicaid underfunding across the healthcare continuum. And as we've previously testified, Connecticut substantially underinvests in Medicaid relative to other Northeastern states. We would spend $2.5 billion more a year on Medicaid if our spend was in line with these other states. This is consistent with the findings of the recent DSS reimbursement studies. However, we think it's important to note that the Phase 2 study failed to document the substantial hospital underpayment that exists in Medicaid today. Connecticut hospitals are reimbursed less than 60 cents on the dollar for the services provided to Medicaid beneficiaries after accounting for the taxes they pay to fund the state share of Medicaid services. The hospital underpayment has grown sharply in recent years, reaching $1.4 billion in fiscal year 2023. According to a recent Office of the Health Strategy report, the Medicaid hospital shortfall in Connecticut is 79% higher than the national average. It's critically important to address this issue. We strongly encourage the legislature to include hospital reimbursement as part of this proposal. We believe that such increases could be enabled by a comprehensive redesign of the Medicaid program, one that could include a better use of Connecticut's hospital tax to advance the important public policy goals that the legislature set forth in Section 17 of Public Act 2371. These goals included addressing social, economic, and environmental drivers of health, improving the long-term health and well-being of the Medicaid population, and promoting affordability for all. There are 2 elements that are critical to this redesign. First, the hospital tax, in conjunction with other sources of revenue, should be used to reduce or eliminate the Medicaid hospital shortfall and provide for annual updates. And the distribution of these payments should be codified in statute. Second, we believe that a new payment model is needed in Medicaid, one that capitalizes on the role that multi-sector health partnerships can play in addressing the root cause drivers of poor health. We recommend a financing and accountability framework that provides new investment funding for hospitals and their multi-sector health partners to invest in place-based health initiatives. We also recommend that 100% of the resulting savings be shared for reinvestment. CHA welcomes the opportunity to engage further on a comprehensive solution that will support the cost of care delivery, drive better health and affordability for all. Thank you.
Thank you, Mark. And not only will I take a look at your testimony, but I'll follow up because I'd love to connect.
Thank you.
And I don't see any questions. Have a great afternoon.
You too.
Next is Gretchen Richardson, followed by Christy Balaciano. Is Gretchen with us? I don't think so.
She is not accepting her promotion to panelist.
Okay, Gretchen, if you can hear us. Up, now she did.
Hi, can you hear me?
Yes, go right ahead.
I'm so sorry, I was having connectivity problems. Good afternoon, Senator Lesser, Representative Gilchrist, Senator Harding, and the entire committee, members of the Human Services. I appreciate the opportunity to offer testimony on HB 7189. My name is Gretchen Richardson. I'm the Executive Vice President and Chief Clinical Officer at Continuum of Care. Continuum has been in operation for almost 60 years. We have 60 programs throughout the state, group homes, supportive housing, community residents, and serve over 2,500 individuals annually with severe mental illness, developmental disabilities, and substance abuse disorders. Continuum operates residential treatment programs for veterans and emergency shelter with beds for 100 unhoused individuals. Continuum operates residential programs for DDS and DMIS, and despite similar program types, there is a lack of consistency related to medication management. Within our DDS program, staff are medication certified, enabling them to administer medications. Within the DMIS programs, residential staff cannot administer medication. Instead, residential staff working at DMIS-funded programs monitor the supervision of self-administration of medication. In addition to the lack of parity between DDS and DMIS programs, as well as the budgetary impact to Medicaid related to the cost of visiting nurse for medication administration visits, I would like to highlight several key reasons why it would be beneficial to the clinical needs of the residents in DMIS-funded residential programs. There is a lack of continuity of care, given that visiting nurses are not part of the daily rounds with residential staff and not always able to attend multidisciplinary team meetings. The lack of client-centered care and visiting nurses cannot always guarantee to be on time due to crises that occur with previous patients. This also oftentimes results in the residents being late for appointments, day programs, or work due to waiting for their nurse. Residents complain that medications are not taken at their prescribed time due to having to take some of their bedtime medications at 7 or 8 p.m. when nurses are able to be present. Due to the utilization review of home care nursing services, residents have medications pre-packed for a week at a time, and staff have to monitor those medications. Staff are not always aware of what medications are in, causing a delay if there is a missed or wrong pill. I encourage the committee to consider including review of medication management related to DMIS residential programs in this very important bill. Thank you for your consideration.
Thank you so much for your testimony and for being here tonight.
Thank you.
Till today. Okay. Have a good evening.
You also.
Next, we'll hear from Christy Balaciano, followed by Sally Grossman.
Good afternoon, Representative Gilchrist, Senator Lesser, and members of the Human Services Committee. Thank you for the opportunity to provide support for House Bill 7191, an act concerning Medicaid rate increases, planning, and sustainability. My name is Christy Balaciano. I am the Director of Marketing and Communications at Fairhaven Community Healthcare. Fairhaven Community Healthcare is dedicated to providing accessible healthcare services to all individuals in our community. We serve over 36,000 unique patients annually. Greater than 90% of our patients represent minorities, and nearly 70% of our patients are Medicaid recipients. We provide primary care services, including nurse midwifery, dental services, and geriatric care. We are proud to offer dental, behavioral health, care coordination, and substance use services. For literally decades, Connecticut Medicaid has been out of compliance with federal law, which mandates that states reimburse health centers based on allowable costs. Our patients have felt the impact of this practice. Though we work diligently to provide high-quality care, there is no question that limited funding has translated into limited services. The situation in Connecticut is particularly distressing, given the practice in neighboring states such as Massachusetts, New York, Rhode Island, and Maine. A recent Medicaid study conducted by the Department of Social Services showed that Connecticut health centers receive, on average, 75 to 80% of the fees received by health centers in these neighboring states. Connecticut's reimbursement to health centers are the lowest in New England, the lowest in the Northeast, and among the lowest third across the country. We can do better. Our patients deserve no less. Our center loses over $100 on each Medicaid medical visit and over $121 on each Medicaid dental visit. We must rely heavily on grants, which are time limited, and on philanthropy, which is often a one-time infusion of cash to allow us to continue to provide high quality care our patients deserve. With federal threats to our funding and to Medicaid, together with rising demand for primary care services, ensuring that health centers are paid in compliance with federal law is key to ensuring access to high quality care for all Connecticut residents. At Fairhaven Community Healthcare, we remain committed to serving our community, but we cannot do it alone. It's time for Medicaid rates to reflect the true cost of care, and we urge the committee to support this important bill. Thank you for your time and consideration. Together, we can ensure that all Connecticut residents have access to the care they need and the care they deserve.
Thank you so much, Christy. Thanks for your work and for being here today. Next, we'll hear from Sally Grossman, followed by Melanie Wild-Lane.
Hi, how are you? Thank you, Representative Gilchrist. My name is Sally Grossman. I am providing testimony in favor of House Bill 7191. I'm currently enrolled in the Husky program along with my 2 children. I applied for the program back in 2012 when I was pregnant with my first child. At the time, I had my own private insurance that, unbeknownst to me, did not actually cover maternity care. Had I not qualified for Medicaid, it's unlikely I would have been able to afford most types of prenatal care. So when I went into preterm labor at 28 weeks, I was able to seek medical care at the hospital immediately, rather than waiting to see if my pain was temporary. And because I got immediate and amazing maternity care, they were able to stop the contractions. And with many follow-up appointments, I delivered a healthy full-term baby boy 10 weeks later. I try not to think about what could have happened if I didn't have Husky, although I do think about it sometimes. In early adulthood, I had private health insurance that amounted to little more than catastrophic coverage, meaning the deductible was extremely high. And even after it was met, I was still responsible for a high percentage of all costs. Because of this, Planned Parenthood became my primary source of medical care for several years. It was the only accessible provider I could afford. Still today, many uninsured and underinsured individuals are left with little options when it comes to medical care. They rely heavily, as I once did, on centers like Planned Parenthood. But these centers cannot continue to serve these marginalized communities without adequate funding. We've seen funding slash at a national level for providers like Planned Parenthood. When you factor in the low Medicaid reimbursement rate, it may soon become impossible for them to continue providing the same level of care to all their patients. It's difficult enough for Medicaid patients to find providers that will take them. Often I've been told by a provider that they either don't accept Husky at all, or they do accept Husky, but they have met their limit on how many Medicaid patients they will see. This is due to the money they lose because of low reimbursement rates. When community health clinics, who see a high percentage of medical patients, the financial hit is felt much more. Because of Medicaid, I was able to have the family I have today. I want everyone to be able to access the same care I received, but not properly reimbursing providers will make that much harder. So I urge this committee to support HB 7191 so we can ensure these healthcare providers are able to continue serving our communities. Thank you.
Thank you so much, Sally. Thank you for sharing your experience and for being here today.
Thanks.
Have a great afternoon. Oh,
You
no,
too.
you have a question.
Okay.
Representative Shake.
Hi, Sally. It's Representative Caitlin Shake. How are you?
Good. How are you, Representative Shake?
I'm good. I just want to say thank you so much for your testimony and for touching on various different issues within why it's important and why you chose to give testimony today. It's appreciated. Thank you.
Thank you.
All right. Thank you so much. Have a great afternoon.
You too.
Apparently enjoy the weather is what I'm being told.
It's beautiful out. I'm not going to lie.
In this little room all day. Melanie Wild-Lane, followed by Sheldon Tubman.
Good afternoon. I'm Melanie Wild-Lane. I'm the Executive Director of the Connecticut Association of School-Based Health Centers. CASBEC is a statewide nonprofit organization supporting over 343 school-based health centers through advocacy, networking, and educational opportunities. I'm testifying today on behalf of Raise Bill 7191. CASBAC fully supports this bill. As you know, Medicaid rates have not increased in years. We have been waiting patiently for the rate study completion and results. Increasing rates for pediatric and adolescent providers will help support school-based health center sustainability. School-based health centers, or SBHCs as we call them, ensures children and adolescents access essential healthcare services directly within their educational environment. They provide various services, including preventative care, mental health supports, and chronic disease management. These services are vital for students' well-being and academic success. These centers help reduce absenteeism and promote a healthier, more focused student body by addressing health issues on site. Higher Medicaid reimbursements will enable school-based health centers to expand their services and hire additional qualified staff and upgrade necessary equipment. This will enhance student health outcomes as more comprehensive care can be provided. Furthermore, SBHCs will be able to implement more effective healthcare education programs with better resources, empowering students to make informed health decisions. Expanded services benefit the community by improving public health and reducing local healthcare burdens. Students receiving timely and effective care at school-based health centers decrease the likelihood for emergency room visits and hospitalizations. Additionally, healthier students contribute to a more vibrant community as they're more likely to attend school regularly, succeed academically, and participate in community activities. With the ongoing national healthcare workforce shortage, the increased funding for our school-based health centers will provide an invaluable opportunity to make our programs more competitive in terms of salary offerings. These will be essential in our efforts to recruit and retain top talent for these critical positions. It's important to note that predictions indicate a significant global healthcare worker shortage by 2030. The World Health Organization estimates a shortfall of approximately 10 million healthcare workers worldwide, with the greatest impact expected in our low and middle income countries, and that's our communities that we service. This projection further underscores the urgency of enhancing our recruitment strategies and ensuring that our compensation packages remain competitive within the current healthcare landscape. The additional funding we are receiving will play a pivotal role in addressing these challenges, and I believe it positions our SBHCs to meet the growing demand for skilled healthcare professions. Timely rate increases are crucial to ensure that school-based health centers can continue to provide essential services to children and families.
Your time is complete. Please.
Our
defer it.
school-based health centers struggle to maintain operations with adequate funding, reducing access to care for vulnerable populations. By implementing rate adjustments promptly, we can safeguard the future of these vital community resources. My testimony also includes what happens when we don't have inadequate funding, but I don't want to be negative Nelly today, so you can read that. Thank you so much.
Wonderful. Thank you so much, Melanie. We'll be sure to go back and take a look.
Perfect.
Oh, I'm sorry, Representative Shake.
Sorry. Thank you for your testimony. Did I miss it? How many children receive services? Do you
So
have
we don't
data on
have a
that?
Sorry, we don't have a really great number on that. We're working with the TCB and appropriations to hopefully implement a statewide data collection tool and method. What I can say is on average, our school-based health centers service 10% or more of the student population.
Per district?
Per school.
Okay. All right. Well, thank you for all the work that you do, and not to be
You're
a
very
negative
welcome.
Nelly. I mean, you don't have to say you're being a negative Nelly. It's the way, I don't know, I've had a million conversations recently, and it's really being a realist, because we can't do our jobs unless we know how much funding we're going to be receiving, and then that impacts everyone. So it's having those emergency plans and planning for the worst case scenarios, right? And that's just being responsible so that we can still hopefully maintain some level of services. So I appreciate all the work that you do, and look
Thank you.
forward to reading the rest of your
It
testimony.
it does indicate what happens when we don't have adequate funding. So yeah, you'll be able to see that.
Thank you.
Thank you.
Wonderful. Thank you so much. Next is Sheldon Tubman, followed by Dr. Karam Guman.
Good afternoon, Representative Gilchrist, Senator Lesser, other distinguished members of the committee. My name is Sheldon Taubman, I'm a litigation attorney at Disability Rights Connecticut. We serve individuals with a range of disabilities. I'm here to testify about the impact on people with disabilities of several bills before you. I won't mention them by name, but there's so many categories of Husky C asset limits, weight loss drugs, PCMH plus, emergency medical condition coverage, and cuts in SB 1251. I can only mention a few, but I have written testimony going through all of them. Husky C income and asset limits. So Husky C is a program which, by express provisions, is discriminating against people with disabilities and older adults in financial eligibility. It's the only program other than MedConnect that has any asset limits. That's also for disabled people. And it has an income limit of $1,370 a month, whereas the other Husky programs are at now $1,800. So it's $430 lower an income limit. This express discrimination has been going on for years, and advocates have been coming to you asking it to be addressed. And I know you've attempted to do that in the past. Two of the bills before you would address the asset limit by raising it slowly over years, and that's helpful. However, if those bills are passed as they are, it would perpetuate discrimination against people with disabilities in terms of the discriminatory income limit. Again, which is only for people who are disabled, severely disabled, or who are older adults. Next is weight loss drugs, and we've talked about this before when I was last before the committee. There's a clear requirement that you pass effective July 1st, 23, that the commissioner shall provide for coverage of all FDA-approved weight loss drugs if the person has a BMI of 35 or over. It's simply not being done. I know the commissioner testified, and she had an op-ed, in fact, on Sunday, saying good governance requires balancing legal mandates with financial sustainability. Sounds good, but it's flatly wrong when the legislature has already done the balancing, passed a clear legal mandate containing no authority for such further balancing. The governor had signed it. So arguments about balancing at that point are nothing more than an attempt to defend ongoing lawlessness. The commissioner noted that they've sought to cover certain drugs, but those are old line drugs, not the more effective GLP-1s, and the statute does not allow that kind of distinction. SB 1474 and SB 11 will serve to strengthen the mandate you already passed. I have a couple of suggestions I was asked last time, and one is you should make it clear that all FDA-approved drugs have to be covered, not just GLP-1s. You can also, as far as the state plan amendment, set a short deadline by which it must be submitted, or even just say you have to do it, period. Don't mention SPA, and it will be done with state funds if the commissioner doesn't submit state plan amendment.
Your time is complete. Please summarize.
Sure. In PCMH Plus, that's handled in 1483. You already heard testimony from Ellen Andrews. This program is not working, and perhaps a better approach is just to end it and take the savings from that and put them into developing care management options that work and care management for long-term care. And lastly, on emergency medical condition coverage, SB 806, the commissioner testified this morning that, well, some of those things wouldn't be federally reimbursed if you covered them. But I believe those come from other states that have reimbursed them, have gotten reimbursed under the feds. And so I think that the easy answer is to work with us, advocates and others, to find out, get confirmation that states are getting reimbursed by the feds for covering these conditions, and those should be the ones covered. Thank you very much.
Thank you, Sheldon. Thank you for being here and for your testimony. Have a great afternoon. Next is Dr. Karam Guman, followed by Todd Johnson.
Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Khurram Guman, and I am an independently practicing family physician and the current president of the Connecticut State Medical Society. I'm testifying in support of House Bill 7191. Medicaid reimbursement is not just a financial issue. It is a health equity issue. Nearly 1 million Connecticut residents rely on Medicaid for their health care, and many are from historically marginalized communities already facing significant barriers to care. Yet, Connecticut's Medicaid reimbursement rates remain among the lowest in the region, directly impacting access to physicians. Specialist wait times are excessive. primary care availability is limited, and mental health care remains out of reach for too many patients. As a physician, I can tell you the doctors want to care for Medicaid patients, but year after year of inadequate reimbursement has made participation unsustainable. Many practices operate as small businesses, and when Medicaid rates do not even cover the cost of providing care, physicians are forced to make difficult choices. As a result, more doctors are leaving the Medicaid network and fewer new physicians are enrolling. Without immediate and sustained investment, access to care will continue to deteriorate. We know that increasing Medicaid reimbursement improves access. Studies confirm that when rates are brought closer to Medicare or private insurance, more physicians participate. Medicaid rate study validated what we already knew, and Connecticut's rate are far too low compared to the peer states. We must act now. I want to highlight 3 key areas where this bill can be strengthened. First, all physician specialties and subspecialties must see rate increases, not just those identified in the study. Medicaid access issue in part stems from the years of uneven rate adjustments, and leaving out certain specialties will only perpetuate these gaps. Every physician who provides care to Medicaid patients must receive a meaningful increase. Second, while we acknowledge the need for a 3-year phase-in, we urge policymakers to move as quickly as possible. Many physicians have already left the Medicaid network, and once a physician stops accepting Medicaid, it is extremely difficult to bring them back. Delays in implementation will only make rebuilding access more challenging. Third, the bill provides mechanisms for ongoing rate adjustments, but we strongly support using the Medicare Economic Index rather than the Medicare fee schedule. Medicare rates continue to decline, and the federal policies make them an unstable benchmark. Medicare Economic Index, however, reflects the actual economic pressures on medical practices, staff wages, rent, and supply costs, etc., ensuring that Medicaid rates remain viable over time. Finally, no Medicaid rates should be reduced if a payment currently exceeds a 70.
Time is complete. Please summarize.
So I thank you for your time and would like to continue to work with the committee to ensure a stronger and meaningful change. And I'm happy to answer if there are any questions.
Thank you so much, Doctor. There is a question. Senator Lesser, go right ahead. Oh.
Thank you so much for your testimony, and appreciate working with you and the society on advancing the goal of fair, just, and sustainable Medicaid rates that will ensure that patients have access to the program. I was really interested about what you just said about tying it to MEI versus to Medicare rates, because we had really been thinking about, coming up with a new rate setting model. Obviously, inflation is one way to do it, but I know that our Medicaid rates have largely been frozen since 2007, but Medicare rates have not been, right? Medicare rates have gone up in the interim, but you're suggesting that the Medicare system is also broken? Because that's the first time I think I've heard of that, and it's possible other people have heard differently, but I just wanted to see if you could elaborate on that.
So thank you so much for this question. It is very important. So every year, Medicare rates, there is a law that was passed a few years ago, and there's 2.8% decrease every year on Medicare rates as well. So if we tie our Medicaid rates to the Medicare benchmarks, that may or may not be as practical down the road, because there's uncertainty. The rate adjustment is in the law, but we are hoping that the Congress will, act and not let that 2.8% decline go into effect. But it's complicated where they have to act every year to stop that set 2.8% change. So I would encourage our Medicaid rates to not tie to something that is sort of unreliable or unstable due to so many other reasons. Cost of practice with the wages, with the all the other pieces of the puzzle, it continues to increase. But if we are looking at the benchmark as a Medicare rate, which is already designed to go down, it may not be a practical long-term solution to tie our Medicaid rates to that. So that's why we are proposing that we tie this to the benchmark, the MEI benchmark, instead of the Medicare rates at the federal level.
Thank you. That's hugely helpful. And I understand my co-chair just mentioned to me that I suppose other people before you mentioned that, but I was out of the room for that. So I apologize to them. So understanding this, I guess in theory, Congress could just allow those cuts to go into effect. I know that every year they have to vote.
Right.
But as a practical matter, they have been taking that vote. I assume the outcry would be pretty swift if they cut every doctor in the country's rates. I mean, I assume if they did that, though, we could come in and vote to decouple, right? We don't have to. We're not tied perpetually to Medicare. We could change the rules. The reason, I don't know, MEI I know goes up pretty quickly. I mean, we do have some language in here around MEI with regard to the federally qualified health centers, but the focus had been really to try to find a more, rational system of rate setting, and that's why I zeroed in on Medicare. So I'm not coming down one way or the other at this point. I want to hear what you have to say and sort of think this issue through a little bit more.
Yeah. And we're happy to work with you and your team on this to find that practical solution. But I think our hesitation to support that is unless Congress acts every single year, it's part of the law. The law is that the rate decreases. Now, if you're designing a new solution to something that in our national physician community eyes already sort of flawed. So I think we are hesitant to support that just because of the inherent built-in challenges with the existing structure at the Medicare rates. MEI gives us that other potential avenue to build this. But certainly, I see your concern, and we are happy to work with you and your team to find a practical solution that will be more sustainable.
Great. Thank you, Doctor. And thank you, Madam Chair.
Yep. Representative Hughes.
Well, hello, Doctor. Good to see you. Thank you, Madam Chair. Can you speak to how, as a preceptor of students in the Quinnipiac School of Medicine, how this lack of, reimbursement rates and delays, what this has on the effect it has on the next generation of doctors that we're trying to train and get into the pipeline?
Thank you, Representative Hughes. Great question. I mean, it is an ongoing challenge to recruit, train, and retain new physicians in Connecticut. So if our state practice environment is not physician-friendly, and when I say physician-friendly, there's multiple pieces to it, but one of those pieces is adequate reimbursements for the clinical services they are providing. And it is very challenging to maintain the physicians that our citizens need in Connecticut when they can, for the similar work in the neighboring state, their reimbursements may be very different. So Medicaid rates, not only for primary care, not only for mental health care, but all other specialties. And it's especially a bigger challenge when it comes to the specialty care. For example, if a patient in primary care needs an orthopedic surgery consultation, now my choices are limited where I can send that patient for this additional help. And on the flip side, if there's only so many practices who are actively accepting Medicaid Husky patients, their access may be limited to the number of patients who need to be seen. So as a consequence, even if they're open to Medicaid patients, their delay, the time it will take for that patient to see that specialist may be much, much longer than if we had more clinicians accepting Medicaid patients. So to answer your question, it does impact our ability to retain those trained physicians in Connecticut when the environment of the practicing clinicians is not as helpful to the new physicians to come in and design and start their own practice or join the groups where they may already be struggling in trying to keep up the doors open. And one of the unfortunate or unintended consequence of these challenges is that if the independent small practice is unable to maintain their existence, they inadvertently then leads to those mergers and large system acquisitions, which we already know have inherent built-in challenges to access in a different way. So it is a concern, and it is definitely indirectly impacting our ability to retain and maintain and recruit new physicians in the state as well.
Thank you for that. I think we already know the answer to this, but especially in trying to attract good physicians to the geriatric field, since we know Connecticut is the 6th oldest state in terms of median age, and there's going to be more and more patients that need really specialty geriatric care. I know we are not seeing enough practitioners going into that field, and that is a Medicare Medicaid blend often.
Absolutely. And to echo your point, in the next coming 10 years, the population growth, the biggest chunk of the population growth is going to be in this 65 and older population. So we do not only have to be worried for today, but we also have to be concerned about what's coming ahead in the next coming 10 and 20 years down the road, where we will definitely feel that problem in a much more severe fashion. As you mentioned, the geriatrics care is already limited. And when you have limited resource but higher demand, that is only going to make things worse when there's a lot more patients who need care from the limited physicians that are available to us. So I certainly agree and echo your concern there.
Thank you. Thank you, Doctor. Thank you, Mr. Chair.
Thank you, Representative. Other questions or comments for the doctor? Seeing none, thank you very much for your testimony.
Thank you.
Next, we have Todd Johnston, followed by Megan Scanlon.
Hi, Human Services Committee. My name is Todd Johnston. I live in Portland, Connecticut, and I'm currently on MedConnect. I'm testifying today against one of the SB 1251, Section 6. My concern is at my last visit with my doctor, afterwards, I checked my MyChart notes and I was marked as being obese. Now, I had asked my doctor if I can go on a weight loss drug, and he said no, due to the fact that I don't have diabetes or other chronic condition which would qualify me for the weight loss medication. I since read further into the bill, and I do see that the fact that I have sleep apnea would make it so I would be able to get that medication prescribed for me. But the way that SB 1251 has it now, it would not be covered under Medicaid. The next thing I'd like to speak on is testifying against the Section 14, which has taken away the proposed raising of the MedConnect income limits after a bump up that is scheduled for this year. I and others that are on MedConnect, you know, that the limits that were set, I believe the $10,000 in your checking account and up to $75,000 was actually set when MedConnect was first established, which I know was many years ago. And now it's just going to go up $10,000 for both assets and income. But it was scheduled to have those lifted. If you think about it, it was so important to have those gone to allow us to thrive and be the best we can and contribute to the community the best we can and make money so we can live here in Connecticut. So please do not vote to pass on the bill as it is currently, because it would have a direct impact on me and others like me. Thank you again for listening to me and allowing me to testify in this bill.
Thank you for your testimony on this issue. Just a question. So my understanding is that MedConnect right now, although the federal program allows it to charge a fee for everyone, right now for higher income folks, there is a fee in Connecticut and there isn't for lower income folks. Are you currently paying for your MedConnect?
I do. It is because I'm fortunate enough to make over the 200% of the federal poverty level. I do pay the 10% that I'm over that as a premium for my Husky C without a spend down.
So we have a program where you're paying a premium for the healthcare that you get, and that is the loss right now, passed by the legislature. I believe it was a bipartisan vote, says that we're now phasing that out. But if we were to go ahead with Section 6 of this, we would say, no, you have to forego, you have to make less money than you can, because even though you're paying a premium for this, just because we say we don't want your money. And I'm not entirely sure why we would do that. And I appreciate your voice expressing concern about this section because I share your concerns. Are there any other comments or questions from members of the committee? Seeing none, thank you for being here this afternoon. It's important.
Thank you very much, Senator Lesser.
Next, we have Megan Scanlon, followed by Daniela Capetta.
Good afternoon, Senator Lesser and members of the committee. My name is Megan Scanlon. I'm the CEO at the Connecticut Coalition.
Megan, you've frozen.
Technical error. One moment, please.
Okay, are we good?
We can see you now.
Okay, can you see me? Great. So good afternoon, Senator Lesser and members of the committee. My name is Megan Scanlon. I'm the CEO at the Connecticut Coalition Against Domestic Violence. I'm here to discuss Senate Bill 1251, specifically sections 4 and 5, which deal with one-time domestic violence benefit program run by DSS. You heard from the commissioner earlier today that DSS does not believe that it has the expertise in domestic violence to ensure the assistance is going to the people the program is intended to serve. So they've proposed to transfer resources to CCADV so that we can administer the program, since we have 18 sites across the state that have expertise in domestic violence. In doing so, the state will save $4 million that it currently spends on the program and allocate $1.5 million to CCADV to run the program. We're not opposed to doing this, but we do have two concerns. The first is that the funding transfer to us needs to meet both the victim need that legislators and DSS want us to meet, as well as the administrative cost to do so. The second is that while we want to assist the state in getting domestic violence victim assistance done effectively and efficiently, and do believe that we're well positioned to do so, we have a serious funding gap for our statewide domestic violence hotline beginning July 1st. And we had asked the governor, OPM, and DSS to include in the governor's budget proposal $1 million for that program. That does not appear to be in the funding request that was included in the governor's budget. So with respect to the first concern, CCADV and our 18-member programs, we have a long history of administering cash assistance to survivors. We just administered over $3 million from fiscal 23, allocated by the General Assembly and the governor. And it took us 2.5 years to administer that across the state through our coalition. So if legislators and DSS do want to do victim assistance differently, we do believe that we can stretch a smaller amount of money further while addressing the safety needs of victims. And with respect to the second concern we have, Safe Connect is our statewide domestic violence hotline. It plays a critical role in our state's overall domestic violence service system and infrastructure. It provides a 24/7 single coordinated trauma-informed point of entry for victims. And without it, many survivors will go without help. They will not have 24/7 access to resources, support, and critical services that they need. And so therefore, focusing on administration of victim assistance will be the least of our concerns if that goes away. thank you for your time, and I'm happy to answer any questions.
Thank you, Megan, for your testimony, and it's good to see you. Just with regard to the cut that the governor's budget currently, or the transfer in of the program from DSS to CADV. So that's in effect, given the increase elsewhere, what a negative on net, it's a negative cut of about $3 million. Is that right? Or are they, I'm not sure.
Yes,
how
so
that
they will.
would work. So how they're just asking you to do it, but they're not providing you the resources to do it.
So I think that from my understanding from the commissioner's comments, the program was projected to cost $4 million for this upcoming fiscal year. I think it was about $2 million last year. So they're proposing to save money, yes, and then allocate. So they'll save about $4 million, or $3 million, yeah, and allocate 1.5. So yes, they are asking us to run this program for less money. But we also do victim assistance differently. Their program provides cash assistance directly to survivors. Based on our contracts with DSS, we actually are not able to do that. So we actually will work with the survivor, address the immediate safety concerns and economic independence needs, and then we actually work with the vendor. So let's say they need a car repair to get to work. We're actually working with the vendor who's doing the car repair, and we pay that bill directly. We do not ever exchange cash with survivors directly. And we can't because of our contracts.
Well, sounds hard to implement then.
It's different from what they do. So they just pay money directly to survivors. We are not able to do that based on our contracts right now. So we can do this, but it has to be done differently.
But your concern is that that survivors would be left, with a gap in support that they're currently.
Our concern is twofold. So one, I do think we can use less money more efficiently and effectively, but our concern is that in order to access services, we need to have our statewide entry point funded, because that enables them to access more than just victim assistance money. So that enables them to access our court-based advocacy, our advocacy for basic needs, and other programs that we work with individuals on, including our shelter services across the state. So victim assistance to us is one tool in a very robust toolbox, but if we don't have a critical infrastructure like the statewide hotline, then victim assistance doesn't really go as far when we're working with individuals. And just to give you a sense of this, so we, with $2.9 million that you allocated in just fiscal year 2023 alone, we supported 7,000 survivors at an average cost of about $150 per survivor. But that's because we're also leveraging all the other services we provide in our service system outside of just that cash benefit.
Got it. Questions from comments? Representative Case.
Thank you, Mr. Chair. I guess good afternoon, Scanlon. How are you?
Good. How are you?
So, and thank you. We did have a good conversation on this. And I think what I see the commissioner talking about, and when we put the monies there a bunch of years ago, DSS just isn't equipped with the correct team to get this money to actually sit at home where it needs to be. And I think that's why, reaching out to you and CCAD or CCADV, you have more, you're dealing with this every day. So your ability to get the most for the dollar is better. But the concern that I have, and I think Senator Lesser said this too, the cut to the hotline in the governor's budget, that wasn't supposed to, the money that was being transferred over out of DSS wasn't supposed to impact that. And that's what we're seeing happening. Is that correct?
Yes. And that was always our concern, that the two would get confused with each other. But they are two separate requests.
It's almost as if we had held on to this money for another 6 months after the budget passed and then transferred it to you, you would have most likely had your call center money and the DSS money that was coming over to you. It's just that it fell before a budgetary time, I believe, when the commissioner was putting her stuff to OPM. And I think that's where it sort of fell off. We need to make sure and work that the hotline is funded and that you have monies able to do that. I don't think it's anything a knock on DSS. I think it's DSS trying to admit that they don't have the specialty people to work with this. Is that fair to say?
Yeah, that's fair to say. And like I said, we're not opposed to running it. We run it differently. And we think we do a really good job with state resources and with making sure that victims are safe and that they're able to move on to be economically independent long term. So we don't have an issue with that. We're just concerned that they won't actually be able to reach our service system if they don't have a single point of entry, and to be able to access our other housing programs and shelter programs and court programs if that's not available. So that's the concern.
Thank you, Megan. I thank you for doing this and taking it on. I think the anticipation was, I believe, for the 1.5 million or the whatever it was that was coming over to you from DSS was a stay for constituent use and not to impact the lifeline for your call center. So I think we're working on that here to make sure that happens. And I think this is going to be the best for the constituents that need domestic violence help, because you are the right agency for this to be with, even though you're not a state agency. I think it's admirable for a state agency to say that they're not equipped to deal with this, and let's put it to the right person. So I thank you for stepping up and taking it. Let's try to work through I think you and I talked, and if we get 500 or 750 for the call center, we might be a little bit better off. It's not whole, but let's see what we can do moving forward, because we don't want you to fall short. We want that money that came from DSS to actually be used for constituents and not have to be drifted off to other things. But thank you very much, Megan. I appreciate it.
Thank you.
Thank you. Other questions or comments from members of the committee? Seeing none, thank you for being here this afternoon.
Thank you.
Next, we have Daniela Capetta, followed by Cynthia Fitzgerald. Is Daniela on?
Yes, hi, good afternoon.
Good afternoon.
Members of the Human Service Committee, my name is Daniela Capetta, and I am a home health nurse with Alara Caring. I'm here today to speak on HB 7191 regarding Medicaid provider rate increases. Specifically, I ask that you ensure this plan include the behavioral home health medication administration rate, which was cut by 15% in 2016. As a nurse working with young adults aged 18 to 25, transitioning from the Department of Children and Families into independent or supervised living, I have seen firsthand the challenges this population faces. Many of my clients have endured extensive trauma, including physical and sexual abuse, and often have little to no support system. Their transition into adulthood is filled with uncertainty, and without the right support, they are at risk of instability, hospitalization, or even involvement in the criminal justice system. My role extends far beyond traditional nursing. I collaborate with community providers to ensure my clients receive the medical and mental health care they need. I help them schedule appointments, arrange transportation, and relay critical clinical information to keep them stable in the community. Education is a key part of my job, teaching them about their diagnoses, medications, and the importance of hygiene and daily living skills. Many of these young adults struggle with medication compliance, which can lead to decompensation and hospitalization. It takes patience, persistence, and a deep understanding of trauma-informed care to help them stay engaged in their treatment. Substance use is a significant concern in this population, and I work closely with clients to reduce use and prevent relapse, which can interfere with their progress and lead to legal consequences. For those with criminal histories, I help them adhere to court requirements while ensuring they stay on track with their health and recovery goals. These young adults require nurses with specialized expertise, professionals who can navigate complex cases with compassion, advocacy, and a commitment to long-term stability. Without our support, many of them would struggle to access the care they need, increasing the burden on emergency services and the state. Nursing services play a vital role in keeping these clients safe, independent, and moving towards a healthier future. Please consider prioritizing restoration of the 2016 cut to medication administration as you determine your path forward to fund much-needed Medicaid provider rate increases. Thank you for your consideration today.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Next, we have Cynthia Fitzgerald. Followed by, I think, Heather Dawson. No. Is Cynthia? No, Cynthia? Okay, and there is a Heather.
Good afternoon.
Good afternoon.
My name is Heather Dawson. I'm the president of the Connecticut Association for School-Based Health Centers, which is a statewide nonprofit organization that supports over 300 school-based health centers. I'm also the director of 8 school-based health centers. Of those, I oversee 5 comprehensive school-based health centers and 3 expanded school health sites. The comprehensive sites include medical behavioral health and 1 dental location. I'm here to testify on Ray's Bill 7191, an act concerning Medicaid rate increase, planning, and sustainability. CASBAC supports this bill regarding the proposed Medicaid rate increase. This is vital to the school-based health center program to maintain the services we currently offer students throughout the state of Connecticut. All students deserve to be healthy and have the opportunity to access quality medical, behavioral health, and dental care. While available to all students, school-based health centers are often a safety net that allows the most vulnerable students to obtain professional care in school where they are most comfortable and spend most of their time. By offering students a unique blend of medical, mental health, and sometimes dental services, school-based health centers help to increase the students' ability to learn, attend school, and be successful. Healthy kids make better learners. School-based health centers have faced many issues with sustainability despite there being an overwhelming need for services supporting students. An increase in Medicaid rate is one step in the right direction to ensure that school-based health centers continue to provide the important services to children and adolescents in Connecticut. Sustainability for school-based health centers means several things. 1, being able to provide services at our current level and not having to reduce or eliminate services altogether. Maintain and employ providers and clinicians who are mission-driven to provide quality and comprehensive health care in schools. Purchasing and maintenance of medical and dental equipment and supplies. The cost of operations has increased steadily over the past few years. Increasing the Medicaid reimbursement rate will help to ensure these needs are being met and allow school-based health centers to maintain and even expand their services within the school districts they serve. By not increasing the reimbursement rate, we run the risk that school-based health centers may not be able to support their operations, resulting in a decrease in services offered, closure of some sites in the state, which tend to be in the health care desert areas. Without school-based health centers to help bridge this gap, the students who rely on school-based health centers will no longer have convenient access to quality health care, resulting in potential worsening of physical and mental health outcomes, which can negatively affect attendance and academic achievement. Thank you for your time, consideration, and support of school-based health centers.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you for all your work. Next, we have Dr. Adam Kay, followed by Thomas Farquhar. No, Adam?
Yeah, I believe Adam is stuck at work.
Got it. Well, hello, hello, Dr. Farquhar. Good to see you.
Hi, Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, members of the committee. Thank you for your time. My name is Thomas Farquhar. I'm a practicing radiologist. I live in West Hartford and currently practice at Yale, and I'm speaking on behalf of the Professional Society for Radiologists, the Radiological Society of Connecticut, and provide comments on House Bill 7191, the act concerning Medicaid rate increases, planning, and sustainability. And we appreciate that this House bill will phase in an increase in the Medicaid reimbursements over 3 years, up to 75% of the Medicare rate, and then be indexed annually, increases with healthcare costs. And we think that this is a great step that's long overdue. Back in 2015, DSS made some drastic payment reductions to the provider component for Medicaid payments. And as others have spoken about, we really think that this is key to keeping access to the large number of Medicaid patients that come from all corners of the state, as well as keeping the state a favorable place to attract practitioners, not only radiologists, but all physicians across the state. This cut in particular was particularly detrimental to those who do the great work of taking care of patients in some of the more underserved areas. And so it had actually a greater impact in a bad way on those providers than those who choose not to see Medicaid patients. And in particular, radiology practices that provide the full gamut of services from ultrasound and mammography all the way up to MRI and CT scans. And as some of the prior speakers had said, having this capacity available to care for all patients is quite crucial. And so radiology practices at the end of the day are small businesses. They employ hundreds of employees, and being able to keep them financially viable for all the patients is critically important. So the Radiological Society strongly supports this legislation, and we will advocate for the necessary funding from the Appropriations Committee. And thank you for considering our views. Thank you.
Thank you for your testimony and appreciate the work of your association. Are there questions or comments from members of the committee? If not, thank you for being with us this afternoon.
Thank you, everybody.
Next, we have Deb Poland, followed by Barbara Monk.
Thank you. Good evening, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. It's great to have you here, hearing all of these people who are so passionately speaking about Medicaid rates and a number of other issues. My name is Deb Poland, and I work for the Community Health Center Association of Connecticut. We work with all 17 community health centers across the state who, as you know well, provide medical, dental, and behavioral health care to about 440,000 people every year, 60% of whom are on Husky. So 264,000 of Connecticut's Medicaid patients do seek care at one of our community health centers. We stand with others in strong support of House Bill 7191 with the Medicaid rates. We've also submitted testimony about community health workers and Senate Bill 11, which I hope to have an opportunity to just say a few words about. But as far as 7191, we want to particularly thank you for including the sections 2 and 3 regarding federally qualified health center rates. As we've talked to you about before, the rates that are paid to community health centers are wholly inadequate, making it so that health centers are losing $85 every time they see a medical patient and $121 every time they see a dental patient. These inadequate rates make it extremely difficult for health centers to maintain financial viability and keep their doors open to meet their mission to see patients and provide this high quality health care. So we are grateful for your attention to this issue in raising rates to meet costs, which is actually also compliant with federal law. So we also appreciate your inclusion of language to change the rate setting process, which is known as the change in scope process. This system is broken at DSS, likely out of compliance with federal law, and we really need attention to this issue. Just a few words about Senate Bill 11 regarding 340B. We appreciate all of the work of the bipartisan, bicameral prescription drug task force. We want to make sure that your committee pays attention to the 340B program. It's a great program that helps people who are uninsured and underinsured access prescription drugs at the lowest possible rate. This is a federal program that has the opportunity to be fixed by Congress if they could do it. They don't seem likely to do so. 8 states so far have fixed this program. We would like Connecticut to be next. I know there are some concerns about lawsuits that have been filed in other states, but just as an update for this committee and for the legislature, you should know that the Supreme Court has declined taking on the pharma lawsuit against the state of Arkansas. So we do feel that it's time for Connecticut to follow suit and work on 340B on behalf of patients and covered entities like community health centers. Thank you.
Thank you, Deb. Questions or comments from members of the committee? Seeing none, you have a wonderful afternoon.
Thank you. You as well.
Next, we have Barbara Monk, followed by Coco Selman.
My note said good morning, but I'll say good evening.
Good evening or good afternoon.
Senator Lesser, Representative Gilchrist, Vice Chairs, Ranking Members, and members of the Human Services Committee. Thank you to the Human Services Committee for taking crucial steps to address the high cost of prescription drugs. I am here to testify in partial support of House Bill 7192, an act implementing recommendations of the Bipartisan Drug Task Force, and Senate Bill 11, an act concerning prescription drug access and affordability. The high cost of prescription drugs often forces many older adults to make difficult choices between purchasing their medications and meeting other essential needs like food and housing. This is unacceptable. It's an unacceptable dilemma that no one should have to face. Moreover, it can lead to poor health outcomes and increased healthcare costs due to complications from untreated conditions. My sister ended up in the hospital a couple of times because she was rationing her drugs. Simply put, drugs don't work if you can't afford to take them. For patients, it can be a complicated maze to figure out how to find the most affordable medication. Do I use a discount program or my insurance? Do I try to purchase my medication from another country? I have a friend who has considered all of those things. She has one medication that costs $93.74 using the cheapest option for a 90-day supply through her insurance's home delivery program. If she does not go through her insurance, she can get the exact same medication in a 90-day supply for $26.75 using a medication savings card. Almost $67 less than using her insurance. Another medication that she takes costs $148 using the cheapest option for a 90-day supply. She goes through insurance, this time filling the prescription at CVS since home delivery would cost $182. She does not go through her insurance, but fills this prescription at the same CVS. She can get it for $33.91 using a medication savings card. $114 less than her insurance. Connecticut must do more to lower prescription drug costs so that patients aren't faced with complicated mazes or unaffordable medications. These two pieces of legislation are a step in the right direction with several important measures to lower the cost of prescription drugs, including allowing for state importation of prescription drugs, limiting price increases to the rate of inflation, and eliminating anti-competitive pay-for-delay agreements.
Your time is complete. Please summarize.
It's time to stop drug company price gouging of Americans, employers, and taxpayers with prices that are 3 times more than what people in other countries pay for the same medications. I urge your support for this legislation. Thank you.
Thank you so much for your testimony and for the work of yourself, but also everyone at AARP. We really enjoy working with you on this and many, many other issues. Are there questions or comments from members of the committee? Seeing none, I just want to say I'm sorry to hear about your sister's experiences. I think it is morally and
Not in
practically-
Connecticut,
yeah.
I will say that. She
Okay.
wasn't in Connecticut, but it's something that happened.
But we have a national problem with high drug prices.
Right.
And we haven't figured out a way to pay for them. Obviously, we need to figure out a way to compensate drug companies and other payers for the cost. And that's a big problem. But the fact that we have a lot of folks who are rationing access to essential life-saving medications is a policy failure. And we got to figure out a solution to it.
Yeah,
I think
and
there's
they
been
don't
some
work if
important
you can't
progress on
take
Medicare.
them.
Yeah. Well, thank you so much for your testimony and appreciate seeing you.
Thank you.
Okay, next we have Coco Selman, followed by Amanda Skinner. Is Coco with us? No Coco. Okay. Is Amanda with us? Yes, Amanda is with us.
I am with you. Good afternoon, Senator Lesser, Representative Gilchrist, and honorable members of the Human Services Committee. My name is Amanda Skinner. I'm the President and Chief Executive Officer at Planned Parenthood of Southern New England, testifying in support of House Bill 7191, an act concerning Medicaid rate increases, planning, and sustainability. As the state's largest provider of sexual and reproductive health care to almost 50,000 patients last year at 14 health centers across the state, PPS&E believes that all people should have access to quality, affordable, compassionate healthcare as a basic human right, regardless of who you are, where you live, how much money you have, or your immigration status. We thank this committee and Governor Lamont for your strategic investments in women's healthcare and family planning, including support for an increase in our social services block grant allocation to PPS&E this year and an additional $800,000 in funding through our DPH grant. Turning to Medicaid, while the modest Medicaid reimbursement increases included in Governor Lamont's proposed budget are a step in the right direction, greater state investments in our public health infrastructure are urgently needed to ensure that reproductive health providers can continue providing the care needed to the people who need us most. PPS&E plays an indispensable and irreplaceable role in the public healthcare system in Connecticut. We are committed to health equity, serving all who need our services regardless of their insurance type or ability to pay. The majority of our patients are people of color. 46% have Husky Health as their insurance and 26% are self-pay. Providers like PPS&E are often the primary care providers for women of reproductive age, people of color, young people, those who are uninsured, and people with low incomes. We are a safety net provider that reduces burden to the healthcare system. And unlike private practices, we have little ability to offset low Medicaid rates due to our payer mix and our service mix, which is 98+% preventative services. We are facing serious operational pressures that threaten our ability to continue over the long term to meet the needs of our patients and our communities. For PPS&E across all payers, reimbursement for healthcare services covers only 51% of the cost of delivering those services. We are running on a deficit and spending down reserves. This is not sustainable and will have a negative impact on our patients and the public health infrastructure in our state. The broader healthcare network in Connecticut is not positioned to provide the services we offer to our patients if our ability to do so becomes constrained. We estimate an investment of approximately $3 million. This investment would underscore Connecticut's position among other leader states that are firmly committed, including Oregon and Maine benchmark states from the rate study, to ensure reproductive health care remains accessible for all who need it. Access to reproductive health care remains vulnerable here in Connecticut. Increasing Medicaid reimbursement rates for family planning providers like PPS&E will strengthen patients' long-term access to time-sensitive, essential reproductive health care. The Medicaid rate study provides important recommendations for decision-making on rate setting based on benchmark states. We urge Governor Lamont and this committee to prioritize continuing your commitment to strengthening reproductive health care access by investing to ensure the sustainability of reproductive health care providers. Planned Parenthood's patients are counting on you. Thank you for your time and consideration.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you. Next, we have, is Russell Schwartz on? Hello.
Good afternoon, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Russell Schwartz. I'm the Vice President and Director of Operations for Avon Health Center and West Hartford Health and Rehabilitation Center, two family-owned facilities that are providing service to our communities for over 50 years. I'm testifying today on three bills, HB 7189, an act concerning Medicaid cost savings, Senate Bill 805, an act requiring homes to spend not less than 80% of their revenues on direct care, and Senate Bill 1251, implementing the governor's recommendations. My testimony has been submitted, so I'm going to try to paraphrase so that I'm not just reading my testimony, but I am in favor of adopting a policy which would put a cap on nursing agencies' rates charged to nursing homes. This subject has come up in the past, and what we've realized is there's at least $61 million in potential savings to the Medicaid program should a cap be adopted. And the proposed cap would be 200% of the median age for nursing personnel by type of nursing personnel in the state, as published in the recent state occupational employment and wage estimates by the U.S. Department of Labor. Rhode Island passed such a bill back in 2023. I think the bottom line with the agency staffing rates is that the rates that the agencies charge facilities are twice what we normally pay our staff. So for example, an RN where we might pay $36 to $40 an hour, to an agency we're paying $70 to $90 an hour. Over the past 4 years, I've spent close to $4 million on agency costs in order to keep my facilities in Avon staffed properly due to ongoing recruitment challenges post-pandemic. Agency staff are certainly, who are working in our facilities, are not bashful about talking about their rates, and effectively this kind of poaches our own staff. With minimum staffing levels increased at the state level too, in addition to recruitment challenges, the cost of agency to supplement our normal staffing patterns puts a big strain on facilities. So I do believe that we need help to get these unsustainable agency costs under control. Reducing the reliance on agency will also help result in consistent assignments to our residents and higher quality of care. So I respectfully request that you pass HB 7189 with Medicaid cost savings language to cap the fees of temporary nurse staffing agencies. As far as Senate Bill 805, I'm opposed.
Your time is complete. Please summarize.
Opposed to that bill by just segregating cost limits on one cost center. It ignores the other 4 or 5 cost centers in the Medicaid rate. The language does not promote any additional funding, and I view 805 as another way to add additional staffing requirements on facilities that are not funded. So I would look to oppose that. Lastly, the governor's budget does not include any inflationary increase. The statutory language has been bypassed for at least 10 years. I'm currently being paid on my 2019 cost report, and we're in 2025. So I appreciate your time today, and thank you for considering my testimony.
Thank you for your testimony. There's a lot of important issues regarding the nursing home industry that we want to get into, and appreciate your thoughts on all of that. Are there questions or comments from members of the committee? Seeing none, thank you for being here this afternoon. Next, we have Kevin Johnson, followed by Kelly Memphis.
Good afternoon, chairpersons and members of the committee. My name is Kevin Johnson. I'm here on behalf of Gaylord Specialty Healthcare to ask for your support of House Bill number 7191, an act concerning Medicaid rate increases, planning, and sustainability. Gaylord is one of only 2 long-term acute care hospitals, LTACs, in Connecticut, and we care for some of the sickest, most vulnerable patients, people recovering from catastrophic illnesses and injuries who require hospital level of care for weeks, not days. But despite providing this highly specialized care, our Medicaid reimbursement rate is significantly lower than that of our peer LTAC in the state. Even Connecticut's inpatient rehab units, which provide a lower level of care, are reimbursed at a much higher rate. Today, our Medicaid reimbursement is only 58% of our average Medicare rate, well below the 75% benchmark that this bill proposes. Meeting that threshold would allow us to care for more Medicaid patients who desperately need our services. In the last 20 years, we've only seen one Medicaid rate increase, while the cost of providing care has risen dramatically. Every day, we absorb that financial gap to ensure that our patients get the hospital level care that they need. And this bill is an important step toward making Medicaid reimbursement more sustainable for LTACs and leveling the playing field across provider types. Addressing this disparity will ensure that hospitals like Gaylord can continue to provide care for those who need it most, while also easing capacity issues for acute care hospitals statewide. We urge you to support this bill and help bring Medicaid reimbursement closer to a fair and sustainable rate. Thank you for your time and consideration, and I can answer any questions that you might have.
Thank you for your testimony. And just, I don't believe you are, but you're not part, Gaylord is not part of the Medicaid rate settlement, right?
Not that I know of.
Right. Are there questions or comments from members of the committee? Seeing none. Good to see you this afternoon. Next, we have Kelly Memphis. After Kelly, we're actually going to go back in time to Lauren Schwartz, who's joined us. If you are not available to take your slot, please do what Lauren did and let the committee clerk know. Otherwise, if you do want to come, you'll have to go at the very end, which will be longer. Hello, Kelly.
Okay, hello. So good afternoon, Chair Lesser, Representative Gilchrist, Ranking Member Harding, Ranking Member Case, and honorable members of the Human Services Committee. My name is Kelly Memphis. I am with the Healthcare Distribution Alliance, HDA. Briefly, HDA is the National Trade Association representing pharmaceutical wholesale distributors, the vital link between around 1,200 pharmaceutical manufacturers and more than 330,000 pharmacies and other healthcare settings nationwide. In Connecticut, our members are responsible for the physical delivery of pharmaceutical products to around 3,200 sites of care. I'm speaking today to respectfully share some concerns that we have with SB 11. We are concerned that this bill misrepresents the role of wholesale distributors, specifically in sections 1 to 5 of the bill. First, we are concerned that the definition of wholesale distributor in the bill is overly broad and captures several entities in that definition. And subsequently, wholesale distributors are then inaccurately captured in the reference rate pricing measures in sections 1 through 5. As you may know, wholesale distributors operate a unique role in the supply chain. In their role as wholesale distributors, they do not set list prices, also known as wholesale acquisition costs or WAC. They do not bring or withdraw products from market, determine pharmacy reimbursements or what patients pay at counters. Rather, wholesale distributors are the logistical experts in the supply chain who, as I mentioned, ensure that pharmaceutical products physically arrive to shelves where and when patients need them. Accordingly, inclusion of wholesale distributors in these pricing measures would cause them to be unduly subject to penalties for decisions they do not determine. This would be especially detrimental in the wholesale distribution industry, which historically operates on an under 1% net profit margin. So we did want to share our concerns with that. And while the inaccurate inclusion of wholesale distributors is our greatest concern, we did just want to express concern about the pricing measure overall. We are concerned that it could add undue pressure on the generics and pharmaceutical marketplace, which is undergoing a lot of national strain, which could impact the supply of pharmaceuticals in Connecticut and the availability to patients. We also wish to briefly express our concerns with the wholesale importation piece, which is also reflected in HB 7192. We certainly appreciate the intent of that language, but we are concerned with how it would be compatible with the Drug Supply Chain Security Act. This is a federal law designed to make the U.S. supply chain even more secure. It's a track and trace requirement law, which is in the final stages of a 10-year implementation. So we are just concerned about that conflict there. So in conclusion, we do believe that there are some critical amendments needed to SB 11 to ensure that it accurately represents the supply chain and the supply chain can remain resilient in Connecticut. To echo an earlier sentiment, I really appreciated the chance to participate in the Prescription Drug Task Force. Really appreciate that chance to share our views and our concerns today. Just want to thank the committee so much for your time. And that's 3 minutes, so thank you.
Well done. So it's great to see you again, and thank you for your work with the Bipartisan Prescription Drug Task Force. And I think we had some drafting issues with SB 11 and the bill last year. And I would love to work with the association just to understand if we got that definition right or if it needs to be tightened. So thank you for that. Are there questions or comments from members of the committee? Seeing none, thanks for being here this afternoon.
Thank you.
So next we have Lauren Schwartz, followed by Tanisha Senior. Did we lose Lauren again?
Oh, nope, I think I should be on.
You are on.
All right, wonderful. Well, I so appreciate it. Thank you to the chair and members of this committee, especially for the opportunity, given that we circled back around to allow me my time. So I did submit this as written testimony. So hopefully if I don't make it all the way through, you have it to reference later. But my name is Dr. Lauren Schwartz. I'm a board certified psychiatrist in private practice and a senior fellow with Do No Harm. And I'm here today to speak in opposition of SB 1481. As a medical doctor, I took an oath to first do no harm. SB 1481 would ask providers to violate that oath to receive Medicaid reimbursement. And while I recognize and applaud this bill's effort to prevent discrimination in healthcare, this bill lends itself to interpretation that could conflate the discriminatory concept of a provider deciding whether or not to provide healthcare based on certain traits, including gender identity, with the concept of providing optimal healthcare for each and every patient, regardless of how they identify. Throughout my career, I've taken a measured, evidence-based approach to the care I provide, ensuring that I accurately and appropriately treat all of my patients. So due to the language in this bill, currently, I'm compelled to address gender-affirming care. Gender-affirming care represents substandard practices, demanding that providers alter healthy bodies to better align with a child's internal sense of self, hinder their development, and risk permanent damage, sterility, and long life dependence on medicine. It's been presented to countless young patients and their families as life-saving, necessary, and evidence-based, but it simply is not. There's a complete lack of evidence supporting safety and effectiveness of puberty blockers, cross-sex hormones, and surgical procedures to treat gender dysphoria. One of the things I wanted to highlight just about this particular bill is that SB 1481 invites action from the federal government to sue the state for failing to comply with recent guidance from the Centers for Medicare and Medicaid Services entitled Protecting Children from Chemical and Surgical Mutilation. It was released less than a week ago on March 5th. The dismissal of SB 1481 is a matter of good public policy and mindful stewardship of state resources. And as a new administration takes hold in our nation's capital, for better or worse, that has already signaled its commitment to enforcing evidence-based care for our children. With that in mind, I just urge the members of this committee to vote in opposition of the SB 1481, and I'm happy to take any additional questions.
Thank you, Doctor, for your testimony. Are you I didn't see this in the testimony. Are you in Connecticut?
I'm not.
Oh, okay. So when you say that the bill would require you to provide care that's outside of your conscience or your scope, that's not actually, it wouldn't apply to you, right?
It wouldn't apply to me personally. It would apply to physicians.
Okay. Well, I appreciate your point, but I guess I don't see anything in the bill that would require you to do anything other than not discriminate against what you wouldn't be covered anyway, but other doctors in Connecticut wouldn't be required to discriminate. It would be required not to discriminate against their patients, not to provide any particular service. I don't see gender affirming care specified here. Are there comments or questions from members of the committee? Seeing none, thank you very much for your testimony. Next, we have Tanisha Senior, followed by Sam Hallmeyer. Hello.
Hi, Senator Lesser and esteemed members of the Human Services Committee. My name is Tanisha Signor. I'm the Policy Director at She Leads Justice, formerly known as QUELF. We're a statewide nonprofit that uses a justice and equity lens to advocate for under-resourced and marginalized women and girls in the state. I'm testifying today in support of HB 791, SB 806, and SB 807. I don't know if I'll get to all of them, but I'll start with HB 7191. We thank the committee for proposing this bill, and as a leader in advocating for marginalized women and girls in the state, we support instituting structural improvements to our state's Medicaid plan to ensure the long-term sustainability of Medicaid providers. We stand in coalition with Planned Parenthood of Southern New England and Reproductive Equity Now in their critical advocacy work to modernize Connecticut's Medicaid reimbursement rate system. We urge the committee to fund an increase in reimbursement rates for family planning clinics, as well as rates for abortion services, which have not been adjusted since 2008. The Department of Social Services Medicaid rate study provides us with important information regarding reimbursement rate setting based on benchmark states. That will help us ensure the long-term sustainability of reproductive health care providers in Connecticut. HB 7191 will increase rates to Medicaid providers over a 3-year phase-in and bring us in line with following guiding states such as Oregon and Maine. It is critical for our state to reaffirm our commitment to reproductive health care for everyone in Connecticut. Healthcare providers in our state need to be compensated wholly for the services they provide. Raising Medicaid reimbursement rates is essential to creating an ecosystem of health equity in Connecticut. We urge the committee to vote favorably on it. SB 806. We're a proud member of the Husky for Immigrants Coalition and support the update in emergency Medicaid coverage presented in 806. It is critical that we ensure all uninsured Connecticut residents can access care for life-threatening chronic conditions. It will go a long way for undocumented immigrant communities in our state being able to access emergency care. It is critical that we pass legislation that helps address the immediate healthcare crisis in our immigrant communities. When communities don't have access to affordable and comprehensive healthcare, our state is impacted negatively in many ways. Limiting access to healthcare for chronic illnesses means that manageable cases become more serious and require extensive treatment that ultimately is more expensive. No person or family should risk their economic security, or experience extreme debt to receive life-saving treatment. All Connecticut communities and residents deserve access to emergency care. How am I doing? Okay, I won't get into 807 then. I'll stop really.
Thank you for your testimony. We will read your written testimony about Senate Bill 807. Are there questions or comments from members of the committee? Seeing none, thank you for being here this afternoon. Next, we have Sam Hallmeyer from PCMA, followed by Paul Pescatello. Good afternoon, or maybe evening, Sam.
I was going to ask you, is it afternoon or evening? What's the official?
I think we're across the threshold.
Well, thank you, Chair Lesser, Chair Gilchrist, and members of the Human Services Committee. For the record, my name is Sam Hallmeyer with the Pharmaceutical Care Management Association, otherwise known as PCMA. PCMA is the National Trade Association for America's Pharmacy Benefit Managers, and PBMs administer prescription drug benefits for over 275 million Americans. I am here today to oppose Senate Bill 11 and House Bill 7192. I did submit written testimony prior to the hearing, so I will keep my comments brief. But before I discuss our concerns with the two bills, I want to remind the committee that there is no state or federal law that would require plans to work with a PBM. Plans could work with drug manufacturers and pharmacies to create a network of pharmacies themselves, but they find that the purchasing power of PBMs and then the networks that they build can help save on costs. And additionally, PBMs have no say in the price that pharma sets. That alone is done by them. So we have three main concerns with the bill: how PBMs are compensated, PBMs acting as fiduciaries, and then a ban on spread pricing. So the language on how PBMs are compensated is going to be on Section 24, Senate Bill 11, and Section 2 of House Bill 7192. So this language would prohibit plan sponsors from choosing performance-based contract arrangements and paying their PBMs on how well they perform by reducing the cost of drugs that pharma sets through rebates. It would change the business model for PBMs and how we negotiate with drug manufacturers, resulting in pharma, we think, having to offer less of a rebate, and PBMs would be paid on a flat fee arrangement. So we think due to pharma having to offer less of a rebate, we anticipate plan sponsors in the fully insured commercial market to see an increase of about $301 million in premiums in 2026. So Connecticut patients will be paying those premiums. Additionally, the state of New Mexico considered this PBM compensation policy on how PBM in the general fund, and it generated a fiscal note of over $60 million in 2026, resulting in the bill being defeated in committee earlier this year. So to be clear, this bill does nothing to lower the cost of drugs set by pharma. It only impacts how plan sponsors pay their PBM. So I think there's going to be other people testifying that PBMs prefer higher list price drugs, yet here I am right now pleading and begging pharma to lower their prices. They alone have the ability to do so. Next, I want to discuss PBMs as a fiduciary. This language will require PBMs to act in the fiduciary duty to a health carrier. PCMA, along with the Department of Labor and federal courts, have stated that PBMs are not fiduciary because PBMs, quote, do not exercise discretion in setting prices when prices are set according to contractual terms. So all those contractual terms are decided by the plan sponsor, and the PBM serves an administrative role administering that plan. So fiduciary mandates, we think, would subject PBMs to broader legal liabilities, and added plan costs would be about $60 million in 2026. So finally, I want to discuss the ban on spread pricing. Spread pricing is a type of risk mitigating contract for plan sponsors to choose. It just offers more predictability for plan sponsors to lock into a price.
Your time is complete. Please summarize.
Thank you. I want to thank the committee for allowing me to testify today in opposition to Senate Bill 11 and House Bill 7192. We were worried that many of the policies mentioned in these bills are actually going to raise costs for Connecticut consumers and patients. And I thank you for the time. I'm happy to answer any questions.
Thank you, Sam, and I appreciate your work with us on the task force. I know that you would have wished we went in a different direction, and I appreciate that. And I know you were actually just telling us about your concerns about the spread pricing provision, and you were getting an awful lot of content in 3 minutes, and I just didn't know if you wanted to just elaborate, finish your thoughts there so we could understand.
Yeah, I appreciate that, Chair Lesser. So there was in the task force report, there was a cited document, I guess, if you will, from the Ohio auditor on it would save the state of Ohio over $200 million. I believe that was the quote. So that quote and article was actually done in 2018. The ban on spread pricing actually didn't go in effect until 2019. So I think that was a predictive, we think this might save $200 million. Well, the Ohio Department of Medicaid actually released a report later in 2019 in the fall, and it showed that there was actually an increase in payments to pharmacies of 5.74% in Q1 2029, or $38 million. So again, that was an increase in spending and not a decrease is what they originally had planned on, or predicted rather.
Thank you. That's good to know. Are there questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Look forward to continuing the conversation.
Thank you.
Next, we have Paul Pescatello, followed by Audrey Flynn, followed by Allison Fora. Good evening, Paul.
Good evening, Senator Lesser and the rest of the committee. Thank you so much for this opportunity to speak before you. Again, I'm Paul Pescatello. I'm Senior Counsel at the CBIA, also Executive Director of its Bioscience Growth Council, Chair of We Work for Health, Connecticut, and I was also a member of the task force, the Prescription Drug Task Force, and its 4 subcommittees. I'm here today to speak on SB 11, an act concerning prescription drug access and affordability, and HB 7192, an act implementing recommendations of the Bipartisan Drug Task Force. Because much, if not all, of 7192 is subsumed in SB 11, and because both pieces of legislation contain a cornucopia of healthcare reform proposals, and because you have my written testimony, I'll limit my comments to 4 broad policy considerations put forth in this legislation: supply chain reform, price controls, 340B, and importation of drugs from Canada. Supply chain reform. We support changes to the drug delivery supply chain, including greater transparency in the flow of drugs, of drug discounts and rebates. It's important that we ensure that such discounts and rebates inure to the benefit of consumers and patients, not PBMs and other middlemen. Although concern over medicine price inflation is reflected in SB 11 and HB 7192, its price control provisions, the data show that for the past 5 years, net prices for on-patent medicines have increased at or below the rate of inflation. Such prices are projected to actually decline by 4% through 2028. Unfortunately, the discounts and rebates that are partly responsible for this modest medicine price increase profile often do not make their way to what patients pay at the pharmacy checkout counter. In addition, insurance plan deductibles and quote-unquote co-insurance often translate into patients paying a significant portion of a medicine's list, not discounted price. Now, on price controls, SB 11 would limit price increases drug manufacturers can charge for generic and off-patent drugs to the Consumer Price Index. This ignores that the Consumer Price Index is an average of a broad spectrum of products. The CPI does not reflect the rate of inflation for any one specific product category. The overall inflation rate in January, for example, for eggs was 3%, while it was 3%. It was 15.2%, while it was 3% overall. I could go, you have my written testimony. There's a lot on price controls. You've heard me say this before. They absolutely never work wherever they've been tried. They cause all sorts of shortages, and it's just not a workable solution. 340B, again, you have my—
Your time is complete. Please summarize.
Okay, I'll summarize. 340B, again, you have my written testimony. I think the key to 340B reform is to link 340B discounts to 340B patients. I think that's what's missing in the legislation. And on Canadian importation, it's just, it's like, I call it a vampire policy. It keeps coming back. The Canadians have come down to this General Assembly and said they're not going to allow it. And there just isn't the supply of drugs in Canada to supply anybody in the United States. It's not working in Florida or Colorado. They have approval from the FDA to proceed to design a program, but the drugs have not flowed from Canada to Colorado or to Florida, and they absolutely will. The Canadians just will allow it. So with that, I'll be happy to answer any questions.
Thank you, Paul. It's always good to see you. Just a question about the Canadian piece. You know, I'm not sure that Canadians are willing to sell Americans anything this week.
That's very true.
But we keep hearing the same concerns every year. This absolutely won't work. Nobody will ever. It will never. It's not doable. And by the way, you better not pass it. So, you know, either it will work and lower the price of prescription drugs, or it won't work. And I guess if it's not workable as you suggested, then what is the great danger?
Well, it's because there's I think a lot of time and administrative costs just in applying for federal designation, all the resources from state agencies just going into trying to set up this program, which just absolutely will never work. Again, there's not the supply. Also, as I say in my written testimony, in all the different parties in Canada and in Connecticut who would have to vouch for the safety and efficacy of the drugs, they're just not going to do it. They're not going to be able to. They're not going to take that risk, so that it's unworkable on so many different fronts.
Well, thank you. I think there is no shortage of things we could talk about, and in the interest of time, we don't need to do that, I think, today. But appreciate your testimony and look forward to working with you and CBIA and BioCT on looking at this issue in greater depth, and appreciate all of the work that you've done with us so far. Are there questions or comments from members of the committee? Seeing none, thank you.
Thanks so much.
Next, Audrey Huang, followed by Allison Fora.
Great. Hello. Thank you. Hi, members of the Human Services Committee. Thank you for the opportunity to testify in support of House Bill 7191, an act concerning Medicaid rate increases, planning, and sustainability. My name is Audrey, and I'm the Director of Behavioral Health Operations at Fairhaven Community Healthcare. I'm not the first nor the last person today to testify from our New Haven-based health center. So you may have heard repeatedly that as a federally qualified health center, we serve nearly 25,000 Medicaid patients annually, which is almost 70% of our patient population. And at Fairhaven, we provide critical and high-quality services to a community that needs and deserves it, utilizing a fraction of the resources that many private healthcare institutions have access to, including those that I have previously worked at. Specifically in the behavioral health arm at Fairhaven, I work with some of the most diligent, most compassionate providers and administrative staff. They bend over backwards working to accommodate our ever-growing patient needs, squeezing in patients long after designated clinic hours because there's always more people needing appointments, writing progress notes into the early hours of the morning, managing overwhelming wait lists that can grow to hundreds of patients long. Our wait times for some of our most in-demand programs, including those for children with neurodevelopmental diagnoses and individual therapy, span from 8 months to over a year at times. And the problem that these services face is that they're not always financially self-sustainable because they are not reimbursed at the rates that they should be. Instead, these programs are kept running through passionate clinic staff who constantly learn to do more with less, oftentimes at the risk of burnout. Our center loses over $100 on each Medicaid medical visit and over $121 on each Medicaid dental visit. And I imagine comparable losses for many behavioral health visits as well. We must rely heavily on receiving time-limited grants and one-time philanthropic donations to even consider expanding many of these critical services. As a recent Medicaid rate study conducted by the Department of Social Services showed, Connecticut health centers receive on average 75 to 80% of the fees received by health centers in these neighboring states of ours. We have the lowest reimbursement rates to health centers in New England, the lowest in the Northeast, and are amongst the lowest third in the country. And these Connecticut health centers provide services to 440,000 people annually, including 264,000 Medicaid enrollees. So we are in unprecedented times, facing threats to federal funding and Medicaid. All the while, the need for services, especially primary care and behavioral health services, continues to grow. At FCHC, we believe that everyone has the right to healthcare, and we remain committed to serving our community, but we can't do it alone. It's time for Medicaid rates to reflect the true cost of care, and we urge the committee to support this important bill. So thank you for your time and consideration.
Thank you for your testimony, and it's great to see Fairhaven show up in force tonight. Are there questions or comments from members of the committee? Seeing none, you have a good evening. Next, we have Allison Forak, followed by Maureen McIntyre.
Great. Thank you, Senator Lesser and the members of the Human Services Committee. I'm going to try to be as brief as possible. I did submit testimony related to SB 1482, an act concerning an elderly nutrition program, and its crossover, kind of a crossover between SNAP and the elderly nutrition program. As we had discussed at the Nutrition Task Force previously, it's truly wonderful to engage multiple-pronged approach to support older adults with their food security. However, I feel that this legislative suggestion may incur more administrative cost to that in DSS, providing lists to the Senior Nutrition Program and Senior Nutrition Program focusing that way. Thankfully, we are doing a lot of great outreach and effort to ensure that people that enter supportive services through either of those methods is becoming more knowledgeable about the other areas of nutrition support that are available to them, so that somebody on SNAP would be encouraged to go to a congregate meal site or participate in the Senior Nutrition Program. And likewise, the Senior Nutrition Program participants have availability for somebody to assist them with SNAP application and education to reach different areas of providing meals. The meals provided through the Senior Nutrition Program are certainly a healthy option for SNAP participants, so I'm not opposed to that in that way. I just feel that the way the bill is written may increase administrative burden on both areas, which are already doing great work in the efforts to improve food security. And likewise on SB 1475, including the food deserts and the SNAP program, I think the DSS commissioner already mentioned to that a little bit about the restaurant meals and how that can work for people 60 and over, and we'd certainly support increasing access to that option for people that are on SNAP. And while I'm here, I was also going to mention a little note to HB 7190, an act concerning the study of the Department of Aging and Disability Services, in that we are currently in and have been in process of doing a lot of study of needs and what goes into both regionally at the area agencies on aging and statewide cumulatively of needs of older adults and what services are more required and would need funding. So we appreciate the interest and concern and would love to share that information as it becomes available. And I didn't get a warning, so I'll open it up for questions or yield my time.
Great, thank you. So if you don't like the language here for signing folks up for SNAP, how are your efforts working in terms of, this was one of the recommendations of the task force, was that we find better ways to enroll seniors who are eligible in the SNAP program. And I'm just curious how those efforts are going. Do you have numbers? Do you have specific recommendations about how we could streamline that or make that work better?
I could get you numbers. I know that we definitely had many people, just in my Eastern region, we had at least 10 people that weren't on SNAP before enroll in SNAP because of the farmers market the farmers market nutrition program, and that's through educational outreach. And then the use of the Form 5, which is what people use as they're getting onto the senior nutrition program, continues to include that educational outreach. All of the nutrition educators include SNAP education as well. And we're really looking at how can we reach people in different ways. Sometimes it is that person-to-person interaction, and sometimes we're doing, a little bit even more YouTube educational outreach on how you can use SNAP benefits for online shopping for people that are in that mode of using services. So it's really just, it is work in progress. But I just don't know that the wording of purchasing meals, it creates an issue of people being eligible for the senior nutrition program because of their age, because it's an Older Americans Act funded program, versus SNAP is a financially related means tested programming, and how the two meet in the same senior center could be a challenge. I'm not saying it couldn't happen, but I'm just saying it didn't seem like an easy fit without some administrative issues for everyone involved.
And for the congregate sites that you offer or for the home delivered meals, are you able to bill SNAP for that service? I would imagine no, but
No.
That's something no.
No, the congregate sites funding for the senior nutrition program is through the Older Americans Act, and also the funding that comes from the state budget in support of the senior nutrition program. But that goes all into one budget. So the process at a senior center site, for example, they don't have somebody there with a card reader, checking people in as far as that individual access to their program goes. I'm not saying it couldn't be possible, but it would also, create more concern over the privacy of the individual on SNAP. If we looked at something that was more, if the nutrition providers were able to be set up more like a retail market that was separate or in addition to the senior nutrition program, that might be an option. But all in the same place doesn't necessarily increase the person's access to food, because if somebody is 60 or over, they're eligible to go to that meal site without taking funding off of their SNAP card.
We had a hearing. We were, in addition to everything else today, we're having a hearing on a bill that would opt Connecticut into the restaurant meals program, the waiver program under SNAP, and that's why I know that Massachusetts has used SNAP to pay for food trucks and sit-down restaurants, and Rhode Island for subways. But I'm curious if that might not be a model that.
And to that, and I'm happy to talk about it with you, further, Senator Lesser, in as such that it might be something in addition to the senior nutrition program, so that if the meal providers had a meal that was ready to leave the senior center with the person, and you created some kind of retail environment, that might work, that it would be able to go. But I wouldn't want it to replace that person's eligibility for the senior nutrition program, so that they're getting maybe more use of the meals instead of utilizing their already limited funding for SNAP benefits.
Okay. I mean, the struggle that I have is, obviously there's a category of seniors who are SNAP eligible who cannot cook meals for themselves. So you're creating low-cost meals to them, but they can't, they can go to a grocery store and purchase food with their SNAP benefits, but they may be homebound, so that doesn't really help them, and they can't cook because they're homebound. So to me, it seems like you've got a finite amount of money through the Older Americans Act, and you should be getting more, but you're not. So why not find a way to use the SNAP benefit that they're not able to use to pay for additional food support? Maybe I'm missing something, but it seems like these two programs should be able to talk to one another more than they currently are, which is not at all.
It would, similar to what you were discussing as far as the restaurants and the food trucks and everything else, it's definitely a good and interesting model for people that don't cook or can't cook or, aren't physically able to cook. So I'm not saying it's a bad idea. I'm just saying it's something that would need to be worked out in different than the noontime meal. If somebody's eligible to come in and have that meal without it coming off of their SNAP card, that actually for the person is another meal instead of another way to get a meal. And if they're already able to get to that location, there are ways of potentially looking at the home delivered option if they wanted like a second meal in addition to their one meal that's through the Older Americans Act. But I'm just saying there's administrative consideration to that as to how it could be done. It's not an easy implementation.
Okay. Representative Hughes.
Thank you, Mr. Chair. Through you, I just wondered if you had gotten a chance to respond to the Office of Food Advocates survey about, mapping out food access, distribution throughout the state that was administered, I think last, December, maybe.
Right, as part of the food policy?
Yes.
Yes, I did.
Okay, great. So you're aware of that office and our attempts to map out food access and address food deserts, right?
Yes.
Okay, thank you. That's all, Mr. Chair.
Thank you. Other questions or comments from members of the committee? Seeing none, thank you for being with us this afternoon. Next, we have Maureen McIntyre, followed by Heather Gates.
Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Maureen McIntyre. I am the CEO of the North Central Area Agency on Aging, and I'm here on behalf of Aging CT in support of Senate Bill number 306. You just heard from my colleague Allison on the food security, so I'm very happy to be here regarding the act providing for the phased-out elimination of asset limits in the Husky C program. You will find the very excellent written testimony of my colleague Marie Allen in your submissions, and so my verbal testimony today is simply to expand upon her presentation, which you will be hearing shortly. If I may provide 3 brief statements in terms of context, however. Number 1, under Husky C, the eligibility for Medicaid is more stringent and more restrictive for older adults and individuals with disabilities than for everyone else. Number 2, the average monthly Medicaid cost of nursing facility placement is $9,000. And number 3, home and community-based care costs, on average, about 1/3 less than nursing facility care. So throughout the past few weeks, and again today, this committee has been tirelessly considering bills with respect to Connecticut citizens who are also Medicaid recipients. Passionate advocates and consumers has prevented exhaustive testimony in support of what is ultimately a very basic ask. Please do right by your constituents who are most at risk. And meanwhile, as legislators, you are duty-bound to ensure that your decisions are constitutionally and fiscally responsible. Senate Bill number 306 accomplishes both. It ends discrimination by treating seniors and people with disabilities the same as other Medicaid-eligible populations. And it saves the state of Connecticut money by preventing unnecessary nursing home placements. The link between expanded eligibility for healthcare coverage under Husky C and reduced nursing home placements is fairly self-evident. Access, prevention, diagnosis, and treatment fosters better health outcomes and leads to greater success in community living. But then there are the nursing home placements that are not even medically necessary. Rather, they're the result of an unexpected car repair, or a new furnace, or a ramp, or a roof. Again, throughout this session, this committee has heard compelling testimony about the dire need to address transportation and housing inequities, expressly preventing seniors and people with disabilities from accruing any sort of nest egg to withstand a financial calamity. Not only has a devastating human impact, it's costing the state of Connecticut money, and it's contributing to some of the most significant social health care needs that we're currently facing. This is counterintuitive to goals of this committee, and it's at odds with the wishes of Connecticut citizens.
Your time
We
is
sincerely ask that you support Senate Bill 306, and thank you so much for your time.
Perfect timing, Maureen, and good to see you. I appreciate your testimony on that bill, but just with respect to the questions I asked Allison a minute ago, do you have any thoughts on that?
I think that one of the most important things that we can do for our SNAP benefits and our SNAP beneficiaries is to continue the education and the outreach. I know that for many years, and I think unfortunately, it's just my history with being in this network for so long. There has been a stigma that we've been working really hard to overcome. There has been Historically a fear or a concept that, the applications are so difficult and you don't get that much for them anyway. And there has just been a lot of kind of that urban mythology around the SNAP program that unfortunately we're still fighting against. We don't want anyone to be leaving that money on the table. We want individuals to be accessing the services that are available to them now more than ever. So I think that the additional efforts in that education and marketing would be very, very well received. I do agree with Allison and with the commissioner that so much good work has gone into this and so much work has really paid off that I feel that we're on the right track. I really do. And I think that that's an important thing for Connecticut to be able to say.
Okay. So we can educate the public, but right now you can't use your SNAP benefits to purchase congregate or home delivered meal. So
Yeah. And yes, and so I also do agree with Allison because, and again, as our resident registered dietitian, I tend to take what she says very, very seriously as a student of this. What we really don't want is to create a situation where people are using one benefit and not another. I do appreciate that the committee is interested in really looking at the finite nature of Older Americans Act funds, because that is definitely going to be an issue. I believe that, the fact that this is an annual allocation of Older Americans Act funds and that there is a great interest in making sure those dollars go as far as they can. But we definitely don't want people who are eligible for a service to be spending their own or another source of federal funding to supplant. That's not, I don't believe that that's really the intent. I think that the intent is really to ensure that there are more options, but not necessarily supplant one with the other.
okay. Thank you. And this is I was looking for did you submit written testimony?
I did not, because I knew Marie had a 3 or 4 page outline of the Husky C issue. So rather I lent my my words instead in support of her very, very excellent and well-researched written testimony.
Understood. Well, thank you very much.
Have a great afternoon, everyone.
You too. Next, Heather Gates, followed by Mary Moberg.
Good evening, Senator Lesser and Representative Gilchrist, and members of the Human Service Committee. I'm Heather Gates. I'm the President and CEO of Community Health Resources. We are one of Connecticut's largest behavioral health providers, serving over 20,000 children, families, and adults every year throughout the state of Connecticut. About 70% of everyone we serve is on Medicaid, and the balance are either uninsured, underinsured, or have commercial insurance. We are also a CCBHC and a safety net for thousands in the state. Thank you for the opportunity to testify on HB 7191, an act concerning Medicaid rate increases, planning, and sustainability. So this bill is a really important first step related to Medicaid rates in the state. As we know from the rate study that was conducted over the last 2 years, the behavioral health rates in the state are grossly inadequate and not keeping up with the 5-state comparison, never mind the cost of care. Our desire is to see rate increases implemented in this budget for the next 2 years. And equally important to adopt and address a system to make sure that every year we are keeping up with the cost of delivering care so that we don't end up in the situation we're in now where we cannot afford to hire staff. We cannot meet the needs of those who come to us for help. And that's frustrating as a provider. We're here to provide care. We don't want to be turning people away, which we have to do now because we don't have adequate staff. So we urge you to pass this bill and also increase rates. It will not be adequate this year to simply pass a rate study. We need action on the rates, and we need to change the method in which they are set and determined every year. SAHAR's mission is to inspire hope for individual and community well-being, and our vision is that every life will get better. And if we have adequate Medicaid rates for our services, we will be able to do that and meet the needs of thousands more than what we're doing now because of the inability to fill clinician vacancies, given the rates we live with. Thank you for your time. I'm happy to answer any questions, and am here to help with anything you need.
We need help with an awful lot. I'm not sure you could help with everything, but we appreciate your testimony and you working with the committee on these issues and so many other things. Are there questions or comments from members of the committee? If not, thank you, Heather, and appreciate seeing you.
Thank you.
Next, we have Mary Moberg, followed by Peter Duell.
Good evening, Senator Lesser, Representative Gilchrist, and all the esteemed members of the Human Services Committee. I am talking about the Bill 807 and 11, Section 9, and I also probably go into the governor's bill. As a disabled person relying on services from the Connecticut Home Care Program, through MedConnect, the process of getting this support is challenging, and the challenge of sustaining it is scary. If you take the regular Husky-C elderly requirement, the average one-bedroom rent in Connecticut is $1,370 a month. My rent is $1,650. So if I get off MedConnect because I can't work enough, I will not be allowed to have enough income to cover my rent. And I know too, it took a while to find out that MedConnect could be associated with the Connecticut Home Care Program. And it maybe was introduced by my own situation because I kept pushing to say, can't I do this? But I am between a rock and a hard place because I need to sustain enough work to be on MedConnect or risk going into regular Husky-C with the amount of income less than what I can afford all my expenses to be covered with. So I appreciate the Connecticut Home Care Program. I would ask for both systems, MedConnect and Husky-C for elders and disabled, to be more realistic and reflective of current economic situation. Thank you.
Thank you for your testimony, and particularly, I think we would like to do both. We were able to get the MedConnect program modernized with those income and asset limits gradually phased out, and that is current law, and that's why it's a little disappointing to see the governor's budget and proposed implementer seek to roll that back. It just seems to me to be a step backwards. But we also, as you know, also have a proposal in SB 11 and elsewhere to raise the Husky-C asset limits as well. So I appreciate your advocacy and thank you for being with us this afternoon. Are there questions from members of the committee? Seeing none? Thank you.
I have a question for you, Senator Lesser.
We don't normally allow that. I guess I'll make an I'm getting a little.
I will not salute you.
Thank you.
I wonder what the regular people like us can do to help support Medicaid in the current federal climate. I did write emails to Representative and Senator, but is there anything else?
I think we need to make a lot of noise about how these proposed cuts will hurt the people of Connecticut. And the more noise we make, not all of it will get down to Washington, but some of it will. And I think that we've shown, we, not members of this committee, but the people of the country have shown that the advocacy around Medicaid has started to make a difference. We've seen folks respond to that. We've seen things being taken off the table. It would devastate, people with disabilities, seniors, a lot of people, poor people all across Connecticut if those cuts were to happen. So we need to make a lot of noise to protect our state and its residents. And some of that's happened, but there are lots of ways to make noise, but I think there's a lot that needs to be done. So if I had a magic answer, I would tell you what it is. I do not, and I don't. Maybe you could tweet at one or two people, but it is a good question. And if folks have suggestions, please let me know. Thank you for your testimony. And without any other comments, we will talk again soon. Next, I see Peter Doyle, followed by Sue Lagarde. No, Peter. Okay. Then Sue. Sue is here in person, and Sue once chided me for not allegedly not listening to her in a hearing, so I will be focused on her 100%.
Thank you. I really appreciate that. And I really appreciate everything that this whole committee does because it's a long day. I can attest to that. So good afternoon. My name is Dr. Suzanne Lagarde. I'm the CEO at Fairhaven Community Healthcare in New Haven. I'm testifying in support of HB 7191, an act concerning Medicaid rate increases, planning, and sustainability. Fairhaven Community Healthcare serves, as you've heard repeatedly, over 36,000 patients annually, providing full scope primary care services, including nurse midwifery, behavioral health, substance use disorder treatments, dental, and integrated care coordination. I want to start by saluting you and others in the General Assembly for bringing the current bill up for a public hearing. A bill virtually identical to this was promulgated in the last session in 2024, but never made it to a vote. With your support, the current bill will be voted upon and will become law. The issue of Medicaid payments to FQHCs and Connecticut's more than 20-year history of failure to comply with federal law has been a point of discussion for many years. Finally, we are now closer than ever to correcting this miscarriage of justice, and this opportunity comes none too soon. We are all aware of the changing federal landscape and the looming consequences for Connecticut's most vulnerable. Fairhaven Community Healthcare relies on over $6.5 million annually in federal funding, and that funding is now at risk. At the same time, changes to Medicaid eligibility seem inevitable. Fairhaven currently serves over 22,000 Medicaid recipients. If federal policies result in cuts to Medicaid, thousands of our patients will lose coverage and join the ranks of the uninsured overnight. For Fairhaven, this would mean a devastating financial double blow, a sharp decline in Medicaid reimbursement, while at the same time, a surge in uninsured patients seeking care. Without action, this combination will push health centers like ours to the breaking point, jeopardizing access to care for hundreds of thousands of Connecticut residents. Unlike other healthcare providers, health centers are not only committed by mission and vision to continue care for our most vulnerable, we are obligated by law to do so, regardless of insurance or ability to pay. Hence, this is your chance to do what is right by your constituents. The threats currently facing health centers are truly existential. The combination of decreased federal funding coupled with massive cuts to Medicaid might not be survivable. If the legislature passes HB 7191, which allows health centers to be reimbursed at cost as mandated by law, it will help to buffer the impacts of anticipated threats to both Medicaid and our federal funding. Senator Lesser, Representative Gilchrist, members of the Human Services Committee, we need your help. The threats are real and the solutions are limited. Ensuring the survival of health centers by complying with federal law is a logical step in attempting to address the upheaval in healthcare that is literally at our doorstep. Thank you very much for your time.
Thank you, Sue, for your testimony, and I agree with you. We have a lot. We've got a lot of work ahead and a lot of thoughtful well, we need to take a thoughtful response to some of the threats that are out there, and we want to lift up and support your work in doing so. I see Representative Gilchrist has a question.
No question. I just wanted to thank you for the work you do, for being here, and for so many of your team members testifying about the importance today too.
So I just want to say that month over month, I talk about the importance of advocacy, that we are the voices for our patients. And I'm incredibly proud that I just put out one email to my staff and said, this is an important bill. This is a time for you to have your voices heard. And more than 14 of my staff came here today, either in person or remotely, to advocate for our patients. So I'm very proud of them, and I just want to give them a shout out. So thank you.
Sign up a strong leader. Thank you so much.
Thank you.
Thank you very much. Yes, Representative Shake.
Thank you, Mr. Chairman. Doctor, I just want to say thank you for all the work that you've done and that you and your staff continue to do. I work in healthcare, and I have heard nothing but just amazing stories about the extent that you and your staff go to try and take care of people and the community at large. And it's noted, and really, I think a model for the state. And I just really appreciate even the amount of effort that you've decided to take in trying to educate and then motivate your staff so that they can be involved in this process. And it shows. So thank you for that.
Thank you so much. Thank you.
Thank you, Representative. Okay, off to hear our next 27 Fairhaven Community Health staff members. All right, next is Marie Allen, followed by Ashton Hurd, who does work at Fairhaven Community Health Center.
Good afternoon, Senator Lesser and Representative Gilchrist, members of the Human Services Committee. I will be brief, and I do apologize for keeping you here so late. My name is Marie Allen. I represent one of the 5 area agencies on aging. I'm here in support of Senate Bill 807 and House Bill 7191, and would be happy to address the nutrition questions at the end if Senator Lesser would like to hear another opinion on that. Regarding 807, Husky C has by far the most restrictive eligibility rules of any Medicaid program, with extremely low income limits of just $1,370 a month and an asset limit of $1,600. This asset limit counts the resources such as savings accounts, including the face value of life insurance policies, funeral burial contracts that applicants have beyond their earnings and income. Connecticut limits assets to $1,600. It's inadequate savings and makes it dangerous for residents who want to get their care in their home in the community. Increasing the asset limit would allow residents to fund those financial emergencies. Without savings, these residents look at skilled nursing care, nursing homes as the only alternative, because they know if their roof goes, if they have to repair something in their home, they will not have the money to do so. So please consider the elimination of the asset limit. And then regarding Bill 7191, an act concerning Medicaid rates, planning and sustainability, I would ask if you would consider the unseen workforce of the personal care attendants, the companions, the homemakers that are all part of that Connecticut home care program. They are the people that are spending 4 to 8 to 12 hours with older adults, persons with dementia, individuals who cannot be left alone during the day when family members have to go to work. They need this Medicaid increase so badly. The agencies that support them have faced minimum wage increases over the years, increases in rent, increases in health insurance, and mandates like the sick leave policy that Connecticut will mandate. And those costs are keeping good qualified agencies out of the Medicaid space and limiting the viability of the Connecticut home care program, because we just don't have quality agencies to connect to older adults who are vulnerable and persons with disabilities. That ends my testimony.
Thank you for your testimony. I will take you up on your offer. Tell us about elderly nutrition and answer my question if you don't mind.
Absolutely. I think that you brought up an incredible point that we have not really discussed between the Department of Social Services and the State Unit on Aging, or the Bureau on Aging. We did not look at SNAP benefits as an alternative payment source to home delivered meals. And I think it's something that definitely could use more discussion. And just because it's complex, because I'm sure administratively it's complex, anytime you're billing the federal government for anything, it's very complex, but it's something we should look at, because Senator Lesser, we don't have enough money in the Older Americans Act, and the state will never have enough money to feed every mouth that's hungry with home delivered meals. So if the alternative is going through a little administrative strife so that we can add capacity to the home delivered meal program, I think we need to bring certain members of that task force back together. We need to figure out what is the pathway to offering that. Keep in mind, home delivered meals is only one, or in some cases 2 meals a day. So the SNAP benefit covers that breakfast meal, covers a little snack, covers a nutritional supplement that may not be part of the home delivered meals. But again, anything we can do to diversify the funding sources would allow us to feed more people. And I think we're at a point, the task force proved that we're at a point where we have to start to look more creatively at all options.
That's great. So I will love to work with you and the members of the task force, bring the band back together, and see if that administrative complexity is impossible to solve, or if there's some there that would work. Worth the conversation with DSS to get their take. But appreciate your thoughts on that and your testimony on those other bills. Other questions, comments from members of the committee? Seeing none, thank you.
Thank you.
Next, Ashton Hurd, followed by Rachel Cottle Lapham. I guess that I just made one crack and everybody left from Fairhaven. All right. Rachel, is Rachel on? Rachel is on, followed by Thomas.
Yes, I am. Hello. Good evening, Chairs Lesser, Gilchrist, and members of the Human Services Committee. Thank you for your time. My name is Rachel Cottle Latham. I'm Senior Director for State Policy representing PhRMA. PhRMA recently appreciated the opportunity to participate on the Prescription Drug Task Force, and we support the inclusion of a number of policies in House Bill 5913 as reflected in our submitted statement. However, PhRMA respectfully opposes several provisions in Senate Bill 11, and I will highlight just a few of these concerns as we provided more comprehensive written testimony. First, this bill would penalize manufacturers for sales exceeding a reference price tied to the Consumer Price Index. This proposal is premised on the idea that drug prices are rising sharply or significantly driving overall spending, but it is well documented that manufacturers are giving larger discounts to insurance companies, middlemen, and hospitals each year, totaling around $334 billion in 2023 alone. Net prices have increased below the rate of inflation for a 5th year in a row now and are projected to decline by up to 4% through 2028. And in fact, half of every dollar spent on brand medicines goes to entities that play no role in the research, development, or manufacturing of those medicines. But imposing an arbitrary price cap would penalize manufacturers for increases in list price, even where there may be no corresponding increase in net prices. And we respectfully urge the committee to oppose this provision. In addition, concerning sections 17 and 18 of the bill pertaining to the federal 340B program, I want to be clear that PhRMA strongly supports the original intent of the 340B program. However, the program of today has strayed from its true safety net purpose and is in need of systemic reform. Counter to the intent of this bill, section 17 and 18 would lock in exactly what is broken about the 340B program and enshrine in state law problems that are increasing the program's market distortions and increasing profits for PBMs, big for-profit chain pharmacies, and large hospitals, as evidenced by a Minnesota Department of Health report finding that contract pharmacies and third-party administrators receive around $16 of every $100 of gross 340B revenue. Between 2010 and 2023, in fact, 340B discounted purchases surged from $5 to $66 billion, and contracts between covered entities and pharmacies grew by over 12,000% over the same period. But there is scant evidence that these discounts are reaching the patients the program was designed to help. The 340B program has often been touted as cost-free to taxpayers, but it is clear that the program is driving up costs for employers, patients, payers, and Connecticut's healthcare system as a whole. Here in Connecticut, employers pay an estimated $121 million more in healthcare costs due to foregone rebates from manufacturers, leading to a $5.9 million reduction in state and local tax revenue. And finally, it's important to emphasize that a pharmacy's status as a contract pharmacy has no impact on whether or not a patient can pick up their prescriptions, just whether a covered entity receives the 340B discount. So in
Your
conclusion,
time is complete. Please summarize.
yes, thank you so much. We'd urge the committee to oppose these provisions and consider our remaining written comments on Senate Bill 11. Thank you very much for your time.
Thank you for your testimony and thank you for working with us on the bipartisan prescription drug task force. Are there questions or comments from members of the committee? Seeing none, thank you again, and look forward to continuing to hear from you.
Thank you, Chair.
Are there, next up, we have Thomas Burr, followed by Christina Emery.
Yes, good evening, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Thomas Burr. I'm the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. NAMI is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. For anyone not familiar with us, more information is included in my written testimony. I am testifying today in support of Senate Bill 807, an act concerning the elimination of asset limits for Husky C beneficiaries over a 5-year period. One of NAMI's core beliefs is that all people with mental health conditions deserve accessible, affordable, and comprehensive health care. When people with mental health conditions are able to access health care, lives are improved, lives are often saved, and as a result, people are in many cases able to work and contribute to society. However, as private healthcare insurance premiums become more and more expensive and the deductibles become increasingly higher, people with limited incomes increasingly find themselves priced out of the market or unable to access care, even if they can afford the premium out of an inability to pay the deductible. And when asset limitations are part of the criteria, the only way to obtain necessary health care is to basically impoverish oneself through a liquidation of assets. This is a cruel and unfair process, and we, as one of the richest states in the union, should be better than this. And extremely low asset limits for Husky C, which have not been adjusted since implemented in the 1970s, mean it is impossible for the elderly and disabled individuals to save up for emergencies like car repairs, to obtain technology improvements needed by disabled individuals, or to put money aside for down payment or a security deposit on a new apartment. So amending SB 807 to require the same income test for Husky C as for Husky A and D will end income eligibility discrimination against disabled adults and older adults. On a related note, we oppose Senate Bill 1251, which is the governor's bill to implement his proposed cuts to Medicaid, including cutting back the scheduled income and asset increases over time that were passed last year for Connecticut's MedConnect program. We also support House Bill 7191, an act concerning Medicaid rate increases, planning, and sustainability. So I thank you for your time and consideration.
Thank you, Thomas. Are there questions or comments from members of the committee? Seeing none, you have a good evening.
You too, sir.
Next, Christina Emery, followed by Alice Forrester, followed by Allie Mendelson, followed by Sarah Fox.
Good evening, Senator Lesser, Representative Gilchrist, Representative Case, and distinguished members of the committee. My name is Christina Emery, and I'm here on behalf of Brooker Memorial in Torrington to testify in support of HB 7191. Thank you for your dedication to Connecticut families and for considering legislation that addresses the long-standing low Medicaid reimbursement rates. Brooker's Pediatric Dental Clinic is the largest provider of oral health care to low-income children in Northwest Connecticut, with over 85% of our patients on Medicaid or uninsured.
Last year alone, we provided more than 9,100 dental visits to 4,700 children, including in-school services across 7 towns. The preventative care we provide eliminates long-term oral health problems, reduces emergency room visits, and alleviates strain on the healthcare system and state budget. Like other dental providers, continued low Medicaid rates are putting the financial sustainability of our safety net program at risk. Recently, the local FQHC was forced to close its adult dental clinic, and just today we were notified by a private practice that they will no longer accept our referrals for patients on Husky that have significant decay and need oral surgery. Last year, our dental program operated at a $330,000 loss, an average shortfall of $36 per visit. While we supplement with investment income and work to secure grants and donations, the financial strain jeopardizes our ability to serve at-risk children. We have made significant investments to expand access, including hiring a second full-time dentist, ensuring bilingual care, and partnering with UConn's dental residency program. But with only 62% of Husky enrolled children in Northwest Connecticut receiving dental care, we must do more. Recruit more providers, invest in new equipment, and expand school-based clinics. Without higher reimbursement rates, however, these efforts are not sustainable. To ensure equitable access to care, we urge you to include nonprofit safety net providers like Brooker Memorial and Medicaid rate increases. Specifically, we request that reimbursement rates be brought to parity with the PPS rate paid to FQHCs, and that a system for annual rate adjustments be implemented to ensure long-term sustainability. Increasing reimbursement rates will help close the access gap and improve long-term public health outcomes in Connecticut. Thank you for your time this evening and for prioritizing the health of the state's most vulnerable children.
Thank you for your testimony. I've heard from you and other folks about some of the issues around Booker for a while, and I know it's important to a number of our colleagues, including our honorable ranking member. Question, I know that the Community Health and Wellness recently terminated their dental program and they have a partnership with you. Does that, I know that that's bad for access in your part of the state, but is that good for Booker's finances? Does that help stabilize that or not really? Does that not solve the issue?
No, we've always had a close partnership with Community Health and Wellness where we refer adult patients to them and they generally refer children on Husky to our clinic. So it really will certainly be a void to this part of the state for adults. It should not really impact our clinic per se.
Okay, other questions? Representative Case.
Thank you, Mr. Chair. Christina, so when we talk about the 7189, how do you feel as though that is going to bring your rates to where they need to be?
Well, we're looking for, as I said, parity with PPS rates. On average, our rates are considerably less, and we also acknowledge that the current PPS rates to FQHCs are likewise low. We do not receive any supplemental funding like other dental educational clinics or FQHCs do.
Thank you. And I think it's known, and you've made it very known in this building that Brooker and one other agency, I believe in the Hartford area, are one of the same that offer this type of service for children. Is that correct? And that's why it's sort of an oddball out, but it's not FQHC rated. It's a different program. Is that correct?
That's correct. There are 2 nonprofit safety net providers in Connecticut, the Greater Hartford Health Collective and Brooker Memorial, that are in this unique category as being a nonprofit safety net provider.
I won't take up any more time, but I thank you for testifying, and hopefully we can get something across the line. It seems that the Northwest corner always has something odd with having a different type of service, but I appreciate you servicing the children and working with Community Health and Wellness with their adults. It's admirable for what you do, but let's keep up the fight. Thank you. Thank you, Mr. Chair.
Thank you.
We would never call you folks odd up there in the northwest corner, Representative Case. You are decidedly not. Next, next we have Alice Forrester, followed by Ally Mendelson.
Thank you. Thank you, Senator Lesser and members of the Human Service Committee. And thank you for your real dedication to the and attention to the Human Services of Connecticut, and in particular for the Medicaid rate study, as well as the Bill 7191. I'm Alice Forrester. I'm the CEO of Clifford Beers Community Health Partners, is a network of nonprofits focused on the well-being of children, youth, and families across Connecticut, from Norwalk to Madison, New Haven to Bethany. I'm here representing today Mid-Fairfield and Clifford Beers Community Care Centers, two outpatient providers licensed by DCF that serve children and families. Together, and we serve over close to 8,000 youth and children and adults across Connecticut, and we have close to 420 employees, and all of them are fully committed to our communities. And together, we represent in total about 225 years of service to Connecticut. And honestly, we're exhausted. And we're exhausted by trying to make services available to all who come to our door with tremendous financial handicaps. And I'll give you an example. Clifford Beers has been open since 1913. And so in 1944, the Child Welfare, State Division of Child Welfare and Juvenile Courts agreed to a $10 per person fee for diagnosis and or treatment. If that $10 today was valued at $25, it would equal about $180.50. And currently, we get reimbursed for a 45-minute therapy session from Medicaid at $93. If that I can tell you from our colleagues, and I've been doing a lot of work with folks across the state, that about a 45 to 50-minute session in a DCF outpatient licensed clinic does cost today about $210. And that includes the salary, but also back office administration and all the data that's required by the state to be able to deliver the service. So we get reimbursed from Medicaid, as I said, for $93. And then DCF has an outpatient grant that some of us have, not everybody across the state. And that maybe covers about $50 for any kids over who are under 18. And that leaves about a $67 hole that's not covered by any income. So that's almost twice as much as the dental provider. And there's almost $177 loss for anyone over 18. And we at Clifford Beers have done a lot of work with kids over 18, in particular in the autism arena, because there's nowhere else for these kids to go. So over 81 years, the state has cut us from $10 in 1944 to $5.
Your time is complete. Please summarize.
So I just think it's very important for the state to take this. I think this bill is very important, and I'm really hopeful that we're able to get to the Medicaid rates that are suggested in the study. And I think that, just to remind folks, if we close, what would it cost for the state to actually deliver these services, which we really don't want to do. So thank you.
Well, that's sobering. Thank you for your testimony. Other questions or sorry, there's some crosstalk here. Are there questions or comments from members of the committee? Seeing none, thank you for your testimony and for your work at Clifford Beer. Next, we have Ally Mendelson, followed by Sarah Fox.
Oh, okay. Hi.
Hi.
Members of the Human Services Committee, thank you for your time. I wasn't sure I could unmute it. So I'm talking today about, I strongly support Bill HB 7191. This bill seeks to increase Medicaid reimbursement rates for chiropractic services in our state. I'm a chiropractor in Hartford, and I've been practicing for 32 years. So currently there's really low reimbursement rates, and it discourages many chiropractors from becoming Medicaid providers. And so by increasing rates for spinal adjustments to at least the federally established Medicare standard, More chiropractors would be able to participate in this Medicaid program, ensuring greater access to care for those who need it most. So I recently re-enrolled with Husky because I'm just committed to providing chiropractic care for children and adults who otherwise can afford it. But the reality is that I lose money treating these patients, but I do it because I really believe in it and I really value it. Unfortunately, most doctors can't afford to do this. So while keeping their practices open. So as a result, many families on Husky do struggle to access chiropractic care, leading to increased doctor's visits, higher medication use, more surgeries, and lower quality of life. So chiropractic care doesn't only improve health outcomes, but also reduces overall healthcare costs. And so by making this care more accessible, Husky could ultimately save money in the long run. However, for more doctors to participate, the reimbursement rates must be sustainable. Aligning Husky payments with Medicare rates would just be a game changer, allowing more providers to accept Medicare and Medicaid, remain in network, and serve these individuals who need this care very much. So I urge you to support Bill HB 7191 and help expand access to essential chiropractic care for Husky recipients. Thank you for your time and consideration.
Thank you. Thanks for being with us.
Yeah.
Any questions? Seeing none, thank you.
Thank you.
We have Sarah Fox, followed by Chris Pankratz. Is Sarah with us? There you are. Hi, Sarah.
Hello, greetings, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Sarah Fox. I'm the Chief Executive Officer of the Connecticut Coalition to End Homelessness, and we lead the Connecticut Can End Homelessness campaign, which is a statewide collective impact campaign aiming to prevent and solve homelessness across the state. I appreciate the opportunity to testify before you today in support of HB 7188, an act concerning homelessness and the CHESS program. The Department of Social Services' recent report on the CHESS program confirms a fundamental truth. Medicaid-funded housing support is essential, and we know when it's implemented correctly, it works. This program was designed to integrate housing and healthcare, and it's so important to have stable housing, and it's a critical determinant of health. Medicaid, and through this, it can provide pre-tenancy and tenancy sustaining supports and case management, which is exactly the services that our people need to exit homelessness and remain housed. DSS's own data shows that housed CHESS participants experience fewer hospital stays, nursing facility placements, and emergency room visits. And these are outcomes that we should and must be building on, not dismantling. I would, you have my testimony, but basically what I think is critical here is that having the 1915 I waiver and ensuring that it is a waiver that we're able to use and access for housing supports is critical. Many states are doing this well. In fact, North Carolina has seen an $85 cost of care reduction due to having a well-implemented program. We know that there were more than 6,800 people who applied for this program, so the demand for the CHESS program is undeniable. Only 292 were housed. We also know that doesn't make this program ineffective. What it means is that we failed to scale and implement it properly, and walking away from this program does nothing to address the demand. For us, it causes further challenges. After talking to providers over the course of the past few years, we know that they struggled so much with low reimbursement rates, noting that this is an unsustainable financial model, and that they had to do a lot of excessive upfront work that was not billable. We also know that it was not coordinated well with our coordinated access networks, leading to duplicity and hard to target people for the program. I would just say, in this time with federal uncertainty, we need every single tool in our toolkit. This is a tool that we can use, and we need to figure out how to use and implement it correctly. So thank you so much for hearing my testimony. I'm open to taking questions.
Thank you, Sarah, for your testimony on the chess program. It's been a long day. Were you here? We had some conversations about the program with Commissioner Barton Reeves and also with Kathy Zoll, and I was curious if you'd heard either or both of those.
I was updated on the conversation with Commissioner Reeves this morning, and I was able to listen in on some of the conversation with Kathy Zoll.
So Kathy in particular was pushing back on the notion, one question that I had was whether or not we should, align the program with the permit supportive housing program within DEMIS. And Kathy was arguing that it should really be a more expansive project. I mean, right now the department's proposing going to nothing, but do you have thoughts about what Kathy was suggesting?
I think when we have thought of this program and what Medicaid in this way can provide is supports for people who who span beyond people living with serious mental health and mental health challenges and or substance abuse challenges. And so what Kathy was saying this morning is looking at this in a way to provide services to people who don't have services able to be provided because they don't fit into the criteria to be served by DEMIS. And I do think that's something to note for consideration. It is a shame that this was not able to be implemented, and it's because we have a subset of the population who is not able to receive these services, and they'll be excluded from services if we move it over to DEMIS. So I heard what Kathy was saying, and I recognize the challenges that it creates.
Okay. Well, conversation for further discussion. We I've heard quite a bit though about the benefit of this program, and it would be a real shame if we had fewer options for.
I concur wholeheartedly with that.
Any other questions or comments for Sarah? Seeing none, thank you. Next, we have Chris Pankratz, followed by James Higgins.
Good evening, chairpersons, ranking members, and members of the committee. My name is Chris Pankratz, and I'm the CEO and co-owner of Masters in Home Care. We're a Connecticut licensed Medicare certified home health care agency, and I also serve as chair of the Government Relations Committee for the Connecticut Association for Healthcare at Home. I want to first thank this committee for your efforts to strengthen Medicaid home health care through HB 7191. To ensure this bill fully supports patients and providers, I urge the committee to consider the following key adjustments: ensuring that all home health services are properly funded. Phase 2 of the Medicaid rate study failed to include key home health services, most notably the medication administration rate, which per the study accounted for over 50% of Medicaid home health expenditures. Secondly, eliminating the subsequent visit rate penalty. The current structure slashes reimbursement by 50% for multiple patients in the same location. Yet each patient still requires the same level of care, including documentation, EVV compliance, safety procedures, physician notifications, and care coordination. Removing this penalty ensures that home health agencies can deliver more care without financial penalties. Next, accelerating the Medicaid rate increases. Home health agencies cannot wait until 2028 for sustainable reimbursement. Today, Connecticut's Medicaid rates are 59% lower than Medicare's. I urge the committee to revise the implementation timeline to provide a minimum 10% increase per year for the next 4 years. And lastly, tying Medicaid rates to inflation beyond 2028. Without an automatic adjustment, we're going to face this same crisis again in a few years. Indexing rates to inflation will ensure long-term stability and prevent future funding gaps. Home health care keeps people safe at home, prevents unnecessary hospitalizations, and lowers overall state healthcare costs. But without adequate reimbursement, agencies will continue limiting Medicaid services, leaving vulnerable residents without care and increasing overall state spending. So I respectfully urge the committee to strengthen HB 7191 by accelerating the home health care rate increases, indexing the rates to inflation, ensuring all essential services, including medication administration, are properly funded and included, and eliminating the subsequent visit rate penalty. Thank you for your time, and I welcome any questions and encourage the committee to review my written testimony for additional details.
Thank you for your testimony. Any comments, questions? Seeing none, thank you. Next, we have James Higgins, followed by Matt Barrett, followed by Nick Carapazos. No, James? Okay. Then Matt. Good evening.
Good evening, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Matt Barrett. I'm the president and CEO of the Connecticut Association of Healthcare Facilities, which is a trade association of some 160 skilled nursing facilities and several assisted living communities. And I appreciate the opportunity to testify on a whole range of bills. I've submitted perhaps a significant amount of testimony. So with your permission, I'll go and summarize our testimony, beginning with House Bill number 7189, an act concerning Medicaid cost savings. We've submitted a substitute language to the committee for your consideration. We think there's considerable savings associated with capping the fees of temporary nurse staffing agencies. And you've heard from several nursing homes earlier today in that regard, and have provided actual joint favorable substitute language for your consideration on that bill. Next, House Bill 7191, an act concerning Medicaid rate increases, planning and sustainability. Our association participates with the Connecticut Hospital Association, Leading Age Connecticut, the Home Care Association, and we formed a joint collaborative called the Connecticut Healthcare Collaborative. And for your consideration to begin the conversation towards perhaps a solution to a state level approval process in the event that there were significant changes in Medicaid policy. We've submitted legislation to that would create a state approval process in the event of major changes to the Medicaid program at the federal level. And it's modeled after the block grant approval process that you find under Section 4-28 of the Connecticut General Statutes. So when you see how we structured it, you'll see it's framed after the block grant approval process, but it is a Medicaid policy revisions approval process. Not just recommended by my association, but our healthcare collaborative consisting of the Hospital Association, Leading Age Home Care Association, and us. Next, Senate Bill 805, an act requiring nursing homes to spend not less than 80% of revenues on direct patient care. We're opposed to that legislation. It amounts to an unfunded state mandate with no associated increased appropriations, so we're opposed on that basis. Next, Senate Bill 1480, an act concerning private equity and real estate investment trust ownership of hospitals and nursing homes. This is similar legislation to Senate Bill 1332, which is legislation in front of the Aging Committee. We're opposed to that because of the broad definition of private equity. And we think since our aging testimony in our research has uncovered the basis for why there's such strong opposition in our sector for this. And that's that the private equity definition we found verbatim in a November 2023 CMS regulation that was introduced and adopted now for the purposes of disclosure of private equity. And in the preamble of the introductory section of that regulation, it's stated very clearly by CMS that this very broad definition of private
Your
equity.
time is complete. Please summarize.
I will summarize. I just want to say that it was for the purpose of disclosure and in no way a basis for banning entrance into the marketplace. And so the definition is overly broad and it was never intended for that purpose. And finally, on the governor's bill, Senate Bill 1251, we've brought substitute language again to the Human Services Committee to actually provide an inflationary increase rather than eliminating the inflationary increase. And so with that, I thank you once more for the opportunity to testify. We submitted a written testimony for your consideration and really appreciate this committee and your willingness to hear us through on these issues.
Thank you, Matt. Representative Case has a question.
Thank you. Thank you, Mr. Chair. So Matt, you talked a little bit, I know we had a discussion earlier on the private equity issue and you brought it up a little bit. You were talking. Why is everybody scared of the private equity? And as I mentioned it with the commissioner, it's what nursing homes are able to do now in order to enhance their facilities and actually garner more reimbursements. Is that correct?
Yeah, I think there's some confusion, perhaps considerable confusion that's caused by the definition of the bill, which is brought forward as a definition for a purpose that it was never intended for. It's just too broad of a definition, and I think it, in one fell swoop, lumps what we might agree on as to be, poor practices and evidence of poor practices in the private equity markets. Although I would say that I don't believe we see this kind of activity in Connecticut, but the activity of perhaps healthcare companies that look more like investment companies that seem to be even advertising themselves entering into the market for the purpose of short-term engagement, lowering costs, the kind of things that don't really reconcile with a healthcare delivery system. And so that is scary. That is scary, but that is not the marketplace that exists for Connecticut nursing homes. In fact, in my research, I found not a single Connecticut nursing home that resembles Prospect Healthcare or Stewart Healthcare or any of the companies that seem to be drawing a lot of very negative attention. And so I think it's just an issue of the definition and it being too broad to include too many people or too many organizations, but being described in terms of the very narrow group of entities that are drawing negative attention.
Thank you. And I think I hear it from a lot of nursing homes that call me, and especially in my area where the reimbursement rates are so, or the rates are so low. So about 218 is the low in the northwest corner, and the max is out like 260 or 280 per day. And they're all talking about going to private equity because if they enhance their facilities, they can get a higher rate for the day. And I just want to move on because I know we want to get to other stuff. I know my feeling of it, of forcing the nursing homes 80% of their stuff towards patient care. I think that's going to push even more to private equity because how are they going to maintain and upkeep and do renovations to the buildings?
Right. Well, when I think that when nursing homes make a reference to going to borrow money in private markets rather than traditional lending institutions, they're not talking about going out to private equity markets. They're going out to private investors that look like nursing home companies, in my opinion. In fact, there's a distinguish to be made between a nursing home company that has private investors versus a private equity company that is entering the healthcare marketplace. And so I don't believe nursing homes are saying they're going into those markets. I think they're going into private lending markets where they perhaps can get more favorable terms, or they can get investors to help stabilize, perhaps and create capital that would help them with their infrastructure improvements. I think that's what's going on. And I think it's two different things.
All right. Well, I thank you, Matt. I've been in a few nursing homes over the past few weeks and dedicated staff. I just think that the motivation to have the facilities up to par helps the staff to want to be there, helps the families that are coming in to like having their family members there. I think it's a full circle. I think we really need to take a deep look at how we can maintain top of the line facilities along with top of the line care, and restricting and driving to where we're telling them they can't do things. I don't know is the right way to go, because I think there'll be more and more that will, if they can't get the private equity, they might close the door. So I think we have to be careful of that. I don't know what your feeling is of that, but I give you a second to respond if you
Well, I
want.
appreciate your comments very much. I think you're spot on correct. And I wasn't at the hearing at this time, and it's been discussed not just in the Human Services Committee, but also in the Aging Committee. The notion that a very prominent large Waterbury facility had closed, there was a monumental, really, nothing I'd seen before, transfer and discharge of some 200 residents, and some of them ended up in 2 Bristol, Connecticut nursing homes. And that those facilities are later, the owner of those, the same owner has submitted a petition to the state to close those buildings, and that's pending before the Department of Social Services. And when our group reviewed the private equity ban bill, one of the first issues that came up was the question of whether you could ever find an owner or a buyer for either one of the 2 Bristol buildings based on the definition of private equity in Senate Bill 1332 and also in Senate Bill 1480. I think that is very responsive to your question. This definition is too broad, and it would probably restrain any investment or purchaser. By the way, I'm not suggesting there is a purchaser for either one of those buildings, but if there were, I think they would walk away from this market under that definition or be precluded from even entering the market in the first instance.
Thank you. And I think our passion is to get the best facilities for our loved ones to be at. And hopefully we can do the best thing in making sure they have a rate that backs that up. So we can keep these facilities in Connecticut. I'd hate to have to see people that can't be here in Connecticut and have to go elsewhere. So I thank you for coming forward, and we'll just keep looking at this and see where it goes.
Thank you so much.
Appreciate it. Thank you, Mr. Chair.
Thank you, Representative Case. I do have a question, actually. And you may have said this in response to one of Representative Case's questions, but did you submit, if you don't like the definition that's in the committee bill, do you have an alternate definition of private equity that would make the association less unhappy?
Yeah, no, thank you so much for that question, Senator Lesser. I didn't submit an alternate definition, but it would be along the lines of the description of the nefarious practices that are drawing negative attention. I think there could be support for precluding or having the definition of private equity include those practices and organizations. And I could, yeah,
So it would be based on an organization's practices, but not their,
Well-
not based on. So it would really not be a ban on private equity. It would be a ban on
well,
practices by private equity,
yeah,
practices by any investment.
And not to be philosophical for the Human Services Committee, we wouldn't favor a practice that outright banned anybody into a market in a free market society, just as a general rule. But to have the definition be one that is describing an organization that perhaps the public policymakers in Connecticut determined was, not the kind of entrance that they wanted to see in the Connecticut market, that would have to be, that organizations in the world we would see wouldn't be precluded per se, but the Department of Public Health in evaluating their fitness, frankly, that's really what DPH is doing. They're evaluating their fitness to have the privilege to provide services here in Connecticut. They would evaluate those questions. Are they an organization that aligns with our policy goals? And an organization that is putting itself forward as one that is designed for short-term profits, lowering costs, and turnaround of the organizational entity over a short period of time, frankly, we would agree wouldn't align with our healthcare policy goals in Connecticut. So I think it's along those lines, Senator.
Thank you for your testimony. No other questions? We appreciate you being here this evening. Next, we have Nick Carapasas, followed by Tom Fiorentino, followed by Rebecca Hopper. Is Nick with us? Nick is not with us. Is Tom Fiorentino with us? Tom is with us. Online.
Senator, I'm here, Tom Fiorentino.
Please go ahead.
Thank you so much. I am here on behalf of the ARC Connecticut, the state's largest and oldest advocacy organization for people with intellectual disabilities. And I just want to say thank you guys, thank you all, men and women, for putting in such a long day. I appreciate it. First, I want to say I'm here on Senate Bill 1472, and I appreciate the sentiment behind this bill because I understand the frustration, the desperation, the need that the families who support this bill have. They need a place for their family members. So it's not the families I blame. I blame a system that has starve the nonprofit sector that could provide and should be providing for these families right now at a fraction of the cost that is sadly inherent and inescapable in the state employee supported system like regional centers. So having acknowledged the need, I want to make clear my opposition to this bill in that it chooses to fund placements in institutions. This is such a step back. It's a 1960 remedy that doesn't fit Connecticut or any other state in 2025. We've moved beyond institutions, which were meant to segregate, separate, and in paraphrasing former Senator Kennedy of your General Assembly, they were a form, or they are a form of apartheid. People's families deserve more. And honestly, folks, Connecticut ought to be ashamed that we still have these institutions, not only because of their segregating effect, but because they're so hugely and disproportionately expensive. And as you know, right now, in particular, every dollar matters. And it brings me to where we are today, which is we've got a nonprofit sector that serves the vast majority of people, but they're forced to pay poverty wages, as you have heard, I'm sure. Many of their workers are working 2 jobs. They're getting state assistance. People I've interviewed who are direct care providers are actually getting donations from food banks to make it through the week for their families. At the same time, the state-operated system including the regional centers, which provide services to very few people, to be clear. Maybe I think it's under 400 people at this point. And I don't want to be misunderstood. I have no argument with the state employees who do this valuable work. I just object to the system that they're in. It's such a costly alternative to the nonprofit group. Just to give you an example, about 400 people last year received direct services from the state of Connecticut, from state employees. And the overtime for that group was just under $40 million, or around $100,000 per person served. So putting
Your
more
time
funds.
is complete. Please summarize.
Thank you. What I would like to say is there's a better way to do this. I appreciate the sentiment, recognize the need, fulfill the need, but do it in a far more efficient way, which is to fund the nonprofits. So thank you for listening.
Thank you for your testimony. Just a question on that. I obviously,
Yes, Senator.
we want to figure out how to meet the need that's out there, and certainly value your opinion and ARC's work in the community and their expertise. Just one of the arguments that we sort of the devil's advocate argument is that DDS obviously has to support a spectrum of a variety of folks who have a variety of different needs, some of which are more acute and some of which are less acute. And certainly, if you're talking about bang for the buck, there's certainly you can serve a lot more folks in the community versus someone in a more acute setting. But then the concern is from other parents that we just don't have enough options for folks with that higher level of need. And I know there's not enough money to go around. There are not enough programs to support everyone or to provide the support that we need to provide to everyone. But I'm just trying to,
No, I understand.
providing that higher level of need is inevitably going to be more expensive than providing support for folks who don't need that level of need. But how do we provide that support for the people who do?
Okay. Let me just give you, I hope this answers the question. At Southbury Training School, they did an evaluation of every single person in that facility to determine whether they could be supported in the community by nonprofit providers. And the vast majority, there were a few people who were on hospice, but the vast majority, the finding of this expert panel was that, yes, they can be served in the community just as well as they can be served at Southbury. It is a fallacy that there's something inherently different about the people served by the state that makes it impossible for them to be served in the nonprofit sector. Now, you can't, though, give I'm sorry, the very small amount of money that the state allocates and then expect them to be taken care of. The per person staffing costs at Southbury, not running that huge facility, are over $600,000 per person per year. You give that to any provider in Connecticut, and they'll do the same job. They'll do it for less than that. And then, Senator, when you add in, because remember, Southbury is a big institution designed for thousands of people, the cost of maintaining and running that facility it brings you up to over $1 million per person per year. So when I hear, well, we're taking care of the most needy, well, yeah, because you won't fund alternative placements, which under the ADA are the preferred placement in the community. I can tell you, we've had experts come in who've testified before the legislature. Many states have no institutions at all. All of their services are provided by nonprofits and in far less restrictive environments and institutions. They have precisely the same level of needs that we have at Southbury and at the regional centers. So that's I understand when people say that, but I just want to say to you that the evidence doesn't suggest, the evidence establishes that there's no service that the state can provide in an institution that cannot be provided by a nonprofit suitably funded. And again, I don't mean at the exact level that the state is getting. I mean substantially lower, but more than what the state is giving. You have to understand that the state is saying, hey, we're the only ones that can do this. And when a provider says, well, we'll take that person, and the state says, okay, well, we'll give you X, and the provider goes, that's not even close to what it's costing you to take care of that person. You got to meet, nope. And so they keep the person. So now there are people leaving Southbury. I don't want to make it, but it's painful how slow that process is. But those people, high level need people, they're moving into the community. The funding has to go there. And I would just say, as a matter of public policy, that money goes farther. In other words, for the same dollar, you can serve more people with the same levels of need and at the same level of service. You can serve more people in the community with nonprofits than you can in an institution funded by, run by the state.
Thank you for that answer, and I appreciate it. I just I know you talked a lot about Southbury, and I know that my reading of the bill, and I could be wrong, but I think it does not apply to Southbury. It does apply to the regional centers, though. So
Yes, Senator. I'm aware of that. I'm aware of that. And I was only mentioning Southbury because we have very, very good numbers on that. I will tell you that staffing costs in the regional centers are also very, very high compared to similar services that you would get in the nonprofit sector. But I am aware that it only asks for admissions to regional centers. Yes, thank you.
Representative David.
Thank you very much, Mr. Chair, and thank you for your testimony this evening. It's interesting because one of the things that we talked about in the 5001 bill in 2023 was looking at sort of transitional academies for independent living, really to help young people who would be transitioning out of a home, their family home, to into some nonprofit group home
Placement.
Right. And that unfortunately hasn't kind of taken off the ground. And so when I was starting to read this bill initially, I kind of was reading it through that lens and just wanted to get your view of those sort of services that were contemplated with the 5001 bill.
I think that there were a number of services that we need to follow up on. In other words, the good intent, better than intent, the good act of the legislature has not been put into practice, let's say, yet. And that needs to happen. I think transition planning is a great thing. My son recently he transitioned from our home to his new home in Bloomfield, run by Favar. And it was, there are bumps in the road. I would just say, Representative Dathan, and good evening to you. I know appreciate all you have done for our community. That when we look at scarce funds, we need to spend them in the most efficient way we can without in any way compromising service. And that's so painful when I look at the state side services versus the nonprofit side services. And a few years ago, and thank you for affording me a little extra time here with your questions. The Program Review and Investigations Committee did a very, very thorough study of this bifurcated system that we had and came to the conclusion that it was unsustainable, that we had to the state needed to get out of that business. And it's ironic, the committee's gone, but the state's still in that business. And their per person costs are, and again, I value those workers. It's not the workers, it's the system that they're in that when you look at some of the numbers, I always go to my people and say, can you run those again? Could that be possible? And unfortunately, it is possible. So I got a little astray, Representative Dathan. I apologize. I hope I answered your question.
You did. And I'm sad to say that you missed our Government Oversight Committee hearing this evening, where we talked about a bill that would be very much like that study that you referred to from PRI years ago. And, that's one of the bills that we discussed in today's public hearing. So looking forward to hopefully making some headway with that, and would love to get your sort of buy-in. I think it's 7184 is the bill that we've talked about. But thank you so much for your testimony, and thank you, Mr. Chair.
Thank you, Representative Dathan. Other questions or comments from members of the committee? Seeing none, thank you for your testimony tonight.
Thank you so much.
Next, we have Rebecca Hoffer, Dr. Hoffer, followed by Catherine Vieta. Kathy Vieta. Is Dr. Hoffa with us? Yes, you are. Can you please unmute yourself? Are you there? No, we can't hear you. You can, if you sign out and sign back in, we'll come back to you if that's an issue. Okay, so we'll come back to Rebecca. Next, Kathy Vieta.
Yes. Hi, everyone. Good afternoon.
Good afternoon. Evening.
Yes. Dear Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee, my name is Catherine Vieta, and I'm the Coalition Director for Husky for Immigrants. Husky for Immigrants is a statewide coalition of over 40 organizations advocating for equitable access to healthcare, to the Husky Health Program for all income-eligible residents, regardless of their immigration status. Thank you for the opportunity to testify this evening in strong support of HB 806, an act expanding Medicaid coverage for treatment of certain emergency medical conditions, and in support of HB 7191, an act concerning Medicaid rate increases, and SB 1470, an act concerning Medicaid reimbursement for community health workers services. Emergency Medicaid is an important conduit in addressing coverage gaps for income-eligible residents who are systematically excluded from the most affordable healthcare coverage options, including Medicaid and marketplace coverage. SB 806 provides a much-needed adjustment to expand the conditions eligible for emergency coverage in Connecticut and allows eligible residents to enroll in coverage ahead of any emergencies. This will ensure that uninsured residents have better health outcomes and not be burdened with the administrative tasks to enroll for coverage when facing life-threatening chronic conditions. Emergency Medicaid allows states to receive federal matching funds, and in light of reduced federal funding through the final allocations of available ARPA funds, as well as threats to cut funding to the Medicaid program, expanding the definition of medical conditions that would qualify under emergency Medicaid coverage will provide the state a pathway to ensure that federal funds can continue to be brought into the state. In our written testimony, we provide recommendations on revisions that we would like to see to SB 806 to clarify some of the current bill language, as well as various conditions under the emergency Medicaid coverage lists that are covered in other states that are not reflected in the current list provided in SB 806. Furthermore, the long-term sustainability and accessibility of the Husky program is of great importance to our coalition, including strengthening its infrastructure. HB 7191 would do just that by increasing funding to FQHCs, a critical point of care to folks on Husky, those without insurance, and immigrants. However, we respectfully recommend that the committee incorporate language that includes the plan put forth by the House and Senate leadership that would bring all providers up to at least 75 to 80% of Medicare rates in a multi-year plan, as this would best address the accessibility and improvements to quality of care across the board for all Husky members and providers. And lastly, we would like to express our support to SB 1470, which would provide more transparency on the implementation of CHW Medicaid reimbursements. We know from our work that CHWs play a vital role in connecting community members to essential resources, and we're eager to see Medicaid
Please
reimbursement.
summarize.
Yeah. We're eager to see reimbursement for CHWs be implemented in a timely fashion to ensure that there's ongoing and sustainable funding for this essential workforce. Thank you for the opportunity to testify, and I'm happy to take any questions.
Thank you for your testimony. Are there questions or comments from members of the committee? Then we support all, or we appreciate your support of all of these items, and look forward to continuing to work with you.
Likewise, thank you.
Have a wonderful evening. Next, we have, we're going to try again. Dr. Hoffer, would you like to try again?
Hello, are you able to hear me now?
I can hear you.
Excellent. Thanks for the second chance. And thank you for the opportunity to provide support for House Bill 7191, an act concerning Medicaid rate increases, planning, and sustainability. My name's Dr. Rebecca Hofer. I'm a family physician, and I work at Fairhaven Community Healthcare in New Haven. I'm testifying today to urge the state to address the inadequate reimbursement to our health center for Medicaid services. By now, you've heard from my colleagues about the large, diverse, and growing patient population that we serve, most of whom struggle with poverty, food insecurity, and/or unstable housing. I'm incredibly proud to work here at Fairhaven Community Healthcare. It's been my dream to work at a federally qualified health center as a family physician since starting my medical training. Nationwide, the large network of FQHCs provide high-quality, essential, and cost-effective care to an extremely high-need patient population. We are a true patient-centered medical home with full-scope primary and obstetric care, behavioral health, dental services, and treatment for substance use disorder. Every day, I get to work with our wonderful patients. Parents trying to navigate the school system and support their child with a newly diagnosed learning disability, a grandmother with dementia coming in with her daughter to talk about her disease progression, a father trying to eat healthily and control his diabetes while working 2 jobs. My patients are hardworking, wonderful people, and it has been a privilege to serve them and get to know them over time. Most of my patients receive Medicaid, and the cost of their care is not fully covered by the Medicaid program administered by the state of Connecticut. In fact, we lose over $100 on each medical visit and over $121 each dental visit for patients with Medicaid. And I'm worried that this inadequate Medicaid reimbursement, coupled with the changes coming out of Washington, pose an acute and existential threat to the care that I provide our patients. I'm here to add my voice to my colleagues, urging you to pass House Bill 7191 into law and ensure that we can continue to provide the high-quality health care that all our patients deserve, regardless of their insurance payer. Thank you so much for the opportunity to speak today.
Thank you for your testimony and for your advocacy on behalf of your patients. Are there questions or comments from members of the committee? If not, just very grateful for the work that's being done at Fairhaven Community Health. Have a wonderful evening. Next, we have Monica Bilger. Monica?
Yes. Thank you, Senator Lesser, Representative Gilchrist, and honorable members of the Human Services Committee.
My name is Monica Bilger, and on behalf of the American Diabetes Association and over 1 million residents living with obesity, I'm testifying in support of SB 1474, which expands Medicaid coverage for obesity medication, and to voice our opposition to language in SB 1251, Section 6, which seeks to repeal obesity medication coverage. Specifically, the American Diabetes Association supports implementing the bipartisan law that was passed over 2 years ago, providing comprehensive coverage for people living with obesity and Medicaid. And yes, that did include FDA-approved obesity medication. Diabetes is an epidemic in the U.S., and correspondingly, we are gravely concerned about the substantial increase of obesity and its related impact. Obesity is responsible for up to 53% of new type 2 diabetes cases, but that's not all. It exacerbates or causes over 200 other medical disorders. At minimum, there is strong and consistent evidence that obesity management can delay the progression from prediabetes to type 2 diabetes. And then, can you imagine the impact of preventing or improving upon 200 other medical conditions? In Connecticut, the percentage of adults with obesity is trending up. We've had a 5% growth from 2013 to 2019, with up to 30% of adults with obesity. And now we're expecting a projected increase to 52% of adults living with obesity by 2030. When folks say we can't afford to provide comprehensive care, specifically pharmacotherapy, I ask, how can we afford not to? In Connecticut, obesity is estimated to reduce economic activity by $6.1 billion annually. And that's surpassing the most expensive chronic disease in our nation. You guessed it, diagnosed diabetes, costing an estimated $5 billion in Connecticut each year. Again, the math is there. People are suffering, dying, and the cost of the state is multiplied by the 200 medical disorders obesity impacts. This should be a mathematical and humanitarian layup. We can't speak to the diabetes and obesity crisis without highlighting the glaring facts related to health disparity. We know addressing obesity is a health equity priority. We know that Connecticut residents are twice as likely than white residents, if you're Black or African American or Hispanic, to be diagnosed with diabetes. And disparities exist not only in prevalence of obesity, but also in obesity treatment outcomes. Disparities are not limited to high infectious diseases. Racial minorities experience higher rates of chronic disease, death, and disability compared to white Americans. The reality is, again, we can't afford to ignore comprehensive obesity treatment, and that includes efficacious FDA-approved medication. On behalf of people at risk for diabetes and the 199 other costly medical conditions, the ADA urges support for implementing existing law for comprehensive obesity coverage, including obesity medication. And as such, we request your support for SB 1474 and to oppose the governor's budget language in SB 1251 on Section 6, page 6 through 8, which would eliminate the coverage of weight loss medications for obesity. I'm happy to answer any questions and appreciate your time in this evening and all you do.
Thank you. Thank you for your testimony and for your advocacy. We are certainly interested in this provision. We wrote the law that the governor's office is now trying to repeal. Are there questions or comments from members of the committee? Seeing none, you have a good evening.
Thank you. You as well.
Okay, next we have Melissa Pensa, also from Fairhaven Community Health.
Good evening. I apologize. I'm on the train commuting, so you might hear some background noise. Good evening, Senator Lesser, Representative Hillcrest, and members of the Human Services Committee. Thank you for taking the time to hear my testimony in support of House Bill 7191, an act supporting Medicaid rate increases. My name is Melissa Pensa. I'm a family physician, and I'm the Director of Medicine at Fairhaven Community Healthcare. I know you've heard from many in our organization tonight. We are proud and we care. To summarize briefly, we provide expansive and expanding primary care services to 36,000 patients annually, the great majority of whom have Medicaid. I'm a true family physician. I care for patients from 0 to 100. I care for multi-generational families. Just today, I took care of multiple sets of families together, spouses and daughters and fathers. Mr. Lesser and members of the committee, I don't need to tell you the risks that we face in Washington. If we receive cuts to our federal Medicaid funding, Connecticut will be forced to reduce its Medicaid recipients. We're going to see more uninsured patients at Fairhaven, and we will not stop caring for them. Already, a quarter of our adult patients are uninsured. Many of these patients have chronic diseases, and I see them every 1 to 3 months. We rarely collect on these payments. Patients who are apt to lose their insurance are working people, and Medicaid is what helps them stay employed and pay their rent. If they come in, we will still see them. An appropriate rate increase to Medicaid, we can better weather the storm. We currently revisit and rely on programmatic and federal funding to fill the gap. A sharp rise in our uninsured population will put us in an impossible spot. We can't turn patients away. We have a responsibility to deliver on our programs. I urge you to place our Medicaid payments at a fair and just rate for now and to the future, for the sustainability of CHCs across the state, for our patients, and for the health of the Connecticut population. Thank you for hearing the testimony.
Thank you for your testimony and your advocacy on behalf of your patients, and you have a wonderful and smooth commute. Are there other questions or comments from members of the committee? Seeing none, have a good evening. Next, we have Jason Moran, followed by Samir Sharaf. Is Jason with us? No? No. Is Samir? No. Is Cal Patel with us?
Mr. Patel needs to accept his promotion to panelist.
Mr. Patel, please accept your promotion to panelist. Okay. Still no Mr. Patel? Okay. Is Dr. Laura Dake there?
Yeah, I am here.
Great. Please proceed.
Hang on. There we go. Senator Lesser, Representative Gilchrist, Representative Case, members of the committee, please accept my comments on House Bill 7191 and Act concerning Medicaid rate increases, planning and sustainability. I'm Laura Dake Roach. I live in West Hartford. I'm a doctor of optometry and a past president of the Connecticut Association of Optometrists. I practiced optometry for 37 years in Naugatuck, Connecticut, seeing patients of all ages for their visual and their medical eye care needs. It was my privilege to have been a Medicaid provider for all of my time, as my belief is that healthcare in this country is a right, and patients of all demographics deserve quality healthcare. Optometry plays a major role in meeting the vision and medical eye care needs of Medicaid patients, providing 70% of the eye care of the Connecticut Medicaid population. And almost 90% of our members state that they accept Medicaid and currently treat patients. We saw 119,000 unduplicated Medicaid patients in 2024. And in 1 out of 5 of our practices, Medicaid patients are the majority of their patient caseload. We've also been told that about half of the 11% of our CAO members who don't currently accept Medicaid would do so with better reimbursements. This would increase access to care. 9 out of 10 optometrists are doing the right thing, but access is important. As far as provider reimbursement, data from DSS shows that optometry was reimbursed $13.6 million for caring for our Medicaid patients last year. That is 10% less than what our ophthalmologic colleagues receive for performing the exact same service or procedure. My practice was a mixed ophthalmology optometry group practice. We used the same equipment, the same medical protocols, the same medical codes, the same technicians, billing staff, and in our main office, the same exam rooms, and yet I was paid 90% of what my MD colleagues were paid. The 90% rule has been in DSS regulation for years. It's discrimination, pure and simple, and it needs to end now. In 2021, the General Assembly mandated fee parity in Medicaid for nurse midwives and podiatrists. So we ask that you do the same for optometry in House Bill 7191. Our legislative chair, Dr. Brian Lynch, has provided you with a copy of our proposed language in his statement. And we have a pretty good idea of how much of what this would cost, what this move to fairness would cost. Our projection is that it would be about $680,000 in state dollars in fiscal 2026. You can count on optometry to continue leading the way in providing vision care services to this vulnerable population But the bottom line is fee parity would bring more ODs into the program, and this would result in improved access to critical eye care to these Medicare enrollees. Patient access to quality eye care increases, and that's the real issue. So I thank you for considering my testimony and for all of the work that you do.
Thank you for your testimony and your advocacy on behalf of your profession. Are there members with questions? If not, you have a good evening.
Thank you.
I believe Cal Patel has joined us.
Yes, Senator Lesser, thank you. Senator Lesser, Representative Gilchrist, and esteemed members of the Human Service Committee, thank you for the opportunity to offer testimony in opposition to SB 1251, an act implementing the governor's recommendation for health and human services. My name is Cal Patel, and I'm the administrator of Essex Village Manor and a board member of CARCH, Connecticut Association of Residential Care Homes. I appreciate the opportunity to testify in strong opposition to governor's recommendation to continued flat funding for residential care homes. Instead, we are urging the committee to amend Section 10 of SB 1251. We have submitted in my testimony written language of suggestions. Basically, we're asking to substitute language to provide for a 5% inflationary increase for fiscal year 26, increase in administrators' base pay, language to rebase every 2 to 4 years consistent with the nursing home statute, and updating the minimum fair rent that is calculated. The governor's proposed flat funding in Section 10 of the bill would continue to underfund residential care homes. As many of you may know, residential care homes provide non-medical home-based room and board for some of our most vulnerable residents. We provide medication administration, meal prep, social services, recreation opportunities, personal care assistance. Most of the homes are family-owned and small businesses with residents that have mental health diagnosis and many cases additional health challenges. The proposed substitute language would provide a necessary increase to ensure administrators' pays are updated to more fair compensation. Also, it would provide more transparency with our rate system and update the costs associated with the fair rent of residential care homes to keep up with the inflation. Our level of care saves the state tremendous amount of money and ensures stability and independence for our residents. Continued underfunding in a difficult economic time have already led significant turnover in industry and bed losses. It is important for you to know that as you consider Medicaid increases, that we do not get funded through Medicaid, but rather through the state supplement through Department of Social Services. These funds are critically important to our workforce and frankly to our residents. We value our employees. It is awfully difficult in this challenging time to keep a consistent staff as we're competing with big box retailers and fast food restaurants that pay more than what our staff provides to our residents. The inability to provide raises for our employees means much higher turnover and less consistency of care for our residents. Unfortunately, paying employees is the necessary wage to attract new people in our industry is almost impossible these days. Our industry strives to employ people for long-term, again, for continuity of care and consistency of care. This leads to better outcomes, long-term health, and more stability for our residents. The inconsistent funding has also challenges our businesses' operations. We are consistently having to make repairs that are subject to state inspections and yet have no margin to do so. Essentially, I urge you to look at the language we've submitted as our industry and please adapt some of the language to assist in the residential care homes. Thank you. Thank you for the opportunity again.
Thank you. We will look at that language.
Thank you, Senator Lesser.
Any questions or comments, members of the committee? Have a good evening. Next, we have Brooks Goodison, followed by Kathy Flaherty.
Yes, good evening. Good evening, committee co-chairs Lester, Representative Gilchrist, ranking members Senator Harding and Representative Case, and the distinguished members of the Human Services Committee. I'm talking about testimony for SB 11, an act concerning prescription drug access and affordability. My name is Brooks Goodison. I'm the president of Diversified Group Brokerage. We're a third-party administrator for health plans in Connecticut. We've been doing this since 1967. We design, manage, consult, on over 400 self-insured plans covering about 50,000 employees and their families, primarily small and mid-sized businesses. We're headquartered in Marlborough, Connecticut, and we are a small business ourselves. We've got about 75 professionals who have been covered by a stable self-insured health plan for 50 years. And we are in strong opposition of SB 11, in particular, Section 12, regarding stop-loss insurance. Stop-loss, I forgot to take a minute. We've submitted full testimony, but I'd like to take a minute and cover stop-loss. I just wanted to let everybody know that stop-loss coverage is not required at all for a self-insured health plan. A plan could go without stop-loss. It is a financial safeguard against catastrophic claims. And mandating higher stop-loss thresholds increases the employer's financial risks, drives up costs, raises premiums, and forces higher employee out-of-pocket expenses and payroll deductions. And these burdens that this would propose would limit employer choices, and it would lead to elimination of health coverage altogether in some circumstances. I think it's important to understand that many employers offer self-insured health plans because they have the desire to operate across state lines, meaning like most of our businesses headquartered in the Northeast quadrant of the United States. Many of them are in Connecticut, but we have membership in all 50 states, and these employers offer these plans so that they can have a uniform benefit coverage nationwide. And then most of the employers, I think it's important to know that transition from fully insured plans to self-insured plans, they want to maintain comparable coverage and do that without increasing costs. So in our daily communications across businesses throughout Connecticut, we have not encountered a single employer seeking to raise their healthcare costs. And we believe SB 11, Section 12 does just that. We urge you to reject that section and protect employer flexibility and affordability and access to self-insured health insurance. Thank you for your consideration. Any questions?
I thank you for your testimony. I understand that stop loss is not required, but I think the thing that we're sort of wrestling with as a legislature, and I know other states like New York have as well, is the emergence of small, obviously there have been large employers have self-insured forever, but the emergence of small employers self-insuring is a new development, or a relatively new development. Certainly something that seems to be proliferating a lot in Connecticut, due in part to market failure in the small group market. But could a small employer, could a two-person employer self-insure? Is that something that you would recommend?
A small employer, I think, has the ability to self-insure. It's not particularly a great market. We typically start at around 25 covered lives and above, is where we believe that it's much more viable. There's a larger access to viable stop loss options at that higher market level.
But do you see any value to us raising attached? Do you see potential problems for a bodega self-insuring?
It's possible that they could be successful with it if they don't. When self-insured plans, they only pay for the claims that their people incur. And if they didn't have claims or very little claims, it would control lower a very large portion of their health plan expenses.
I guess we've traditionally relied on insurance companies to bear that risk. So if we're saying no, that they would self-insure, that's usually something that we've looked to larger, more sophisticated, more financially sound entities to do. It seems to me an innovation. You could be right, but I think there's a reason why, two-person companies don't do it too often. But
I would agree. I think it's more challenging to find a reasonable way to cover the catastrophic loss. Stop loss, I think it's important, doesn't affect the benefits at all. It's just the plan of benefits is what the employer establishes those to be, the coverage. The stop loss it only protects the employer from the catastrophic losses. It doesn't, and so for smaller groups, it's harder to secure that at a smaller level in a financially viable way. But north of 25 employees covered, there's much more market capacity and reasonable pricing around those types of coverages.
So insurance is cheaper in New York State, I think, in general. It's my understanding. You tell me if that's incorrect for small employers. And yet New York has done actually more aggressive version of what's in this bill. They've raised I believe, and you tell me if that understanding is correct or if that's not correct.
No, New York has some limits on how on group size, not so much stop loss deductible. This would be the first that I've seen that would have stop loss deductibles this high, that or force employers to have stop loss deductibles that this high. New York limits, takes a different approach on groups, on groups of a certain size, and it doesn't really get involved with a specific stop loss deductible being a certain amount. It doesn't also get into compelling stop loss carriers to only cover plans that cover state mandates, even though many of them do.
Got it. Okay. Thank you very much. Other questions or comments from members of the committee? Seeing none, thank you very much for being with us this evening.
Thank you.
Next, we have Kathy Flaherty, followed by Aaron McCleary.
Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. I thank you for your time and attention today, and I thank you for the opportunity to testify on Senate Bill 807, which also includes the same language as in Section 9 of SB 11, which would raise the asset limit for the Husky C medical program. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and we represent a number of people who depend on these Medicaid programs for their access to health care. And Husky C has the lowest asset limit and strictest asset eligibility. And while we think it's really important and we appreciate that the committee has proposed language to finally address this fundamental unfairness by raising the asset limit over the course of 5 years. First, we do think that the fact that it takes 5 years to deal with the asset limit is too long a period of time. But what it really doesn't address is the income eligibility unfairness. And that's a real potential problem for our folks because if their income is too high, then they have to go into what's called a spend down to try to get access to Medicaid coverage for the rest of a 6-month term. And they can't always meet that spend down, which means they don't have any access to Medicaid at all. And there's really, while there may be a way to deal with excess assets, there really is not a way to deal with excess income. And having income limits that are so incredibly low for the Husky C program makes it very difficult for people with disabilities and older adults to qualify for Medicaid. So we would urge this committee to consider amending the language to also address that income limit unfairness. I know that you've heard from other people today on this bill. And I know you've had a very long day, and I just wanted to add my voice to the chorus of people asking you to fix Husky C.
It's not been long. We were expecting a lot longer testimony. Any comments or questions from members of the committee? Seeing none, thanks as always, Kathy. It's good to see you.
Good to see you too. Thank you.
Next, we have Aaron McCleary, followed by Denise Dean, followed by Gilda Descala.
Hello, good evening, Senator Lesser, Representative Gilchrist, and other members of the Human Services Committee. I'm coming to you from my car this evening. This is how important this is. I have submitted testimony. I am the past president of the Connecticut Association of Optometrists, Dr. Aaron McCleary. I reside in West Hartford and have been practicing for about 18 years. And I am commenting regarding House Bill 7191 concerning Medicaid rate increases, planning sustainability. I have submitted written testimony along with my legislative chair, Dr. Brian Lynch, and you just recently heard from another colleague, Dr. Laura Day Roach. We are kind of drumming the same pattern out here for everybody. So I'm not going to reread all of the testimony that you have before. I just want to give another perspective in being an optometrist in the state of Connecticut. There's kind of this 90% rule where relative to ophthalmology, optometry is paid 90 cents on the dollar that ophthalmology is. And I've had the privilege of being able to work with my ophthalmology colleagues in various settings in West Hartford and serving people of my community, but also many surrounding communities. And I have a really great example where what I do is equal in value to what ophthalmologists do. And that is a specific case of pediatric eye care, specifically regarding children who've had cataracts at infancy. They require surgery from a surgeon, which one of my ophthalmology colleagues is performing. But the only way that this child will ever develop good quality vision in their lifetime is if I provide services to fit them with contact lenses and fit them with other glasses. If they never have contact lens access and I can't take care of them, their vision will never develop, which means that academic performance is going to suffer, and not to mention their contribution to our communities. There is nothing that says that my value and care for these patients is any less value than my ophthalmology colleagues. And we would urge that some of the language in this new bill be amended with the recommendation that we have set forth in our documentation submitted to you, to just make sure that we're addressing fee parity between ophthalmology and optometry. We've already done this with several other medical professions in recent years, specifically with Public Act 2102, Section 333, which addressed the nurse midwives as well as podiatry. We were able to rectify some of these disparities in fee parity between them and other providers. And we're simply asking that this same consideration is applied and the language is fixed to incorporate optometry as well. Currently, we serve 80 to 90% of a lot of our care provided for all these Medicaid patients in the state of Connecticut. And if we're able to accept increased pay parity for these services, you will be able to service even more patients in the state of Connecticut. And so that's really what we're getting at the gist of here. And I really thank you again. It's been a long day. And the bottom line is that fee parity is going to help more optometrists in the state of Connecticut access and provide care to more of our constituents, your constituents, and our patients. And that's ultimately what we care about. I thank you for your time this evening.
All right, thank you for your testimony and your advocacy on behalf of your profession and your patients. Are there questions or comments from members of the committee? Seeing none, have a good evening.
Thank you.
Next, we have Denise Steen, followed by Gilda Viscala, followed by David Fenton.
Good evening. Yes, I am Denise Dean, and I act as the Person-Centered Care Manager at Fairhaven Community Healthcare. I have made FHCHC my work home for the past quarter century, and it's time to speak with you about this bill, HB 7191. So we're all swimming in this sea of chaos, right? And I get it. We are all doing whatever we can to keep our heads above water, but let's not forget that we all still have power and we can still do amazing things. We can celebrate all the good in this world, and some of the best good that you can find is happening at FQHCs. Across our state, we are taking care of hundreds of thousands of people who have no other place to go. We alone see more than 36,000 in our locations, many who have been coming to Fairhaven Community Healthcare for 30, 40, some even 50 of our 50+ years of existence. And why? Because we are their medical home. We will not turn our patients away. We will continue to follow our mission, and we will take the best care of all of the people inside of our buildings, which means our staff and our patients, as well as the communities outside of our windows. We will provide high quality healthcare regardless of the ability to pay. But to do that, especially now, we truly depend not only on your understanding, on your compassion, but on your action. We need your vote. Please pass this bill, HB 7191. With the increase of Medicaid reimbursement rate, we might actually be able to exhale. We have put in our time. We have weathered the storm. We have been eating financial losses for decades, and we have been trying and fighting and begging for this Medicaid reimbursement rate to be increased to match our neighbors. Please, I cannot think of a more dire time to act. Do your part and help save FQHCs, because if we're not here, where will our people go? What's going to happen to the health of our community? Who's going to vaccinate our babies? That was the rising fighting cry of our founding mothers in 1971. And people who suffer with health conditions, it's not just their personal suffering, it's a ripple effect. It goes out to the family that they either co-infect with their illness or that needs to stop everything to take care of them, to the employer that struggles to get jobs done when staff don't show up for work, to the kids that don't make it regularly to school and don't learn and don't become their fulfilled adult selves, to the parents that lose their jobs because of sick days and the financial crises that will follow, to the EDs that will overflow with situations that are not emergent and could have been prevented, and to you and your family after your car accident or your heart attack that gets stalled in the overcrowded ED because you can't get care fast enough. You can make a difference. FQHCs were born out of a need to take care of those who need it most, and we have worked so hard to build such a complete healthcare system. We do take the best care of people. They rely on us, and so we rely on you. Please help us survive and maybe even thrive. Pass this bill, because without this increase, you put it all at risk. I thank you so much for your time, and my fingers are crossed.
Thank you. Some audio feedback. Who's ever unmuted, please mute themselves. Okay. Thank you so much for your testimony, and I think we all heard the passion in your voice that you bring to your profession, and also for advocating on behalf of your patients who are some of the most vulnerable people in the state. And we are impressed by it, and very grateful for you being with us. And we've heard from a lot of folks at Fairhaven tonight. Are there questions or comments from members of the committee? Seeing none, you have a great evening. Next, we have Gilda Descala, followed by David Fenton, followed by Joe Pandolfo. Is Gilda with us? No Gilda. Okay. David Fenton, Dr. Fenton. No Dr. Fenton. Joe Pandolfo is on, though. Good evening.
Good evening, Senator Lesser and Representative Gilchrist, and ranking co-chairs and members of the committee. Thank you for working on so many important matters that we've heard about through this hearing, including Medicaid coverage. I'm Joe Pandolfo. I'm representing the Connecticut Society of Acupuncturists. I'm the public member on their board of directors. And we'd like to speak to you tonight on House Bill 791 and also one section of Senate Bill 1474. We appreciate that as drafted, House Bill 7191 will phase in an increase of Medicaid reimbursements over 3 years to 75% of the Medicare rate. And I could report to you this increase would really help sustain participation in the Medicaid program by the licensed acupuncturists in our state. Many of them are small businesses, and under the current fee schedule, as encouraged as they are to participate in the program, they can't fully absorb the demand that they'd like to meet for Husky patients. This increase would be very helpful to I think, maintain the participation and the access to acupuncturists. More and more studies and data evaluation from other state programs show that care from the fully credentialed licensed acupuncturist has the effect of, among other things, reducing the use of opioids and pain medication. Medicare now recognizes acupuncture as a covered service for this very reason, and the Veterans Administration uses acupuncture care extensively. And in many locations, they're actively recruiting to meet the demand for these services. In that regard, the Connecticut Society would relatedly like to comment on particularly Section 3 of Senate Bill 1474, the Act Concerning Department of Social Services. This provision would have Medicaid prescribers become familiar with alternatives to opioid drugs in the treatment of a patient's pain. And we totally support this change. We believe some additional language would make it even more effective. Right now, the role of acupuncture in providing non-pharmacological strategies for pain reduction is recognized in Section 20-14S of the General Statutes, and we would suggest referencing that option in this section of the bill to facilitate awareness among the prescribers and to hopefully increase referrals to the more efficient care by acupuncturists. In my written testimony, there's some suggested language that we've included. And I would just finish by saying our members that participate in the Husky program report that the Husky recipients are the most conscientious patients, are profoundly grateful for the ability to get acupuncture treatment for their pain, which reduces and in some cases even replaces their opioid prescriptions. So the benefits of these services are extremely valuable to the system overall, especially with respect to the
Your time is
ability
summarize.
to reduce the use and costs of opioid prescriptions. And we have data and materials we'd be happy to share with you if it would be helpful. And again, I thank you for the opportunity to comment this evening.
Thank you, and that's a suggestion that we appreciate, and if you want to send that to the committee, I think that could be useful. Questions or comments from members of the committee? If not, thank you for being with us this evening.
Thank you.
That concludes our list. However, we did skip a couple of folks who were not able to testify initially, and we've also had a couple people show up in our committee room who are ready to testify. So the next person I would ask, and I don't know if they're here, is Julie Schubert here? I don't think so. How about Mag Morelli? Mag is online.
Thank you, Senator Lesser. Representative Gilchrist, members of the Human Services Committee, thank you for allowing me to move my position to the end. My name is Mag Morelli, and I'm the president of Leading Age Connecticut, a statewide membership association representing not-for-profit and mission-driven provider organizations serving older adults across the continuum of aging services. On behalf of Leading Age Connecticut, I provided testimony on several bills before you today, and I'll speak to just a few for my 3 minutes. House Bill 7191, an act concerning the Medicaid rate increases, planning, and sustainability. Leading Age Connecticut supports this bill, which would increase the rates of reimbursement to Medicaid providers over 3 years in accordance with the rate study that was commissioned by DSS. We thank the committee for proposing these increases and for including the continuous updating of the rates on a predictable schedule so as to maintain the integrity of the rate systems and fee schedules moving forward. Senate Bill 1251. This is the bill that contains the proposals to implement the governor's budget recommendations regarding health and human services. In addressing this area of the state budget, we encourage continued planning and investment in our entire system of aging services. Specifically for the nursing homes and the residential care home rates, that would mean funding the inflationary increases that are required by statute. We therefore encourage the committee to remove sections 10 through 12, as these are the sections that would remove those statutory increases. And regarding the state-funded home care program, we appeal to the committee to consider whether the small amount of savings attributed to the increase in the cost share is worth the burden it'll place on the older adults who rely on the long-term services and supports provided through that program. Regarding Senate Bill 805, this is an act requiring nursing homes to spend not less than 80% of revenue on direct care. As proposed, this will require 80% of revenue received by a nursing home from Medicaid, Medicare, and all other payment sources to be used to pay for nursing personnel who provide hands-on care to the residents. Respectfully, Leading Age Connecticut cannot support this bill. While we highly value the work of nurses and nurses' aides, the way this bill is crafted, it is unworkable and does not acknowledge the realities of nursing home care and services. Nursing home care is highly dependent upon nurse and nurse aid services, but also upon social work, therapy, recreation, dining, and housekeeping services. In addition, the nursing home is just that, a home that provides their residents with meals, laundry, linens, hot water, and heat, and all which are expensive and must be paid for by using the revenue received from all these payer sources. Regarding the Medicaid revenue, Connecticut has a cost-based nursing home rate system that just transitioned to an acuity-based component, and the new system was designed with staffing concerns in mind. When it comes to Medicare revenue, only the short-term rehab patients receive Medicare for their nursing home stay, and the the rate that the nursing home gets for a Medicare patient must cover the cost of physical and occupational therapy, speech therapy, intensive nursing services, and all of their prescription medications. So it would be impossible to cover all these high-cost services if 80% needed to go toward direct care nursing personnel. Regarding House Bill 7189, an act concerning Medicaid cost savings, we would support this effort to review the opportunities.
Please summarize.
All right. Well, we like the idea of the nurse delegation, particularly in the nursing home and the assisted living services. And then I just want to say that on 1471, which is the pilot program at the retreat is a member of Leading Age Connecticut. We would really strongly support this concept of piloting a memory care program within one of the affordable assisted living sites. Thank you for the opportunity to provide the testimony.
Mag, you've gotten a lot of testimony in, and
There's a lot more that I wrote.
I'm sure there is. Are there comments or questions? If not, glad you were able to join us, and thank you for your testimony. And
thank you very much.
We'll chat soon. All right, Peter Doyle, followed by Don Holcomb.
I want to begin by thanking the committee for hearing my testimony. It's late, so I will be brief. My name is Peter Doyle, and I'm a volunteer with LGB Courage. I'm a Democrat and liberal, and I'm here to oppose the bill as written. I'm also a gay man with a history of gender dysphoria, so I know firsthand what it's like to be a young person distressed with their sex. As a child, I believed I was a girl, but lucky for me, the adults did not affirm me. Rather than pathologize me and medicalize me, what is a normal and common phase for children that would one day grow up to be gay or lesbian. They simply let me grow up. So I know a thing or two about what it means to be young and confused about my gender. Happy to answer questions about this. I oppose this bill because it does not account for instances where ethics and scientific evidence are in opposition to definitions of discrimination. Doctors need to be able to refuse to offer services and care that are not evidence-based. So-called gender-affirming care, including puberty blockers, hormones, and surgeries, are not evidence-based. They are not safe, effective, or supported by current science. We know that these interventions permanently sterilize children and have no long-term benefits. Practicing so-called gender-affirming care goes against the current widely held standard of care that we should use the least invasive and least permanent treatment available. Multiple doctors have already filed testimony to this effect. However, activist groups confuse this fact by promoting their own standards of care. Providers should not be forced to provide such services due to the poorly worded policy. Providers are trained to practice medicine, and we should allow them to do so based on the highest quality evidence and ethics. Accusing providers of discrimination for not providing services for which there's no evidence and demonstrated harm opens providers up for bad faith accusations, threats, and legal actions. Please protect distressed youth and revise the bill so it allows providers to uphold their oath to do no harm. Let providers practice evidence-based medicine without the threat of legal action and help gender distressed youth get appropriate care. Thank you all very much for your service.
Thank you for your testimony. Are there any comments or questions from the committee? Seeing none, have a good evening. Next and last, we have Don Holcomb. Don, just press that button. Make sure you're.
Okay, now. Thank you so much. And you're right. I'm last. I apologize, but this was so important that when my request to speak didn't take and I realized it, I drove down here and I've been waiting 6 hours just to talk about this. My name is Dawn Holcomb. I live in South Windsor and I serve as the executive director of the Connecticut Oncology Association. I was honored to serve on the Prescription Drug Task Force. Thank you very much, Senator. And I did participate in a lot of it. Unfortunately, the bill that the task force presented is missing the boat on some major significant issues. So I do need to speak about Raise Bill 7192, an act implementing recommendations of the Bipartisan Drug Task Force. There's a lot of overlap between that and Bill 11. I have a couple things to say about that. I have submitted written testimony on both, so I won't go into deep detail. But I will say, please do not pass Bill 7192 as it is presented. There are language modifications suggested for sections 1 and 2, And sections 5 through 14 related to drug importation should be completely eliminated. I can give you chapter and verse about why. And sections 15 and 16 related to drug shortages should also be implemented. What we would be better served doing is looking at Oklahoma's bill on patient choice for prescription drug fulfillment. In that are a number of the bullet points, and I have them in my testimony, some of them, that talk about how patients need to be able to make their decisions about their drugs, because that is where we're going to get crux of the problem of drug affordability. When the PBMs are wrapping the patients up and tying them up and forcing them to go to their own pharmacies with pricing that they have set, that is where you're getting the cost of drugs doubled. It's all those add-on fees. And so we really need to take a hard look at the direction that many states are starting to look at. Maybe we stop trying to nickel and dime the PBMs and shutting the door after they've already left that door and gone and opened a different window. Put it back to patient choice so we can eliminate a lot of that gamesmanship. Very quickly, section 1 in Act 6192. I approve of fiduciary responsibilities for the healthcare area, but I think we need to add to the patient as well. By putting that language in there, we can start to address with them some of the most egregious activities that are happening. They should have a fiduciary responsibility to the patients that they touch. And right now it's too distant. In section 2, the pharmacists and treating physicians both deserve equal protection under state law. All of our legislation in Connecticut talks about the impact on the pharmacy and the pharmacist. We have dispensing physicians and physicians that treat in their office. They're administrative physicians. They deserve the same protection from PBM regulations and atrocities and contract language that the pharmacists do. Drug importation. There's so much that is not going to happen with drug importation. I'll give you one example. But we've already talked about the fact
Your
Canada.
time is complete. Please summarize.
Okay. I'll stop on that. Just very quickly, I just want to add on Bill 11, the PDAB. There is not a single state that has gone down the PDAB route that has saved a single penny, despite years and years of activity for any patient. So I've given you chapter and verse about why PDABs don't make sense and why we should not be looking at that. And I will stop there. Happy to respond to any questions.
Thank you so much, Dawn, and I want to thank you. You were a member of the Bipartisan Prescription Drug Task Force, and we're very grateful for your thoughtful contributions to that task force and your testimony tonight. And sorry about the sign-up issue today, but we're glad we could hear from you anyway, and appreciate your written testimony.
I live in the drug importation world on the oncology side. Please take a look at the part of the testimony where I mentioned to you that these drugs are not intended to be sold in the United States. So the labels don't have the single number on it that is required for every single billing code for every single processing of a bill in the United States. Just think about the potential for risk and harm and error, because a new label is going to have to be attached to every single vial that comes into the United States, every single vial, or it can't be put through the billing system. That's just one of the huge risks that no consultant will tell you. They'll just say, oh, it can be handled. I've seen the danger. I've seen the hassle. Take a look at that one section, please.
Thank you. Questions, comments? Seeing none. Thank you, Don. And with that, we have reached, I think we've reached the end. I don't see anybody else here left to testify. Is there anybody else wishing to testify who has not yet spoken? If Representative Case, you're not allowed to testify on the committee you serve on. With that, this is our last public hearing that's currently scheduled of the year. We will recess momentarily. We will be in on Thursday for the purpose of JFing bills. We will see you very soon.